and letting me be a part of Pulmocon. So I'll start my first case, that is a pleural disease case, and I would like all of you to please stop me somewhere wherever you have any doubts and just give your expert opinion regarding all those things. So my case title is Pleural Effusion, Where is the Confusion? So this was a case which I presented during my DM residency in the clinical combined round at AIIMS New Delhi. So he is a 35-year-old male, he is resident of Delhi, he is a software engineer, presented to a private practitioner in August 2017 with the chief complaints of low-grade fever since 1 month, cough since 1 month. So going into the history of presenting illness, he has a history of low-grade fever which has evening rise of temperature and it was not associated with any chills and rigor. He has cough which was productive and that too with scanty greenish sputum with non-foul smelling, but there was no associated history of any hemoptysis. Again, going into the presenting illness, he has history of loss of appetite also, loss of weight also, and he was breathless with a grade of 1 mmRC. Going to other system, so he has no history of any urinary complaint, no history of any abdominal pain, no history of chest pain, and no other systemic symptoms to suggest any autoimmune history like a rash, joint pain, oral ulcers, or Raynaud's phenomena. Past history was not significant, personal history was not significant, and there was no history of TB or any similar illness in the family members. So when we did so he had undergone some baseline investigation which showed CBC.
Before investigation, from the history, what is your opinion and expert opinion, Dr. Sundar? Simple history.
Not pointing much towards pleural disease also, excepting for the fact there is a shortness of breath. Fever, so we are inclined to the most common cause of, if it is a pleural disease, tuberculosis. And then we have to keep our minds open if it could be some other causes also.
With evening rise of temperature, the tuberculosis should be the first diagnosis in our country. And next one.
Yes, sir. So as rightly said, a 35-year-old male, when he comes to us with a history of fever, when he comes to history with a cough, with a history of weight loss, loss of appetite, the first diagnosis that comes to our mind in our country is gonna be tuberculosis.
Is that is sporadic chest pain?
No, sir. There was no history of any chest pain as
That
such.
was against.
Yes, sir. So only a history of. So I will show you later on that this patient didn't had pleural effusion in the first beginning also. So that will come with our X-ray and all the investigations. So the routine investigation which any practitioner does for a patient who comes to him with all these symptoms is a CBC, which was done, which was normal. Again, sputum testing was done. So sputum showed no evidence of any gram stain, no evidence of AFB, no evidence of any culture. Urine examination was done also for the evaluation of fever, was negative. Chest X-ray was done, CT was done, which I will show you in next few slides. Montux is a very common test to ask for in our country whenever a young patient comes to us with history of fever and cough. So Montux was done, it was also negative. Somebody thought of sarcoid also in the beginning, that private practitioner, and he got a ACE also. So ACE was also normal. So this was the X-ray of the patient, first X-ray. So this X-ray showed that there was probably some hilar enlargement and there was a paratracheal enlargement. But surprisingly, both the CP angles were clear. So this patient didn't had any pleural disease to begin with. CT was, yes sir.
In the X-ray, paratracheal lymph node, it may be the sternal.
Yes.
Yeah, due to rotation. Dr. Bhuiya, what is
No, I think as Dr. Pauja rightly pointed out, means the CP angles are clear, I think. So obviously, mediastinal lymphadenopathy, I think sarcoid, bilateral lymphadenopathy, sarcoid will be the first thought which will come to our mind,
yes, sir.
with also paratracheal lymphadenopathy. Young patient, I think
It is
no other significant finding.
no, in Mantoux test, what is the significance of Mantoux test in this case?
Yes, sir.
Continue.
So with a significant lymphadenopathy which is looking apparent on an X-ray, bilateral, symmetrical, with no effusions, with Montux negative, again sarcoid becomes a consideration, and already ACE was done on, although we know that there is no significant role of ACE in diagnosing sarcoid. So the patient underwent a CT, and can anyone point out the opacities which are apparent on CT, although it's a bidirectional cut? So there was a big paratracheal lymph node which was apparent on this scan of CT. There were prevascular lymph nodes also. Then subcarinal lymph nodes were also there, and there was a segmental collapse of the right middle lobe, probably due to the lymph node which was compressing on the bronchus. So at least we were sure enough that this patient had a mediastinal lymphadenopathy to begin with some symptoms of fever, cough, weight loss, loss of appetite. Montaux was negative, ACE was also negative. So this is again the lymph node which I am showing you. So it was reported outside to be a query, a necrotic node also, with due to the high intensity changes which was shown on the CT scan picture. This was the parenchyma. Parenchyma did not show us any opacity to suggest either a tuberculosis or to suggest either a sarcoidosis, like we see perilymphocytic cuffing in their sarcoid, some nodules are there. In case of TB, we see centrilobular nodules, stream bud pattern. So there was nothing apparent on a parenchyma in the present scan or in the first scan. So it was an isolated mediastinal lymphadenopathy with some constitutional symptoms.
Mediastinal lymphadenopathy has some necrosis.
Yes, sir, with some
And
necrosis.
that probably rules out sarcoidosis and.
So again, if you have necrosis, it becomes more of tuberculosis rather than sarcoidosis. But it is there 10 to 20% case of sarcoid can also have necrotic lymph nodes. So there was again a clinical dilemma which all of us day-to-day practice face between tuberculosis and sarcoidosis. So what should be done next? An expert opinion on this. With this kind of a presentation, you have a CT, you have an X-ray showing necrotic mediastinal lymph nodes, Montaux negative, ACE negative. What should be done?
Always tissue or microbiological diagnosis. Always option D. Always go for diagnosis.
Tissue or microbiological diagnosis. Yes. So this is not an era of empiricism where we can start a patient on ATT, where we can start a patient directly on steroids, suggesting that this can be tubercular or sarcoid, or the combination of both also is given commonly in day-to-day practice. This is an era where we are practicing evidence-based medicine, so a tissue or a microbiological diagnosis should be achieved first, then only the patient should be started on any therapy. But this I am talking about 6 years ago, when we didn't have that good sarcoid guideline which came in 2020. So the patient was started directly on anti-tubercular therapy in view of necrotic lymph nodes and radiologists giving a possibility of tuberculosis first, followed by sarcoidosis. So the patient was started on anti-tubercular therapy. He had some reaction to that therapy. Again, it was found that the Z was the drug which was causing reaction, so therapy was changed to HRE levo. He received it for a period of 1 month. There was no improvement in symptoms. In fact, there was 2 kg weight loss. So he went and got consulted with another practitioner, and he underwent an endobronchial ultrasound. Now the endobronchial ultrasound was done. All the tubercular workup, microbiological, AFB, gene expert culture, all were negative. Cytology was inconclusive, but the core biopsy which was taken from those lymph nodes showed, one lymph node showed epithelioid cell granuloma without necrosis. The second showed some focal necrosis. The paratracheal node, which was apparent on CT also that it has some necrosis, also showed in the biopsy that there was granulomas with focal necrosis. BAL was done, although they had the facility of getting a CD4 by CD8 also. So it showed that CD4 by CD8 ratio is raised. They attempted a transbronchial lung biopsy also, despite the parenchyma was not showing any infiltrate, because as our latest guidelines are clear that in a sarcoid patient, multimodality approach should be done, not just a BAL or an EBUS. In fact, an endobronchial biopsy as well as a transbronchial lung biopsy should be done whenever you are dealing or suspecting a case of sarcoid to be there. So it also showed epithelioid cell granuloma without caseous necrosis. Endobronchial biopsies, no granuloma was seen. So now what should be done? Should his ATT be stopped? Should he directly be switched to steroids? Or should both be continued, because ATT has already been going on for 1 month?
Was tissue culture also sent for tuberculosis?
Yes, sir. MG80 was negative.
Without, I mean, you don't have a parenchymal lesion,
Yes,
but
sir.
transbronchial biopsy is showing epithelioid granuloma.
Yes, sir.
Not common with tuberculosis. It's not common with tuberculosis.
Okay, sir.
So we are inclined towards sarcoidosis.
So now this is a quite common situation. A patient comes to you, you diagnose him to be query sarcoid, or suppose with this biopsy we say he's sarcoid only, but he's already been receiving 1 month of ATT. So what should be done? Should we stop that ATT directly up front? Should we now continue it for 6 months? Because this is a dilemma which we face day to day in our practice.
We have evaluated other organs also. I mean, liver, no granuloma, eye, no changes, urinary calcium, negative. We have done all the, we should have done all the parameters for
Yes, sir.
extrapulmonary features for sarcoidosis.
No,
But no point in giving anti-tubercular drugs actually.
so basically the patient should be shifted to steroids directly and ATT should be stopped. But again,
I have a case, similar case,
Yes, sir.
and it was ultimately found to be histoplasma.
okay.
So fungal disease should be considered in
Considered.
this case. And I follow the principle, unless you proved other diagnosis. If AT drug started, then AT drug should be continued.
Okay.
Otherwise, after investigation, if you get it is a tuberculosis, then
But as
there
of
will be
now-
confusion. So unless second confirmed diagnosis is reached, I think the AT drug, there is no need to stop AT drug.
Stop it. So basically,
And should steroids be given or not? Because he doesn't have any definitive indication for
Steroids
steroids.
should not be given.
Should not be given.
Should not be given.
but in this situation where we have tuberculosis negative, where we have epithelial cell granuloma without any necrosis, symmetrical lymph nodes, which are could be sarcoid only. So why should not we consider a steroid? Yes, sir. But he is symptomatic. He is symptomatic patient, although with stage 1, but he is symptomatic, and then TBLB showing epithelial cell granuloma would make it actually a stage 2. Because then it suggests there is some parenchymal involvement, although it's not apparent on a CT.
Now,
So maybe a stage
necrosis has been seen in the CT, and from the site of biopsy, you may not get the causation
Okay.
in some cases.
One more thing, that as sir rightly told that anti-TB treatment should be stopped. We should stop the treatment if we will give the combined therapy, and rifampicin will not allow the steroid to work. So again you will be in the confusion. Even after steroid, your
What
patient
worked
will not
actually or what did not work for this patient.
Yes. So
Exactly, sir. So my opinion also on this thing is same, that we should be on a forefront to tell that we can stop ATT. It's not like we have given it for 1 month, so it should be continued for 6 months, and steroid should be given that for 6 months. So the answer should have been actually start steroids if we are labeling this case as to be sarcoid, and that too maybe stage 2 with symptoms. But what happened with the patient, the ATT was continued for 6 months. Steroid was started along with ATT, which is a common thing in practice, started with 40 milligram of prednisolone. Over the next 6 months, the steroids got tapered, and by March 2018, both the steroids and both the antitubercular therapy were stopped. Now come to the follow-up radiology. So follow-up radiology in Feb was more or less showing the same X-ray as we have in the first beginning. Both the hilar were predominant, the paratracheal was also there. Till now, there was no pleural disease. And you guys must be wondering that if I am talking on pleural disease, where is the pleural effusion? So here comes the pleural effusion in April 2018 X-ray. So in the April 2018 X-ray, as we can see, slight blunting of right CP angle is there. So this patient who has received an antitubercular therapy, this patient who has received a steroid therapy for 6 months, after stopping both the therapy, comes to you 1 month later with again some and with a right-sided pleural effusion. Yes, sir. Yes, sir.
Was there any evidence of nephropathy in any other system, abdominal or peripheral?
No, sir. Because the patient, when he came to us in July 2018, after this effusion came into the picture. He had only CT chest available as well as X-rays available, on the basis of which he was given antitubercular therapy as well as steroids. So till that time, there was no extra pulmonary evaluation done for the patient. Only they focused that this patient is most likely having a pulmonary and a mediastinal issue, and he was being dealt as that only, rather than searching like doing an ultrasound abdomen or all those things.
Those are not looked for. Those were not looked for.
No,
I mean,
not looked for, sir.
abdominal lymphadenopathy,
No, sir.
but should have been so.
Exactly, sir.
Should have.
Patient with mediastinal lymphadenopathy, I think lymphoma is one of the differential
Consideration.
So we have to look for it
Definitely, sir.
in other systems also.
So this is
Now,
all.
audience may have some question and they can contribute with the discussion.
Hodgkin, I mean, Hodgkin can occur. Hodgkin can occur.
Is not possible, yes, sir. We should and now especially after stopping steroid, because sometimes lymphoma also responds to steroid, we have seen that thing. So even if a lymphoma patient is there, he might also show some response to steroids also. And then this now new pleural effusion which has come up, this has now again complicated all the issues.
And you can
So-
get even granuloma in biopsy specimens of lymphoma.
Definitely,
So
sir.
let us keep our spectrum wide also.
Spectrum
Granuloma
wide.
does not always only means TB or sarcoid.
So now,
Pure intrathoracic lymphoma is usually non-Hodgkin and it should have some symptoms.
It should.
Okay.
This must be an atypical case, so you
Yes,
are
sir.
showing it.
so now this was the CT which was done after that X-ray, and CT showed clearly that there is a right-sided pleural effusion and that paratracheal lymph node was also sitting there, although it has reduced as compared to the previous scan, as per the scan report. But yes, this effusion was a new finding which has come up in this patient. So the
What was the duration of steroids? I'm just interrupting.
6 months, sir.
6 months.
6 months steroid, 6 months ATT, both stopped together in March 2018, and this is
In
April
April.
2018. After 1 month of stopping both these things, that effusion is a new finding.
The disease process was continuing, it was masked by steroids.
And patient responded to those steroids as well as to that clinically. Although we can't say it radiologically, because radiologically there is a worsening. This atelectasis was still there. The effusion was still there. The effusion came as a new finding. And when the parenchymal window was seen, or the lung window was seen, it showed that there are now perilymphocytic and some nodularity which has come up, which is a new finding. Nodules has come up, which was not there in the first scan, which the patient underwent in 2017. So reduced size of nodes is one finding, new pleural effusion is another finding, and new perilymphatic nodules is another finding. So what should be done next now? Should we again start steroid? Should we again start ATT? Should we start both because he has responded, but we don't know to what thing? Or should we again target a tissue or microbiological diagnosis?
Investigate. No point in giving
Your
steroids.
opinion?
What I think that probably we have not treated sarcoid adequately in this patient. We have given, as I told earlier, that rifampicin you are giving steroid, your steroid will not work. So this patient, though he has received steroids, but probably they have not worked because of the accompanied rifampicin. This is my version in this case.
In sarcoid also, yes sir.
It is rare, but happens in 5% of the patients.
So again the same practitioner who
And
did
if
the
you give
EBUS.
rifampicin with steroids, steroid dose has to be doubled.
Yes.
That wasn't done.
So again that practitioner who did his EBUS again investigated him for his pleural effusion. Pleural effusion came out to be exudative, it was lymphocytic, ADA was low, and all the microbiological workup like AFB gene expert, culture, fungal, cytology, everything came out to be inconclusive. So as expected with an Indian patient who has taken 6 months steroid, 6 months ATT, now not having an answer, what he decided why not go to an Ayurvedic practitioner to get it resolved, because allopathy is not working for me. So he went to an Ayurvedic practitioner, took the therapy for 3 months, had persistent loss of appetite, persistent fever, persistent dry cough. He thought why not go to an Apex center. So then this is the first time when he came to AIMS in July 2018 to get himself evaluated, because he was fed up of all the therapies whatever have been given to us. So on presentation to us, he had fever, he had weight loss, he had cough. On systemic examination, we found that he had findings to suggest a right-sided pleural effusion, and now you can see in the X-ray, the effusion has actually increased over the past 3 months. So again, as expected, we did a routine repeat examination of his pleural fluid. Pleural fluid again showed exudative, lymphocytic with a low ADA. So pathology review of the first EBUS which was done outside was done here. So in that, the report was something like this: granulomatous lesion of the lung, again sarcoid versus TB. So the pathologists did not help us at all. They gave us those two common diagnoses which are there. We were expecting they might give us something about lymphoma or something like that, but again they gave us more possibly sarcoid rather than tubercular because of the presence of non-necrotic epithelial cell granulomas in the EBUS report. So we had a clinical dilemma. A 35-year-old male responded to maybe ATT, maybe steroids, now came with a new pleural effusion. So what are the diagnostic possibilities here? And as the house suggested that there are these 2 or 3 common possibilities, maybe a tuberculosis, maybe sarcoidosis, and not to forget lymphoma should also be kept in the consideration loop, although this was an atypical presentation for lymphoma, but it should be kept. So what are the points which are favoring tuberculosis? A necrosis in the paratracheal lymph node on the histopathology and the presence of a pleural effusion. But the points against are Montauk's negative, stain and culture every time negative, even in pleural fluid, even in EBUS sample, and there was no radiological improvement despite patient taking 6 months ATT. So can it be drug resistant tuberculosis? Because we all know EBUS sample and pleural fluid samples are relatively less yielding as far as the microbiology workup of a TB is considered. Can it be sarcoid? As Sarah suggested, response to steroid was there, and now there is a parenchymal involvement which is more looking in favor of sarcoid, but again pleural effusion is rare in sarcoid, and there was a radiological worsening despite being treated with steroids. Then comes lymphoma. Presence of pleural effusion and lymphadenopathy in a young male can be a consideration for lymphoma, but again cytology is negative. And we also know that cytology in pleural fluid is not very sufficient, and EBUS per se is not a sufficient test to rule out that this patient is not having any lymphoma. So all the ancillary tests for sarcoid and TB were done, Montauk's was done, urine calcium, serum ACE, ECG, even ophthalm evaluation, everything did not give us any clue whether we are dealing with a patient of sarcoid or whether we are dealing with a patient of tuberculosis. So as expected, we have decided why not do a repeat sampling or a tissue sampling in this case. So EBUS was done in this patient, as well as semi-rigid thoracoscopy was done in this patient to look for the cause of pleural effusion. So on thoracoscopy, we could find that there are some small nodules which are present on the parietal pleura. So from those nodules, a biopsy was taken, and the biopsy was sent for pathological evaluation. Now the pathology review of the pleural biopsy showed us very beautiful non-necrotizing epithelioid cell granulomas with no necrosis. All the workup of TB like staining, culture, gene expert from the EBUS lymph node as well as from the pleural biopsy samples came out to be negative. Even the AFB stain was also negative. So we made a final diagnosis that this patient is actually suffering from sarcoid with pleuropulmonary and maybe a lymph node involvement also. And now comes the next question, what should be done? Should he start steroids? Although we know that tuberculosis, to start ATT is not justified in this patient because everything came out to be negative. So should we just start steroids? Should we start steroids with ATT? Or should we start steroids with methotrexate because now we are suspecting that it is a relapse of sarcoid or an inadequately treated sarcoid?
Only steroids.
So this is the follow-up X-ray. The patient was started on only steroids without an ATT. Follow-up X-ray showed complete resolution of pleural effusion within the next 3 months. Even the USG thorax done after 4 months showed that the effusion has responded. The patient received steroids for around a period of 2 years, and then after that he is just on a follow-up with the serial radiology, which showed that the patient is not having any effusion. So just briefly 2 or 3 slides for review of literature. So in sarcoid, although it is rare to have pleural effusion, but it is not like that the sarcoid patient can't develop a pleural effusion. Although the effusion whatever develops in sarcoid are small or modest in size, right-sided are more common. Exudative, lymphocytic and low ADA picture again suggest you should think about sarcoid also. And the definitive diagnosis of a sarcoid pleural effusion will only be made when you have a non-necrotizing granuloma and, as sir rightly suggested, exclusion of granulomatous disease of all the known etiologies, maybe histoplasma, maybe TB, maybe lymphoma, everything needs to be ruled out. Then only you can say that this patient is most likely suffering from sarcoid. If you see the organ of involvement, there is no mention about pleura being involved in sarcoid because it is a rare organ to be involved. The incidence range is somewhere from 0.7 to 1% only. It is unclear why there is less pleural involvement in case of sarcoid. Some say that there is a protective mechanism which inhibits pleural fluid formation, and some says that pleural pathologies, we don't have sensitive modalities to check for whether sarcoid does have it or not. But again, if you start looking for sarcoid in pleura, you will find out some or other cases of sarcoid having pleural involvement also. What are the types? They can be thickening in the pleural space, they can be nodules, there can be effusion, even pneumothorax, chylothorax has also been reported with sarcoid as far as the pleural involvement is considered. If you do the medical thoracoscopy of these patients, you will see nodularities can be there, adhesions can be there, hyperemias of the parietal pleural space can be there. And as sir very rightly suggested, why these kind of patient doesn't respond, because usually these patients are given ATT along with steroids, and there is a very specific thing which antitubercular medicine like rifampicin causes to steroid. They reduce the effect of these steroids. So whenever these patients are given concomitantly steroids along with an antitubercular therapy, the effect of steroid goes down, and as soon as you stop steroids in them, these patients come out to you with a relapse of sarcoid. So the take home message is, although it is uncommon, but we should be looking for it whenever we have a case of pleural effusion presenting to us with exudative, lymphocytic and a low ADA picture, and especially when some parenchymal or a mediastinal lymph node involvement suggests that this can be sarcoid. And usually whenever we are treating these patients, we should keep in mind that we are giving them a good dose of steroid, and a steroid should not be going ahead with the medication which reduces the effect of steroids. So that will be all from my side.
Thank you.
Thank you.
If there are any questions.
Thank you for giving a very good case. I have a similar case that was diagnosed as sarcoidosis, and he was diagnosed at Delhi, and 5-year follow-up, there was no symptoms. And after that, he came to Kolkata and then developed right-sided pleural effusion. I started antitubercular drug, and his relative, a doctor himself, asked me why you are giving AT drug. I told him that you may have a second opinion, but I think it is tuberculosis. And after that, patient develops liver abscess, and from that, AFB was isolated. And this is so the main problem here is that dual therapy. Dual therapy should not be done. And tuberculosis cannot be a dustbin diagnosis. You have to confirm it, or if you give, there is no question of trial AT drug. If you give AT drug, then stick on that. It is a clinically diagnosed tuberculosis. And in those cases, you cannot combine AT drug with steroid. That is the message of the case. Thank you again, Saurabh, for giving us a very nice case. Now I call upon our next speaker, Dr. Shelly Samin, one case. One case. After that, if we get time, then we can allow it. Huh? Clinically. Clinically. No.
Actually, I have formulated
not
2 or 3
given
cases,
steroid.
just diagnostic part. So these are not elaborated case. We can, Supriya, we can go through because the cases are not that elongated.
আচ্ছা ঠিক আছে তোমার বেল বাজলে থামবে
Eosinophilic lung diseases are rather rare entities, so we should have a strong suspicion and also an approach in our mind to clinch the diagnosis. So that's why I have formulated this 2 or 3 cases in different aspects of eosinophilic lung disease. So I'm starting with, these are actually common presentation rather, though not that uncommon or busier presentation. A 40 years male without any comorbidity came with dry cough for last 3 months, prominent at night, low grade fever, malaise was also there for 2 months with some amount of weight loss. On clinical examination, wheezing was found with scattered crackles. So any patient coming to these symptoms, definitely we will go for radiology. So X-ray was done, not that much contributory, might have some reticular opacities or maybe normal. However, as there was dry cough for last 3 months and low grade fever, had a suspicion of miliary tuberculosis, we did this CT scan also. It suggests some amount of nodularities, fine nodularities are there with some central lobular ground glass opacities also. Routine tests were asked for, complete blood count definitely revealed some high eosinophil count. Eosinophil was 50%. If you see the absolute eosinophil count, it is more than I think 6,000 or 7,000 like that. Other blood parameters were normal. The urea creatinine, LFT were normal. Sputum was also seen and came to be negative for tuberculosis. When to suspect eosinophilic pneumonia? Whether only কিছু discussion? No.
তাড়াতাড়ি তোমার যতটা সময় আছে তোমার মধ্যে যা খুশি করো will not interfere with you.
Okay.
No, but this appears as a case of tropical pulmonary eosinophilia.
Right.
I mean, you showed miliary shadows, you said wheezing, so it's tropical pulmonary eosinophilia.
Simple,
This is
frequently see.
this
as
appears to be the
picture.
first diagnosis.
Now,
Why crackles? You got wheezing and crackles. How do you explain crackles in pulmonary eosinophilia? What is the mechanism of crackles?
it was seen, but I don't think it has much to discuss.
Okay.
Now go to the investigation.
The eosinophil counts, if there is high eosinophil counts with any pulmonary infiltrate, not in this case, but for others also, we should go for other entities like other organ involvement. So history of any drug intake should also be taken that can cause eosinophilic pneumonia. We have huge list in pneumotox.com. No prominent GI symptom, no neurodeficit, no skin rash, no dual or purpuric lesions was seen. Echo was normal. I think this is the routine test or routine evaluation that you should do whenever you suspect any eosinophilic pneumonias. Urine RE was also normal. Stool OPC was also done and it was normal. So I think these are the routine tests that we should do if we suspect any case of eosinophilic pneumonia with the peripheral eosinophil count is high along with any pulmonary infiltrate. Should we go for BAL in this patient? No. So in current scenario, it is better to go for BAL in spite of peripheral eosinophilia to at least it can give whether and tuberculosis is there or not, if possible transbronchial biopsy can also be taken and also it can actually confirm the eosinophilic pneumonia by BAL eosinophilia. If it is more than 30%, here it was 60%, And that indicates, confirms that it is really eosinophilic pneumonia, and with the typical CT picture, TPE comes to our mind. So we did.
My question is, suppose you had this one serum Ig positive for microfilaria.
Right.
Before BAL, will you
Then-
like to go for the BAL?
Exactly.
After that?
I think it's not that required,
Consistent clinical.
because
The clinical picture is consistent with
Consistent.
TPE, so you should do an IgE, do a microfilaria test. BAL is definitely indicated if you are suspecting eosinophilic pneumonia, acute eosinophilic
Other
pneumonia,
eosinophilic pneumonia.
chronic eosinophilic pneumonia. Yes, you have to go for BAL eosinophil count.
right.
But actually, if you look at BAL, it can still be negative. I mean, so actually for eosinophilic pneumonia, you need to establish that there is tissue invasion by eosinophils. So you need biopsies because biopsies can be false negative.
But biopsy is not any
No, no,
diagnostic
I mean,
criteria.
transbronchial is fine for eosinophilic because
Right.
they are bronchocentric involvement.
So
I mean, that's the.
tropical eosinophilia has some diagnostic criteria that doesn't need examination. But for diagnosis of eosinophilic pneumonia, biopsy is necessary.
Right.
Tissue involvement is necessary.
Not always necessary, I think.
No,
Is diagnosed as per the UCD criteria.
If you get it in BAL, it's fine. But most cases of acute eosinophilic pneumonia, the BAL will be negative.
In acute eosinophilic pneumonia.
Even in acute.
Do you
Don't
agree?
get peripheral eosinophilia in many cases.
In acute eosinophilic, definitely we will not find any peripheral eosinophilia.
But
But
BAL
BAL
can be negative.
Okay, continue.
Anyway.
So it was tropical pulmonary eosinophilic. So that's just how we should proceed. Eosinophilic pneumonia, if we find extrapulmonary manifestations should be assessed, and also any known cause triggers should be assessed, like drugs or any parasitic involvement. Accordingly, we can classify. I will not go to that detail. The drugs that can produce eosinophilic pneumonia.
Go to your second case, actually, discussion is not.
So 45-year male with diagnosed asthma for last 8 years was on ICS-LAVA high dose, still remains symptomatic and requires OCS 2 times in last 1 year. Developed increased shortness of breath and cough for few weeks with low-grade fever and malaise and arthralgia. Also had hyposthesia and weakness in hands, more in left side, and couldn't hold objects with left hand, and left-sided wrist drop developed for last 2 weeks. Again, X-ray was done. Some infiltration you can appreciate, and mainly in the left upper zones, mid zones, also bilateral, I think. In CT scan, peripheral based multiple ground glass and some areas consolidation-like lesions were seen. Again, routine test came out to be high peripheral eosinophilia. 65% eosinophil was there among 27,000, so more than 7,000, I think. Others were normal, renal function, LFT slightly altered, STLT slightly altered, otherwise normal. Sputum A B negative, gene expert MTV again negative. So no specific drug history except use of Montelukast as part of treatment of asthma. It was continued. No skin rash, no GI symptoms. However, echo revealed there was eosin fraction is really low, 35%. No regional, almost an abnormality. Urine RE was also normal. Stool OPC was normal. BAL was done. TB excluded. No parasite. The importance of doing BAL is sometimes in eosinophilic pneumonia, you may find parasites also, larval form of parasites also. It was also
No
not
expert comment
seen.
regarding diagnosis?
This
from
is
my
where you
side?
need a tissue diagnosis. In this case, you need a tissue diagnosis to see that there is infiltration, extravascular infiltration by eosinophils, because you are tentatively making a diagnosis of EGPA.
So whether tissue diagnosis from lung is that easy in EGPA?
No, you should go for a transbronchial biopsy and see. You can do it.
It is not
Or,
difficult.
or more, you can do it from the sural nerve, I mean from the nerve biopsy. That is more delayed. Biopsy from other side, especially sural nerve biopsy.
Nerve biopsy whether easily done. I have not actually. So can it be EGPA?
Skin, there is no lesion. Skin.
Though there was a skin biopsy.
There is
skin
no
lesion.
lesion in this.
It was easier, becomes easier if there is purpuric glass lesions are there. Not biopsy, it is very difficult to do, at least in Kolkata, I find.
It is usually sural nerve biopsy.
What was the, I mean, obviously we'll show, what was the MPO PR3?
It was okay. Positive. I mean, so that was the diagnosis. Can it be EGPA? Can it be primary eosinophilic? Primary
Hypereosinophilic syndrome is a very severe condition, and the diagnostic criteria one is the death within this year period. So probably we should not consider
I think
it
you
yet.
need immune markers, I mean, to decide about primary hypereosinophilic.
Karyotyping and also
Exactly, that
molecular
plus
genetics
CD
to diagnose.
markers as well.
Right. More goes in favor of EGP rather than hypereosinophilic syndrome in this case scenario. Pianka was positive, MPO was also high. EMG NC was suggestive of mononeuritis multiplex. Cardiac MRI was suggestive of myocarditis with delayed enhancement. That was quite suggestive of eosinophilic myocarditis, although biopsy could not be done.
What's the specificity and sensitivity of Pianka, I mean, MPO?
Sensitivity is not that high. Sensitivity is not that high.
What's the rate of false positives? Because as you see in Wagner's or GPA, I mean, we can see
There is
lung lesion, PR3 positive, yes, you don't need a biopsy. But here, I think, what's the sort of?
there is chance of false positivity, but if you have other clinical features which are suggestive of EGPA along with positive Pianka and MPO, then unlikely that it is
I think
other
what the literature says.
This Cotin-Codier diagnostic criteria. ACR criteria suggests that biopsy is essential.
Yeah.
But there is another Cotin-Codier diagnostic criteria actually suggests that if there is asthma, peripheral blood eosinophilia or bowel eosinophilia, along with typical extrapulmonary clinical manifestation like mononeuritis multiplex, cardiomyopathy, confidently attributed to eosinophilic disorder as we have seen in MRI, cardiac MRI or palpable purpura. If any of these three are present, along with evidence of peripheral eosinophilia or bowel eosinophilia, then you can clinch that diagnosis is EGPA without biopsy. Or if the extrapulmonary involvement is not that typical, then we need biopsy or ANCA. So that's their criteria. But ACR criteria, I agree. They are saying that biopsy to have
This is
evidence
called
of vascular
pulmonary
disease.
eosinophilia with lung infiltrate. Pulmonary eosinophilia with lung infiltrate,
Like
with mononeuritis multiplex, with cardiac
or
involvement,
typical
and
cardiac
everything suggests clinically. But confirmation should be by biopsy.
Sometimes it becomes difficult to have biopsy also. That's why the question. Right. Right. That's 40%. If typical clinical background, if ANCA comes positive,
Coffee? Black tea.
right. No need for biopsy.
Coffee.
চাটা হচ্ছে চিনি ছাড়া
Very difficult.
চা চা খাই
I mean, you can do biopsy from extrapulmonary sites as well. See, there's a purpura.
If purpura is there, it is easy to do biopsy.
From the nerves, from the peripheral nerves, a pseudo nerve biopsy.
Okay, go to your
Okay.
third case.
Sure.
No, but how did you treat him? How did you treat him?
Pardon?
How did you
How we
treat
treat
him? I
him?
mean, did you add azathioprine from the beginning or immunosuppression? Because there is so much of heart involvement. Only steroids or steroids with immunosuppression?
There is 5-point prognostic criteria is there. If 5-point prognostic criteria fulfills, then definitely we will add immunosuppression along with steroid. As there is significant heart involvement, better to
No, how was this case treated? That's what we want to know.
steroid along with cyclosporine.
Steroids along with cyclophosphamide.
Then my third case, a 55-year-old male with cough, dyspnea, fever and pulmonary infiltrate. Cough and mucoid sputum was there for 8 months. There was shortness of breath and wheeze for 5 months, partly relieved by oral or inhaled bronchodilator and steroids. Fever was intermittent, sometimes with night sweats. Weakness, anorexia was there. Weight loss was there also. Patient was ex-smoker, no history of diabetes, hypertension or previous asthma. Prescribed ATD
না ও বললো তিনটে
elsewhere based on chest x-rays.
আমি একটাই বলেছি
Looked ill and toxic on admission. So this was the chest x-ray, pulmonary infiltrate we can see. Previous chest x-ray we had, you can see in 2003 there was right upper zone opacities, then some middle zone opacities are appearing in 2004 January, then the bilateral opacities in April, and in on presentation the left side opacity is predominant. So these opacities are fleeting, I would say, going and again appearing in some other areas. It was there in serial x-rays. Had also lab parameters available from past, and eosinophil count on presentation was not that high. Total eosinophil, absolute eosinophil count was hardly 903. However, in 2003 it was more than 1500, 1568. On presentation it was not that high. Other blood parameters were quite normal. Sputum was also normal. At that time GeneXpert was not available, so only sputum was done. This was the CT scan at the time. Peripheral based consolidation we can appreciate. Bilateral, mainly subpleural. So with that,
I think Soren should. Soren, what is your opinion at this stage?
oh, not included. No, lymph node was there at least.
Soren, what is your opinion?
With the given history and this CT scan, I think ABPA is the first thing which comes to my mind, because I think there are some dilated bronchus with some mucus impaction is there on the periphery. Given the history background with this CT, I think I will go for ABPA.
So
first.
ABPA was also in differential diagnosis at least. But however,
no
patient didn't
peripheral-
have any past history of asthma. That was one striking point. There was no past history of asthma. There was wheezing only for last 3 or 4 months. With all the symptoms are for last 8 months. There was no past history of asthma.
And there is no peripheral eosinophilia.
Peripheral eosinophilia.
It was there, but not much. Not
1 year
high.
back, it was there more than 1500, but currently it was 900.
Now, what is your first diagnosis? Your opinion. What is your opinion?
I'm coming.
I'm coming.
I know about the case.
Okay, okay.
No. He knows the diagnosis, so it will be difficult for him at this stage to give it.
Okay, continue.
Okay. So, total IG. Total IG was, I don't think it was given.
IG was done or not?
It was done, not high, 240. I'll come to that point.
Yes, yes.
So we had actually, the thought process was same.
As he is
ABPA was
presenting three
definitely,
cases, we cannot discuss in detail. And so let him continue.
so patient was started with the antibiotics because there was consolidation, but however didn't improve. And we had the same DD, ABPA was in our mind. However, as there was waxing, waning, opacities, peripheral based consolidation, so chronic eosinophilic pneumonia was also in mind, cough or book, and even malignancy. However, as the opacities were waxing, waning, unlikely to be malignancy. If you can exclude the infective cause, then these things, if there is consolidation, will come to our mind. So fiber optic bronchoscopy was done. Bowel fluid revealed that eosinophil count is more than 25%, confirming that it is eosinophilic pneumonia. Malignant cell, fungal cell, no parasite. CT guided FNAC was also done at that time. to clinch whether there is other pathology or not. Only eosinophil with charcot-laden crystal was found, others were negative, even TB was negative. Further workup, no drug exposure related to eosinophilia, history was taken, no neurodeficit, no other systemic involvement, no GI symptom typical, no skin rash. Total IG was rather not that high, and IG specific for aspergillus came negative. ANCA panel was also negative, PFT mild restrictive change, echo was normal.
Okay,
Comments. So with that, basically idiopathic chronic eosinophilic pneumonia was diagnosed. There is waxing, waning opacities in lung with BAL eosinophil count more than 25%, indicating that eosinophilic pneumonia is there, and typical and without any systemic involvement, without any drugs exposure, clinch that probably we are dealing with idiopathic chronic eosinophilic pneumonia. The symptoms are more than 1 month, that is also important. In acute, the symptoms is less than 1 month. If symptoms persist for more than 1 month, we will consider chronic eosinophilic pneumonia.
whether the radiology is consistent with the chronic eosinophilic pneumonia?
Radiologist.
The radiology, picture is
radiology.
consistent with that diagnosis?
To some extent, but not typically,
It looks smaller, and there was no pleural effusion.
No problem was there.
Right. I think what I would have done, I mean, during the bronchoscopy, I would have also taken a transbronchial biopsy. I mean, that's my.
It was
the
not
reason
done.
is because I don't know what the valve will show when I'm doing the.
Right.
I can't do bronchoscopy again because that would have clearly shown you, established the diagnosis, and if there was organized pneumonia, which can behave in this way.
But unlikely to have BAL eosinophilia more than 25%.
No, but when you are doing the bronchoscopy, you don't know what
Right,
the valve
right,
will show.
right. It was not that popular at least. It was there.
You have to order specifically with the pathology, especially if you are looking for a BAL eosinophil count. Yes.
Dr. Gupta, what is your opinion, sir?
Because you can say that by exclusion, probably we are close to the
By
chronic
exclusion.
eosinophilic pneumonia.
Because the feature doesn't favor ABPA. Your immunological panel by the criteria, by the
Didn't
present
met-
criteria, it
didn't
is
met.
not fitting with ABPA.
Right.
Eosinophilic pneumonia, CEP, has wide variety of radiological manifestations. So ultimately we are left with how did he respond to steroids. So must have given steroids.
It responded
Yes,
very well with steroids.
Yes, proceed.
After giving steroid, what is the radiology? That is very important.
It cleared. I actually didn't incorporate because therapeutic part I have omitted.
It is totally cleared.
More or less, it improved dramatically.
And Shelley, in the differential of a migratory opacities like this, actually bronchoalveolar carcinoma, now called is adenocarcinoma with
Right.
lipidic pattern, that comes into the differential as well.
So I kept that in my
Yes.
differential diagnosis.
That is also, I mean,
But it should be progressive. Here, the shadows have disappeared. It disappeared.
it can migrate. I don't know, I mean, what's the mechanism, but
Lipidic spread. The mechanism is lipidic spread.
So one striking is chronic eosinophilic pneumonia. In this case, usually more than 1,000, usually very high peripheral eosinophil count. But here we had eosinophil count not that high. So sometimes the cases may not be typical form. So that's it. So acute eosinophilic pneumonia, can it be acute eosinophilic?
No.
Unlikely
It
because
is like an
duration
ARDS.
duration-
Yes, it's an acute fulminant.
the dense consolidations, they look like acute, but some of the look
Other
like
features didn't know because symptoms are there for more than 1 month.
Yeah.
And usually acute eosinophilic pneumonia present with respiratory failure, and so that's why it's not acute eosinophilic pneumonia. So diagnostic criteria, I'm not going into detail. Should we continue?
No,
or
no,
complete?
no.
Complete.
3 cases. Okay.
Pardon?
follow-up
It
check-
improved rather. I haven't
Improved.
incorporated.
He
With
said
steroid dose.
it is improved totally or subtotally.
Near comprehensive.
So thanks Dr. Seli Samin for presenting 3 cases of pulmonary eosinophilia, and except the last one, first 2 are classical and the third one there is confusion somewhat, because the chronic eosinophilic pneumonia is negative bat swing shadow is the most important thing, and the radiologically it appears to be AVPA. Now I invite Dr. Raghav Rao G, and he will discuss about the granulomatous lung disease. Okay, sir, continue. And biota slide.
That's fine. That's fine.
He is a MD, DM. আবার চলে গেল কেন রে ভাই?
I did my study from PJ Chandigarh, sir.
Oh,
I
you
finished in
introduce
2019.
yourself. That will be
I'm
better.
presently working at AAG in Hyderabad. So, yeah, good morning to one and all. I mean, we've been taken through 2 wonderful talks till now. A granulomatous lung disease, which eventually turned out to be sarcoid in the first case. And then my case is more of a story of a middle-aged man who had to endure with us for 3 to 4 months before we could give him one specific diagnosis. And before this, thanks for the organizing team for having me here, and my patient in particular, who eventually after 2 years, just with a phone call, he gave me all the details again, traveling nearly 350 kilometers. This was a 56-year-old gentleman from coastal Andhra Pradesh who is a farmer with significant smoking history and uncontrolled diabetes. This was way back during the COVID pandemic. I mean, the second wave. He was just symptomatic for 5 days to begin with fever, breathlessness, and dry cough. Then he was treated elsewhere and eventually shifted in view of worsening breathlessness, increased oxygen requirement, and multiple episodes of non-massive hemoptysis. Clinical examination, there was oxygen requirement and expiratory wheeze. Preliminary investigations were normal except for leukocytosis and thrombocytosis. The radiology of this gentleman was something like this, with a right upper lobe thick walled cavity, a left upper lobe mass-like consolidation, and a left lower lobe small cavitating nodule. So this was the initial presentation with bilateral GGOs, which was in consistence with the COVID being positive, RT-PCR being positive at that time. All this history was just for 5 to 10 days. So the differentials to be considered at this point for us were, if anybody would like to take it up.
Now our expert.
Some 5 to 10 ml of streaky hemoptysis, sir. Multiple episodes, maybe 4 to 5 episodes every day. This was for last 5 days. His illness duration was just 10 days.
RT-PCR positive.
Yes, sir.
And we don't have any previous X-ray before these 10
No,
days.
sir. He presented first time within 10 days during the COVID time. So differentials infective which were considered. History though was very acute, where fungal with mucor going on very rampantly at that point of time. Then tuberculosis, nocardia, necrotizing pneumonia. Non-infective at an acute episode would be very early for us to consider, but those which were kept in mind were malignancy and vasculitis. So this was
During COVID pandemic, what we have seen that the pathology, clinical manifestations of different diseases has changed. And that is very important. Now, even now, we are getting cases that the pathology again has been changed. As for example, during COVID period, we are seeing lots of cases of pneumomediastinum. Now we are not getting it. So at this point, our experts may have some comment.
I think
Any other
post-COVID,
differentials?
We have seen quite a few cases of organizing pneumonia.
Yes, sir.
post-COVID. And rarely organizing pneumonia can cavitate.
Yes, sir.
You know, COVID and mucor became, right hand and left hand.
Anyway,
So as
So
these
fungal
things,
disease is a possibility. Tuberculosis always in cavitary, bilateral cavitary lung disease. And another is the granuloma. What about the kidney function or kidney?
But if you show this CT only, many of us will be inclined to make a diagnosis of GPA. I mean, with these sort of cavitary deletions, some airway symptoms, some parenchymal symptoms, we should give vasculitis in the differential diagnosis also.
he was It was very odd. Pre-exist.
Yeah.
So he was asymptomatic. His history is precisely 10 days to begin with.
Can I just make one
Yes,
just
sir.
general comment? In such a scenario, actually, our experience, we have got patients with uncontrolled diabetes. That is what you told, I think.
Yes,
With
sir.
this infection with Burkholderia is very common, actually. It is not detected, actually. It is commonly misdiagnosed as Pseudomonas. So this Burkholderia infection is very common in undiagnosed, uncontrolled diabetes mellitus patients. So we have to be very careful, and the bacterial culture is a must, because the treatment will change completely. And it is the duration as well as the type of treatment will change completely.
So we worked up for melioidosis. Ultrasound abdomen was normal. Blood cultures were negative. So next for
So-
this patient, for diagnostic purposes, thought of serological sputum or tissue analysis. Initially went ahead with sputum, followed by induced sputum and a bronchoscopy and BAL initially. So all the extensive workup was negative, with stains for AFB, modified AFB, gene expert, ultra, KOH mount, fungal PCR, and even galactomenin. All were negative. And all the differentials, infective workup for which we did were negative. So empirically, he was initially treated with IV antibiotics, and with this presence of hemoptysis, he was also put on empirically posaconazole at this point of time. Uncontrolled diabetes and a cavitating pneumonia. All the workup was negative. So clinically, he was off oxygen after treatment for nearly 2 weeks, but radiologically there was no improvement. Initial BAL was done from the right upper lobe cavitating lesion. So since there was no radiological improvement, we went ahead with a repeat bronchoscopy, this time from the left upper lobe.
Do you have urine examination?
Sorry, sir.
Urine
Yeah,
examination?
it was normal, sir.
It is normal,
I showed
totally.
in the beginning.
Okay, that is very important in this situation.
Yeah, it was normal.
Oh,
But you said it was city-guided through-cut biopsy was done.
That was the next third procedure, sir.
Oh, next, but
So
before.
this was a second procedure. First one was from a right upper lobe cavity, we did a BAL.
Yes.
Second procedure, after 2 weeks, there was no radiological improvement. So we took a BAL and a cryo-TBLB, cryo-lung biopsy from the left lung mass this time.
So fever continued.
Fever was still there, sir. And eventually, again, BAL extensive workup was negative. TBLB, no evidence of malignancy or well-formed granulomas. Occasional histiocyte aggregates were noted. So eventually, we were at a point saying something like an ill-formed granuloma now. Still, no definite answer at this point of time. To look for all the causes of granulomatous lung disease, those which have been elaborated, probably to add on would be autoimmune diseases here. Then he was still stabilized, but I still don't know what I should discharge him or what I should continue treatment at this point of time.
So what were your differential during this time? I mean,
Same thing, sir. Infective and non-infective.
So what are the infective status? You have ruled out most of them. So were
Eventually,
you inclined towards non-infective?
we thought of vasculitis and malignancy still.
Vasculitis and malignancy. Okay.
Organizing pneumonia with cavitation is pretty rare, I think, sir. These were our workup.
In the
And-
COVID background, the fungal infection should be the first possible.
Can you elaborate on the biopsy findings?
I'll come, sir.
Okay.
One thing, na, that you told that vasculitis and malignancy, probably malignancy we can keep aside now.
Yes, sir.
Malignancy will not present like this 3 or 4 lesions, different places.
Bilateral things. So he was on posaconazole at this point of time. Nothing, sir.
No,
TB culture, he went 2 weeks into his illness. RFT is normal, CUE no proteinuria, 24-hour urine protein is normal, no proteinuria.
I mean,
We just put him on IV antibiotics for 2 weeks, and empirically, I mean, it was a COVID time, we put him on posaconazole at that point of time.
I would have stopped the ATT by now. I mean, we have done
2 weeks, sir. 2 weeks, 3 times gene expert ultra negative.
Yeah,
So TB has been
so
good.
it, I mean, yes. I mean,
There is no
Okay.
possibility of TB.
Okay, biopsy was also showing occasional histiocytes.
anyway,
Okay.
but
So 1 month later, again, he's improved. Probably clinically. Fever and fatigue have settled down, hemoptysis subsided, X-ray was not showing any improvement. Now, into 1 month of his illness, we did a CT-guided biopsy from the wall of cavity. From right upper lobe thick walled cavity, we did a CT-guided biopsy at this point of time. And biopsy report was a bouncer, reported as organizing pneumonia. But still, I don't think this makes sense to me. I was still very skeptical.
Given steroids,
Initially, sir.
how much?
For COVID, he was treated with steroids.
But he possibly have developed when the steroids have been stopped.
That was hardly for 5 to 10 days, sir.
Huh?
5 to
I
10
mean,
days.
It can relapse very quickly. I mean, it's easy to say in retrospect, but I've seen organizing pneumonia quite a few, and if you taper off the steroids too quickly, they relapse.
I don't know.
No.
I mean, still I
No,
was
you
not
are
very
treat-
convinced with organizing pneumonia at this point of time. And I mean, probably we didn't consider the differential initially, so I was not very convinced, sir. And again, we went ahead with the further workup, repeated it again, rechecked for anchored, 24-hour urine protein creatinine were normal, blood culture multiple times, no growth. And almost 2 weeks into this illness, now the decision was to what should I treat him still. Antibiotics stopped after 2 weeks, he improved clinically, antifungals, all the cultures till now are negative. Empirically, he was clinically better with posaconazole. Gene expert is negative. Bowel and lung biopsy are negative, even on culture and gene expert. Or steroids have to be started. This was the dilemma. Finally, still I couldn't dare him to start on steroids with this, even the biopsy report. Continued with posaconazole for another 2 weeks. He's clinically better, but X-ray again is still the same. Same opacities are still persisting. Yes, sir.
One is underlying, and sometimes, rarely, they can predict the development of an autoimmune disorder. It can. I mean, you won't find the serology might be negative now,
Yes, sir.
but in 1 to 2 years needs careful follow-up.
So it's almost static. Now, should I continue treatment or should I just wait and watch or redo a sampling? Already this person underwent 3 procedures. He was just continued on
You
treatment.
have
His
given
diabetes-
steroid? You
No
have given?
steroids,
No
sir.
steroid has been given.
Diabetes is better controlled. He developed polyarthralgia. Workup for connective tissue diseases was negative.
So throughout this period, no steroids.
No steroids still.
Uh,
So this was after almost 4 months of his illness. The cavity which was there has probably reduced. It is more like a mass-like consolidation. On right upper lobe, left upper lobe, and left lower lobe nodule is still persisting. With great difficulty and probably some amount of guilt, we convinced him for next biopsy. Finally, we convinced him for a next biopsy. Again, these investigations were negative. All these investigations. Now the biopsy was done on the left side, on this mass-like lesion. And now we have a report of granulomatous inflammation on the biopsy, 4th biopsy finally. Again, all the workup was negative. And eventually, still, I don't have a diagnosis. Gave him antifungals for nearly 4 months. There's no significant improvement. And finally, I mean, more. So mass-like consolidation is still persisting. Sorry. Sir.
I think I cannot justify. I mean, I wouldn't have. I'm sorry.
Yes, sir.
I wouldn't have given antifungals and anything. Secondly, if you see any lesion with undiagnosed, say, with time, there will be development of granulomas, chronic inflammation,
Sir.
be it organizing and be. Thirdly, he never had a full course of steroids.
Never.
So this was
I
during
think that's my view. I mean,
during COVID, uncontrolled diabetic. My suspicion
yeah,
was of.
I mean, diabetes can be.
Ultimately, what is your conclusion?
I mean, Ultimately, we just started him on ATT, sir.
Huh?
After our MDT, I mean, we started him on ATT with an granulomatous inflammation in the last biopsy, ill-formed granuloma, no response to steroids, no response to antifungal, sorry. And within...
Shelly, would you agree on ATT? No. Was a tissue sample sent for gene expert?
Oh, yes, sir.
It was TB culture?
All were negative.
So,
All are done.
I mean, there is...
Now, fever is persisting or not?
No fever, sir.
Fever is not
Radiology is...
persisting. So, after COVID, there is very difficult to diagnose some of the cases.
So this
because
is after
of the,
2 months of ATT.
because of the atypical present.
I don't know.
No, I'm coming. So there is very, the clinical spectrum and the diagnostic criteria has changed after COVID. And during COVID, he was COVID positive. And during this bilateral cavitary lesion, we should think of fungal disease first. And when fungal disease, there is after so many investigation, biopsy thrice, there is no conclusive evidence. And one important organizing granuloma is a diagnosis of exclusion, excluding other causes. Here he has excluded all other causes. And tuberculosis, there is no possibility, as Hari said, because from tissue, the CBNAT has been done, and fungal, you have given enough antifungal drug. So organizing pneumonia, and organizing pneumonia, organizing pneumonia is typically, there may be the fleeting type of shadows, and they may cavitate. And organizing pneumonia, one thing is the steroid is the treatment of choice. There is high chance of relapse. And so tapering of steroid is very important. It should be very, very slow. Otherwise, it will relapse. Yes, yes. Any other opinion of our experts? Again.
Want to say only one word. Want to say only one word. Yes, one word. That all the slides should be reviewed by the pathologist. All the slides, I mean, all the 3 biopsy slides, that could give a better diagnosis. And one, there is an entity called infection-associated organizing pneumonia.
Yes.
And that do respond to treatment of infection itself. So infection-associated organizing pneumonia could be a possibility in this case.
So organizing pneumonia, which we thought was probably post-infective in this. So
Yes.
we did.
These are the patients, I mean, some old and malignancy.
Sure, sir. So this is...
Dr.
I mean,
Bhuya, your opinion?
Just wanted to say that in the background of this repeatedly gene expert negative and everything, patient has responded to antifungal therapy. I don't know, maybe NTM was also.
yes, sir, we thought of it, couldn't get anywhere. So
Dr. Gupta, your opinion, sir?
NTM is most unlikely, I believe. NTM before that, if you just take the day 0 illness, there should be background, some structural damage and something for the NTM like this. Now, and NTM are very bad for the radiological resolutions. Whatever you do, radiological things will persist in NTM. And difficult to treat NTM patients. And fourth thing, NTM,
So even now,
he was
after-
treated with the first line. He was treated with the first line. He was not given macrolide, he was not given amikacin, he was not given rifampicin like that. NTM disease treatment was not given to him. So, if it was there, it is
What
tuberculosis.
treatment
but
you are
NTM
suggesting at this stage?
I don't know, temporarily he definitely responded to ATT. 1 year down the lane, he's 1.5 years down the year, he's still doing perfectly fine, sir.
So I think patients should be kept on follow-up. You have any comment?
Now patient
Total
is
6 months, sir. 6 months, yeah. Yeah. Between somewhere 2 to 4 months period of time. Sir, I accept, sir, but I don't know if he...
TB always a mimicker of any finding. And you need not always get a positive gene expert test. You don't get it.
No, sir, we were left with
TB
nothing,
always
sir.
a mimicker of
We
any
had
lung disease.
two issues of granulomatous inflammation.
No,
He
repeatedly
didn't respond to other
CBNAT
things, did
done
work
from
up
the
for other
tissue is
things.
negative. That's why we
I mean,
cannot.
that we were just more like hit to the wall at that time. Never, sir. Never, sir. 6 times we tested. All the times it was negative.
Yes, yes.
Empirically, sir, yes, sir. But I don't know, he responded.
So we have three presenter, and three presenter has presented very nice cases, and we have a very good discussion and participation of the audience.
Thought-provoking
With
at
this,
least.
I concluded the session. Thank you. এটা কি হলো? Okay, I am going to Hyderabad and I will see you. Okay, sir. Thank you. চলো ছেলে তিনটে হয়েছে, চারটা দিলাম না।
আপনি কোঅর্ডিনেটর নাকি? আচ্ছা, আমারটা তাহলে একটু এখানে
স্যার আপনি টকটা কি ওখানে দিয়ে দিয়েছেন?
না,
হ্যাঁ ওখানে দিয়ে দিন, ওরা ওখান থেকেই কন্ট্রোল করছে এটাকে। হ্যাঁ আপনি দিয়ে দিন, আমি জাস্ট সেশনটা স্টার্ট করে আপনাকে হ্যাঁ হ্যাঁ দিয়ে দাও। So we will resume the next session, which is a very interesting one, a symposium on occupational lung diseases. For that, we have 4 presentations in this symposium. Yes. We will start in 5 minutes.
ড্রাইভ আছে? আচ্ছা তুমি দিদি, আচ্ছা আমার সাথে পরিচয় নেই। এটা অকুপেশনাল আছে। পাঁচ মিনিট অভিষেক আসুক তারপর শুরু করছি। Should I start? Very good morning to all. Today we are having the session on occupational lung disease, and I am the first speaker to talk on it. My topic is occupational asthma. So we'll directly go into the subject, and we start with the word called asthma in workspace. That is, these articles you can find in the 1920 journals, and the recent most guideline has been published in 2022. So it's a very old known disease, and till the classification, diagnosis, and how to treat, the understanding is going on. First, we can, asthma in workspace, we used to divide it into three parts, like occupational asthma, which we'll talk today, asthma exacerbated in workspace, and variants of asthma. Variants of asthma means occupational COPD, occupational rhinitis, and some other allergy-mediated disease which does not qualify to be asthma. Asthma exacerbated in workspace is something when the patient has asthma, previously documented asthma, and when in the workspace his symptoms worsen. It is a very important point to note that if asthma is exacerbated in workspace, then also the employee compensation should be in place. But obviously there are a lot of argument on this point. And what is definite occupational asthma, where the immunological reactions, the triggers and the sensitizers both are present in the workspace. So that kind of occupational asthma we can divide in two parts. One is sensitizer induced occupational asthma. Is there maybe IG mediated, may not be IG mediated, and there the inflammation starts in the workspace only. That is the belief, without any prior asthma. And there is an acute onset occupational asthma. This also can be known as irritant asthma, which is not directly related to immunosensitization. It is, can be due to single exposure, multiple exposure, low chronic exposure to irritant agents, which doesn't cause a IG mediated or IG non-mediated immunological reactions. With this background knowledge, we will have a quick look at the pathophysiology of asthma. This is a very busy slide. I cannot make it less busy because there are a lot of words that have to be hard ones. So how it begins? It can be a high molecular weight agent, we'll discuss, or can be a low molecular weight agent. It can be IG mediated, IL-4, IL-13 stimulated B cells, or it can be CD8 mediated pathway. Both ultimately result in sensitization of the airways to various stimuli. So this is classical immune mediated occupational asthma. The three lines in blue. The lines in green, that is the irritant asthma, where the inhalation of high level of irritants may damage the airway epithelium in subject to develop irritant-induced asthma. When your airway epithelium is damaged, lot of biomarkers, lot of cytokines are released, which cause and propagate the asthma. And these are the mechanisms. Number 5 is telling you that binding of Ig to the receptor induce recruitment and activation of inflammatory cells, and ultimately you develop a subepithelial fibrosis. This subepithelial fibrosis in asthma is also an old concept. Does it actually remodel the asthma or not? We don't know exactly right now. So this is the, in a nutshell, the mechanism of occupational asthma. Now we'll have a short comparison of these three types of asthma we have just narrated. One is immunological way, that is the occupational asthma classical. One is irritant-induced way, that is when the immunity is not induced, but till the patient develops asthma symptoms when he is in the workspace, and exacerbated way asthma. So asthmatic symptoms are present in all. Onset is during working life, within 24-hour exposure when it is an irritant-induced asthma, or before or during working life, it was an asthma exacerbated in workspace. Relation to work, symptoms worsen during working day and may improve away from work. Re-exposure to the same exposure condition as occurred in the acute incident is not recommended, so you don't know actually whether it recurs. Symptoms worsen while at work. Our characteristics is exposure to a known sensitizer. Known sensitizer matlab already there are some literature evidence that this kind of sensitizer can induce an asthma. That is required till date. But we are obviously discovering new sensitizers. No previous diagnosis of asthma or other chronic disease is important for irritant-induced asthma, and it is present. Now investigations, we will discuss investigations in details later on. Here is the comparison. So lung test, objective evidence of asthma can be present in all three. Serial PFR is usually worse in immunological asthma and exacerbated, work exacerbated asthma. But this serial PFR measurement will not show a change over the working day if it is an irritant-induced asthma. It will be in the same level. Methacholine challenge, airway hypersensitivity is present in all three conditions. Specific challenge is always the basic test to diagnose occupational asthma, and that is not present in other two variants. And assess exposure should be done in all of them. And should the assessment of exposure is the true or most important thing to limit the occupational asthma. We'll now move to some of the most common workspace sensitizers that we know till date. That includes these diisocyanates, dust from woods, natural rubber, anhydrous, animal plants, animal plant insects, enzymes of cleaning agents, etc., etc. And there are various kind of occupation where people get exposed to them. Like a hairdresser, they can be exposed to par sulfate and develop occupational asthma. So knowledge about the occupations and the sensitizers is very important and should be commonly known to the respiratory physicians, but even I was not so aware, or most of the people are not so aware of which occupation can lead to occupational asthma. So this is a kind of information that should be more widely available, I think. And now we have a small discussion about the investigations that are commonly employed to diagnose occupational asthma. So assessment of NSBH, immunological tests are low cost, but common extracts for the IG sometimes get a little difficult. serial assessment of work-related changes. It is also a low-cost test, but it is not always practical to do it. And the minimal criteria for optimal validity is sometimes difficult to get. Then we come to the serial assessment of work-related changes in sputum eosinophils. Also expensive and time-consuming test, so obviously not very feasible. Serial assessment of work-related changes in Excel deno, sometimes erratic results can become, and non-invasive, easy to perform rapid test, but expensive test. Specific inhalation challenge in the laboratory, it is a referral test because it can actually diagnose the asthma. So we'll have some algorithm where we can show you that we can have stepwise implementation of the test so that they become more cost effective. And workspace inhalation challenge, it's a little tricky test. It's like you do a challenge where there may not be the medical facilities completely available. So this is a graph. It is showing a 4-week series of peak flow measurement completed by a baker during the off and on days, and which represent a typical occupational asthma. And we have this sensitivity and specificity assessment of different tests, like skin prick test is a sensitivity of 81% but specificity of only 60%. Low specific IgE antibodies, it is 31% sensitivity but specificity raised to 89%. Serial measurement of PEF and non-specific bronchial responsiveness, it is sensitivity something between 84 to 90%, specificity 61 to 67%. Sputum eosinophil, if you get a value of more than 3%, it is the highest specific test, but sensitivity is very low. Serial assessment of sputum eosinophil at and away from the work, it has a very acceptable sensitivity and specificity, but definitely very difficult to get. And this is the prognostic issues of or the risk factors for occupational asthma. So we can see there is onset of exposure and environment, nature of agent, level of exposure, genetic makeup of the person concerned, genetic predisposition and bronchial hyperresponsiveness all together give rise to a sensitization, which ultimately goes to rhinitis or asthma. And then if you can cessation of the exposure, then there is a possibility there can be cure or persistent. It depends on duration for the exposure also. There are some risk factors, and obviously the first and foremost risk factor is cigarette smoking, activation of airway epithelium, and it causes more likelihood for sensitization. Host-related factors, it includes the atopy, genetic markers, pre-existing non-specific bronchial hyperresponsiveness and work-related rhinitis. These patients are more likely to develop airway remodeling and asthma. And this is a diagnostic algorithm which we may follow. I have copied it from Cecil's textbook of medicine. Consider the diagnosis in all patients with work-related symptoms, new asthma and or worsening asthma symptoms during work days. Then confirm the asthma and the onset. For you need a spirometry, you need a methacillin challenge test. If it is no asthma, then it is out of the algorithm. If it is the asthma, then the occupational history becomes very, very important. If you can have a specific history of a exposure to a specific sensitizer, then assess the relationship of asthma to work, symptoms, physiology like a serial PFR will help, and if you can ultimately lead to a work-related asthma, it may be asthma but not work-related, and it may be work-related asthma, then decide if primary occupational asthma based on above. If it is away, then you go for the management, or if it is a work-exacerbated asthma, then you go for the second box. We can divide the investigation in first step and second step. In the first step, we can assess the non-specific bronchial hyperresponsiveness and SPT or IgA. These are little less expensive tests and more available. If they are positive or if they are not available, then we go for the second step investigation where we can do the more specific tests like workspace challenge, like specific antigen challenge, etc. This can be a two-step investigation, can be a better cost-effective way. Now, management of work-related asthma, if whatever the asthma, you have to treat. How to treat? Follow the common guidelines. There is no specific agents or specific recommendation to treat occupational asthma. Prevent exposure to the causal agent, prevent exposure to high level of irritants, and reduce exposure to workspace resistance. Stay in the same job? No. If you can prove it's a sensitizer induced occupational asthma, we can tell a no. But it is very hard to prove in India. We have very less number of papers, if at all. Some papers are from food industries. Otherwise, there are no papers, no such worker liability issues are also in place. So I don't know whether if you don't go to the workspace anymore, you will get a compensation or not. But the recommendation a medical practitioner should make for the sensitizers in such a way that he cannot stay in the same job. Return induced can be feasible because it is not the exposure which is happening daily. Work exacerbation asthma may be feasible. Compensation, these are foreign information, so not very useful for us most likely. Initiate compensation claim, notify authorities. Other may say prohibition of cigarette smoking in all of them. So if you make a tilted pyramid, most effective is elimination. Next effective is substitution. Then comes engineering control, training behavior, this comes at the least. And these are all the pillar of managing occupational asthma. Standard asthma education and treatment, occupational health and employers liaison between them, report care to show, I don't know whether that kind of thing is available here, prevention and reduction of exposure and treatment of related conditions. Prognostic indicator of the occupational asthma. Individual with younger age, normal BMI, higher level of education, no childhood asthma, short duration and no dependency. They have a better prognosis. Also normal spirometry, mild NSBHR, NSBI recovery less than 2 years and no sputum production has a better prognosis. And skilled work role or cessation of exposure also lead to better prognosis. So I end my discussion here, and what I want to point out that our information regarding the sensitizers should widen. We should identify the more jobs where the patient can get exposed and sensitized to asthma related agents, and also claim for a compensation, how it is possible in our country, that should also be found out. Thank you.
Okay, that's the next talk. Parthoda has given me a sort of challenging job because both the diagnosis of HP and establishing HP as an occupational hazard is extremely difficult, particularly in the Indian scenario. You can see the literature. Now, agreement in the MDTs when HP is a diagnosis or considered as a diagnosis is less. That is, it means there is more disagreement in the MDT when HP is involved. So you can understand that how difficult it is to diagnose. Now in the Indian registry, again, HP is the commonest ILD. So a commonest ILD which is difficult to diagnose. Now, what's the challenges in diagnosis? Firstly, it's a varying intensity, clinical presentation and natural history. Now, gone are those days where we say acute, subacute and chronic. It's two types. It's either acute and fibrotic. And who develops acute, who develops fibrotic, we don't know. Very non-specific symptoms and signs. I mean, for acute, you see it's malaise, the sort of night sweats, which are very non-specific. And again, sort of patient can miss unless specifically asked. And these are one of the most specific symptoms for HP. Identification of offending antigen is again one of the difficult tasks. And there are obviously reports of new antigens. We get discordant imaging patterns on the CT. Varied histologic features. It can have granulomatous disease, can have UIP-like picture, can have IP-like picture. And treatment decisions, as I will show you at the end, are often based on diagnostic probability rather than certainty. Something like sarcoid, because in sarcoidosis, the diagnosis is never secure. Very rarely it is secure. So as I was saying, two challenges: securing a confident diagnosis of HP and identifying the offending antigen. Now, why is it important? If you see that, is there a laser pointer? If there is unidentifiable antigen, then survival is worse. And that makes sense, because if you don't identify the antigen, you cannot remove the patient from the sort of source, and there is probably progressive lung damage. So antigen identification is very important. Newer antigen, as I was saying, so not occupational particularly, but these have been sort of reported to cause HP. Now, this was a study. You can see that they found the antigen sources in the urban, suburban, and other, and you can see that about 25% of cases, no antigen found. So, why do we fail sometimes to make a diagnostic? First is failure to consider the diagnosis, that it could be HP. Now, generally what we do is in our practice, two things. Do you have molds in your house? Do you feed pigeons? And do you keep birds? Done. So I think you have to firstly see the CT and assess the patient, and always have the HP as the differential. Now, dismissal of the relationship between the exposure and the illness. Patient might have moved away, but has developed HP. Presence of negative serum precipitants are not a criteria to rule out HP. Presence of normal lung functions or normal CT. Absence of an offending antigen. As said in various studies, it's up to 25 to 40%, and that can lead to consideration of other ILD. An incomplete evaluation of the lung biopsy. Of course, yes, we need properly thoracic pathologists. Now, epidemiology can vary, of course, depending on climate, the geographic locations, availability of the culprit environments, and occupational or industrial practices. Now, I'm showing this, not reading this slide, but you can see the list of antigens that has been published in literature and the occupation. And there is more. You can see the number of publications and the jobs and the offending antigens. So it's not just, so basically that's needle in a haystack. Now, you can get in a concise form evidence-based exposure screening questionnaire. It is very important, and you can sort of have devised a sort of questionnaire. And as I said, HP may be underdiagnosed or misdiagnosed due to failure or inability to identify causative exposures, and 40% won't have identified antigen. Now, this was a survey done between different physicians and with some agreement that what occupational history should be taken from the patient. And this is that sort of agreement between the chest physicians and the occupational physicians. You see the water damage or flooding tops on the list, followed by moldy, standing water, mold. Yes, we do ask, but there are loads more. Now, chest has got sort of, you can get the reference, a short one. It is for day-to-day practice, because it's obviously impractical to go through that list. And you can just tick these boxes, asking specific questions to the patient. This systematic review revealed 158 antigens or haptens and 125 occupational sources. And still new are coming up. Now, why are we so sort of worried about identifying the antigen? As I said, survival is worse if you don't identify the antigen. Secondly, if you look that in the HP study group, the significant predictors of weight loss symptoms, finding exposure, and the odds ratio is the maximum. Now, the probability of HP in this study, if you again have a look, it's not just breathlessness, it's a weight loss symptoms, presence of antibodies, and exposure to the antigen. So you now understand that why it is important. Asking about specific symptoms, try to identify the antigen. Radiology in HP, as I was said, is very varied. You can have bronchiolocentric inflammation. You can have air trapping, as you all know, mosaic appearance, ground glass nodules, and 3-density pattern. The 3-density pattern is 3 areas of different lung attenuation: normal, ground glass, and air trapping, that is black, side by side in 2 or 3 lobes. And that's very specific for HP. Or it's also called the head cheese sign. These are form of sort of HP, which is chronic or fibrotic, I would say, rather. You can see it's a mainly bronchocentric. As I said, radiology has got some role in diagnosis. Fibrosis, as I said, may be patchy, honeycombing in up to 70% of patients, subpleural or peribronchovascular, less basal predominance like IPF. Occasionally, you can get lobular areas of low attenuation. HRCT-based diagnosis has 88 to 92% accuracy and up to 61% sensitivity. So there are about 40% false negatives. Often not specific. Other fibrosing ILDs with upper lobe distribution can give a similar appearance. Now, if you look at the CT predictors, the odds ratio, the ground glass attenuation nodules typically found in acute HP has got the highest odds ratio. And if you look at the ATS guidelines for non-fibrotic HP, air trapping, ill-defined central lobular nodules, mosaic, GGO, basal sparing, axial diffuse. So they have done a compatible, indeterminate, and typical. Now we will incorporate that into the final algorithm for diagnosis. And for fibrotic HP, these are the typical, compatible, and indeterminate. You cannot always go through the literature and sort of read it. Second confusing point, BAL. More than 80% of patients with chronic or fibrotic HP have more than 20% lymphocytes. However, as fibrosis develops, lymphocyte count decreases, neutrophil count increases. As for all fibrotic, because if you look at cellular NSIP compared to fibrotic NSIP, lymphocyte count is lower. So with fibrosis, it's a natural, the neutrophil count goes up. So it can be normal or even lower than normal. BAL lymphocytes can be found in asymptomatic exposed individuals. Okay, as I said, cellular NSIP will have the higher count, in UIP lower count, fibrotic NSIP lower count, probably also in fibrotic HP. So these are the problems in establishing the diagnosis of HP. Now, how do we look for the occupational source or identify an occupational source. So these are the points, where you have to go through, and I will highlight what are the importance of each. History taking and exposure questionnaires are probably the one most important. I will come later on to this. It has to be a structured questionnaire. And of course, a questionnaire in India won't be appropriate for a questionnaire in the European countries. So these are the sort of history at least we should take. It's not only the present job, current job, part-time job, it's also the job environment you have to ask. For example, type of ventilation, types of chemical materials utilized, not just the job. Work-related symptoms, symptoms when on holidays, symptoms of the weekend, knowledge of other worker complaints, and availability of industrial hygiene and medical monitoring results. So this is the complete occupational history. And this was published, that the utility of a standardized questionnaire in 33% of HP, it elicited an exposure where the clinician did not, using the standardized questionnaire. 63% of these had provisional low confidence HP diagnosis, and using the standardized questionnaire, 96% of HP participants reporting in exposure compared with 75%. So the confidence level increases. And you can see that these are different types of lung biopsy, fibrotic ILDs, where exposure using the standard questionnaire has been included, and the diagnoses have shifted from one form to HP. We were discussing, Onam was discussing about inhalation challenge. Now, is either a nebulized solution or by exposure in a challenge chamber. Right, very difficult. It can differentiate both acute and CHP from other ILDs. Sensitivity and specificity can see, and positive test increases the probability of HP. However, where do you get the antigen from? Now, and what should be the parameters of a positive test? These are the sort of studies published in literature. You can see they have used different parameters. So it all ranges from rise in the body temperature, rise in the leukocyte count, drop in the FVC, drop in DLCO, drop in saturation in a mix and match. So that's the limitations. It's non-standardized. No consensus guidelines, and where exactly it stands in the diagnostic algorithm. Which antigen should be used? Now, sometimes antigens can be collected from the workplace by the environmental hygienist, they are called. In the Western countries, they collect the workplace sample and then they prepare the antigens. But there are no guidelines how it should be prepared, how provocations should be performed, what constitutes adequate monitoring, what defines a positive response, and of course, trained personnel. The next thing is antigen avoidance test. It can be used to support a diagnosis of occupational HP. So 2-week antigen avoidance test in 196 patients with chronic HP and a control group, and this was the positivity. Sensitivity of 51% and specificity of 81%. Specific immunoglobulin assay. 4 studies yield pooled sensitivity 83 and specificity 68%. Now, most studies, they measured the immunoglobulin HP who have known exposure, exposed to pigeon, test for pigeons. However, there could be other antigens, as I have just said. So the problem is variability in the measurement methods, antigens used, thresholds. Now, we often use a commercially available panel. I mean, we all know the HP panel, it can produce a large number of false positives. Whether serologic testing is more useful rather than structured questionnaire is unknown. And there is higher test-to-test variability. If you perform on the same patient after 7 days, the results might vary. And it only indicates exposure, not disease. We don't know what quantity of antigen exposure is necessary to provoke a response. Also depends on the interval since last exposure. A patient exposed today might have a negative antibody if checked after 1 month. And preparations can contain different antigen mixes. So it's not a standardized. Asymptomatic patients can still have positive, and we don't know whether HP can occur in the absence of specific antibodies. So this is a bit interesting study. 19 patients with HP, 15 classified as having fibrotic disease. 54 bulk samples were collected from each patient's environment, from the patient's environment itself, and multiple isolates. 7 tested positive to 1 or more samples. 3 had a positive response to more than 1 antigen. The next one is the lymphocyte proliferation test. So it's a role in antigen identification, potential antigens from multiple sources, same, no standardized methodology, test not widely available. Now, if you look at the ATS documents, they have put sort of high importance on the first 3, history, questionnaire, and improvement with antigen avoidance. Environmental assessment, yes, if specific inhalation challenge, if done properly, yes, and multidisciplinary assessment. In 32 patients with bird breeders HP, antibodies against extracts were positive in only 35%, whereas blood LPT results were positive in over 90%. It is actually, you subject the patient's lymphocytes to the antigens and see their reaction. So, one of my last but one slide, that's a diagnostic algorithm, you can see. So, if the HRCT is, I've shown you the HRCT typical, compatible, indeterminate for fibrotic and non-fibrotic. So, if it's typical, we go for exposure assessment. If the exposure assessment we have got and we follow this, these are definite, not excluded, low confidence, moderate confidence. And with the low confidence or moderate confidence, if the clinical suspicion is still high, you can go for a lung biopsy, but for the definite ones, we don't need a lung biopsy. If there is definite exposure history, if there is positive antibodies, compatible CT scan, and BAL lymphocytosis, biopsy, not necessary. Okay? So the challenges we face, I mean, I'm sure all the face eliciting exposure history. And I would all suggest to get that from the chest and follow that. At least it will sort of cover many of the things. Doing specific immunoglobulins, BAL fluid analysis, it has to be done properly, and a surgical lung biopsy. Thank you. Questions? Huh?
And also in BAL, typical acute HP.
CT scan was typical?
Typical, with ear trapping, and BAL also lymphocytic, high lymphocytic for 60% I could remember. And we could diagnose it as acute HP, although that exposure was there, dismantle old TB. So that was the case. It improved on its own.
Yeah, if you
gradually.
remove the patient
Right.
with this acute, I mean, they will improve. But it's important, I mean, you have got that history, but say if it was a sort of slow exposure, we might have missed it. And the problem is also checking the immunoglobulins. We are doing just against for 4 or 5 things. And it's, as I said, it's an antigen mix and... Okay, thank you. Yes.
Thank you, sir, for the beautiful talk. Sir, I have a query regarding this lymphocytosis. I also presented a poster in this disease where I have found the lymphocyte-monocyte ratio is significantly higher than the neutrophil lymphocyte ratio in the seropositive patients of HP, rather than the patients who were seronegative. But both these two groups were radiologically diagnosed as HP. So I did not understand the reason behind. I would like to ask what might be the probable reason for this?
You found the ratio in the blood?
Yes,
Or-
sir. A serological.
Right, not
in the peripheral blood.
The lymphocyte ratio and the neutrophil. I mean, not to my knowledge, I don't know, but it could be an interesting finding. I mean, you can do it on a big group of sort of patients and try to see. I mean, it could be interesting. I mean, generally all the studies have been done on ball fluid. Most of the lymphocyte proliferation tests, they collect the ball fluid lymphocytes and then they subject them to the antigens because those are the reactive lymphocytes. But it could be interesting.
Okay. So could it be a possibility that the lymphocyte percentage can vary because of the exposure to variable antigens?
Yes. As I say, I mean, it can vary. If it's a persistent stimulation, then probably the lymphocyte count would be up. But if the exposure ceases, or you have checked the patient after, say, 1 month, of course the counts might come down. Again, if fibrosis develops with chronic exposure, the counts will come down.
Thank you so much, sir. Thank you.
Okay, so we have among us the coordinator for this session, Dr. Kunal Datta, sir. So I would like to hand over the mic to sir to further proceed the session and invite the next speaker, Dr. M.L. Gupta, sir.
So we do not, Dr. Datta is there, no? Should I start? Mr. Chairperson, Coordinator and dear colleagues, I'm thankful to Dr. Parth Sarthi and his team for inviting me to share my view on a topic which has an immense value not only medically but socio-economically and emotionally, not only to the family of the sufferer but to the society and for the nation also. And before I go to my presentation, I will just narrate a small story. It was my first day as an assistant professor back in 1983. The first patient was with silicotuberculosis. I asked the gentleman, Baba, you know that इससे पत्थर के काम करने से नुकसान होता है. He told, yes, I know. Then my second question, then why you do that? He told, बाबा काम करेंगे उसी के लिए काम करेंगे तो 60 साल तक जिएंगे, नहीं करेंगे तो 30 साल में मर जाएंगे, और क्या काम है? This was the statement of that gentleman. Persons are still dying at the age of 30 years. Earlier, person used to work with chisels. There was a low degree of the exposure. They used to survive at the age of 60. But now, after mechanization, they are having heavy exposures and they are dying at the age of 30 years. There are many villages in Rajasthan where dozens of the young males between the 20 to 40 years, they have died because of the acute silicosis after the mechanization of the silica work. This is the very bad story, but this is the magnitude or repercussion of this disease, which has dimension beyond the medical science. Silica is the most abundant mineral on the earth crust, and primarily it is in the two forms. One is the crystalline and other is the amorphous. These two forms, they have a distinct characteristic. Like in crystalline, the silicon and oxygen, they are arranged in a fixed manner, while in amorphous, they are in the random orders. Crystalline silica, it has a piezoelectric features that is the responsible for its pathogenicity or for its fibrogenicity. When silica is combined with other metals, we call it silicate, and they are also fibrogenic to the lungs. The fact that silica causes lung injury, it causes injury to the other organs of the body, was known to the mankind as back as before 430 BC. But in spite of the 20 centuries of the knowledge that silica is injurious to the health, still we are encountering the epidemics in the 21st century, and classical examples are that denim jean disaster in the Turkish workers, engineered stone bench stove in 2010 in some of the European and American countries, and jewelry polishers particularly in the China and in India. Still we are having the silicosis in the epidemic form in certain population. Silicosis is a global, or silica exposure is a global problem. It has a worldwide presence, and China has highest number of the person exposed to the silicosis, that is around 23 or 24 millions. Although silica production is maximum in the United States, but because of the exposure control and with mechanized work, the incidence of silicosis is less in those countries, in the developed countries. In India, it is estimated that around 11.5 million persons are exposed to the silica dust, and the problem is rising because of the rampant construction and mining, illegal mining, I will say. The silica exposure is more in unorganized sector than in organized sectors, and certain states in our country like Madhya Pradesh, Chhattisgarh, Jharkhand, Gujarat and Rajasthan, they are most affected. I don't know about the status of mining in West Bengal, how often you come across the silicosis, but it is a very big problem, particularly in our state. In Rajasthan, we have more than 30,000 sandstone mines, marbles and granites, and again it is more in the unorganized sectors. Certain districts like Dosa, Karoli, Kota, Chittorgarh, Jodhpur, they are most often affected. Any occupation where the person is exposed to the respirable silica is likely to have silicosis. There is a long list of those occupations where a person can acquire the silicosis. But surprisingly, there are situations where a person is not exposed directly to the silica dust, and there can be non-occupational silicosis, like those in agriculture workers, that be desert dust, or persons residing near silica industry or a machinery. Various factors that decide about the development of the silicosis include cumulative dose of the silica that depends upon the content of the respirable silica and duration of the exposure, tridymite followed by the cristobalite and quartz. It is in this order, the pathogenicity, or we can say the fibrogenicity depends. The tridymite is the most offending, and quartz is the least offending among the three variety of this one crystalline silica. Freshly fractured silica dust is more injurious than the age-old silica dust. Black population is considered to be at more risk than the other population. When it is combined with other trace materials like tin and tungsten, it again has more potential to cause silicosis than alone. In the most simplified way, the crystalline silica, when it interacts with the aqueous medium, free oxygen radicals are liberated. On the other hand, when the alveolar macrophages, they engulf the silica dust, they get disrupted and inflammatory cytokines are released. Inflammatory cytokines combined with the oxygen radicals, they causes fibrosis and inflammation in the lung parenchyma, and so-called silicosis is developed. Depending upon the duration and intensity of the exposure, there are primarily three types of the silicosis we see. That is chronic silicosis, subacute or accelerated silicosis, and acute silicosis. I will take one by one. When there is a low intensity of the exposure for more than a decade, we have chronic silicosis. Patients with chronic silicosis are usually asymptomatic, but symptoms are present. They are usually cough and dyspnea, and the symptoms are only present when the person either develops progressive massive fibrosis, or person is a smoker, or either because of the smoking or the silica exposure he develops obstructive airway disease, or silicosis is complicated with the lung cancer or a tuberculosis. In absence of these, a patient with chronic silicosis will not have symptoms. Clubbing and crackles are usually absent in patients with chronic silicosis. Coming to the radiology, in silicosis, chronic silicosis, we find nodules around 1.5 to 3 millimeter in the diameter. They are discrete. If you see carefully, they are hard in consistency. Nodules are usually more in the upper and mid zones. Often we see mediastinal and hilar calcification. Characteristically, the calcification can be axial calcification. The other condition where we can see the axial calcification sometimes is the sarcoidosis. In patients with simple silicosis, we can find linear interstitial opacities like Curly's B line at the base edge, and there can be pleural thickening. The nodules in silicosis, the one particular thing is that in spite if the person has seized the exposure, person is out of the exposure, the nodules can progress, disease can progress. This is in contrast to the co-workers pneumoconiosis, where once the this one exposure has ceased, disease stop progressing, while this is not true with the silicosis. Over the time, the nodules, the coalesces, and they found the bigger nodules of more than 1 centimeter size with an area of the calcification and fibrosis, and this situation is called progressive massive fibrosis, like this. This formation of the progressive massive fibrosis is more where there is a continued exposure to the silica dust, or a person is a smoker. These nodules of the PMF, earlier they were an exudative characteristic, but over the time they become dense fibrotic nodules which cause a distortion of the lung parenchyma and associated vascular structures, and there is a compensatory emphysema of remaining healthy lung. Like this, we can see the basal emphysema in both the X-rays, and in second X-ray we can find some small pneumothorax on the right side also. This patient with progressive massive fibrosis, they may have cavitation or a breakdown, often because of the ischemic necrosis or sometimes because of the superior infection, mycobacteria, or because of the fungus. Coming to the imaging, usually the nodules are there, which I have told. They are symmetrical, they are in the upper zones. This is the CT picture of a patient with simple silicosis. Nodules, both the upper, more common in the upper and mid zone. And when it is complicated, we see white dense opacities, which are usually in the posterior part. This is called progressive massive fibrosis associated with hilar calcification. The second variety of silicosis is the accelerated silicosis, which usually develops after 5 to 10 years of the heavy exposure. Contrast to the chronic silicosis, patients with accelerated silicosis, they have early breathlessness, which progresses rapidly also. The radiology of accelerated silicosis, they have a sparse and indistinct nodularity as shown in the X-ray, and there is a progressive upper lobe fibrosis with basal emphysema. This is a CT picture of a patient with accelerated silicosis. This again the CT picture, we can see large fibrotic bands, progressive massive fibrosis, and there is a sparse nodularity. A few weeks or years of the exposure with high concentration of the respirable silica can cause an acute silicosis. Patients are symptomatic from very beginning, informed the cough and dyspnea, and These patients often have constitutional symptoms like fever, chest pain, and they also have respiratory insufficiency. The disease is mainly in the mid and lower zones. In contrast to the chronic and accelerated silicosis, patients with acute silicosis, they have a disease more in the mid and lower zones and more in the posterior part. The type of the opacities include ground glass, consolidation, centrilobular opacity, crazy paved appearance, punctate calcification, hilar calcification. The radiology of the chronic acute silicosis should be differentiated from pulmonary edema, alveolar proteinosis, and PCP pneumonia. As long back in 1992, we reported 2 cases of acute silicosis in patients who were engaged in the powdered bag, silica powder bag. In those times, CT scan was not easily available, so I don't have any CT film. X-rays are also I have taken from the journal site. Sometimes patient with silicosis, they may have a picture resembling that of a chronic interstitial pneumonia, like this. There is a peripheral honeycombing, reticulations are there. So whenever we encounter a young male with a picture similar to that of an UIP or an ILD, always try to take the history that have you ever exposed to the silica dust, because we may be missing that, because IPF or IPF is not common in the younger age group. So whenever a younger age group person comes with such picture of a IPF, we should try to take the history of a exposed to the silica or a mining work. The diagnosis of silicosis requires history of the exposure, compatible chest X-ray or radiology, and simultaneously exclusion of other competing diagnoses. Pathologically, if we see grossly, there is hard nodules on the lungs, usually in the peribronchial distribution and over the hilums. In the early part of the illness, there is a dust-laden macrophage with loose reticulin fibers will be seen, but in the later part, a classical silicotic nodules which have an hyalinized centers, which on polarized light can give a picture of a birefringence, and it is surrounded by the spiral or the bird appearance as shown in the diagram, and outermost layer contains of the macrophage and lymphocytes. Coming to the other diseases which are associated with the silica are silicotuberculosis. One, exposure per se increases the risk of the silicotuberculosis. Risk is highest among the acute silicosis patients. Patients with acute silicosis, not only they are at risk of tuberculosis, they are at risk of other opportunistic infections like fungal, nocardia, like that. They have a similarity with that of silicosis. They are whenever a patient with silicosis present with a constitutional symptom, we should work up for the presence of a tuberculosis. A patient suffering with silicotuberculosis requires a longer duration of a treatment for a 1 year rather than a 6 month. And more so, in spite of the 1 year treatment, we should not expect a clinical response as seen in a other patient with a tuberculosis, because patient is likely to be symptomatic even at the end of the treatment because of the background silicosis, and we are not going to get a optimum radiological resolution. NTM disease is more common in patients with silicotuberculosis, but there is no report that MDR is more common. Active tuberculosis at the baseline in an exposed individual increases the risk of the silicosis. These are the 3 important risk factors like diabetes, HIV, and silicosis for the tuberculosis. And with our annual incidence of tuberculosis is around 210 per lakh populations. With this, around 22.44 lakhs cases were reported last year in our country. Considering this and considering the estimated number of patients with these 3 comorbidity, we find that around 30% patients are with diabetes, 3% are with HIV tuberculosis, and 3% are silicosis. If we consider that every silicotic patient is going to have tuberculosis, that is not so. So this way, do you think in our control program or our tuberculosis eradication program, tuberculosis and HIV, diabetes and HIV, they have integrated. But what about silicosis? Should we integrate this also? Answer is no, because each and every patient who is going to get treatment for pulmonary tuberculosis, with few exceptions, they are going to get an X-ray chest. So silicosis as a byproduct we can diagnose at the same times. But what it is required that all silicotic patients, they should be screened for tuberculosis at a periodic interval. If you really want to take care of these populations. TB is both underdiagnosed and overdiagnosed in silicotic patient. Whenever the patient comes to us, we just think that let's think of a chemoprophylaxis in this patient. We ask him, have you taken treatment? Yes, I have taken treatment 3 years back. In our country, whenever we see any infiltrate in the X-ray, person used to give the anti-TB treatment. So that's the problem. So probably chemoprophylaxis, before chemoprophylaxis, person has already received a full treatment. Hong Kong Chest Services, TRC Madras and BMRC, they conducted a double-blind, placebo-controlled clinical trial of 3 anti-tuberculosis chemo regimens in patients with silicosis. That were 3 months rifampicin, 3 months rifampicin INS, and 6 months of isoniazid. And they observed that by giving 3 months or a 6-month regimen, the incidence of the tuberculosis can be reduced by 50% in silicotic patients. These silicotic patients, they are prone to have necrotizing pulmonary aspergillosis. It has been reported because of the local poor immunity which create a breeding ground for the fungal invasion, and a term silicomycosis has been given to these diseases. Various epidemiological studies have shown that there is an exposure-response relationship between the airflow obstruction and cumulative dose of the silica. More the exposure, more likely the person is having airflow obstructions. Silica exposed individuals have an excess loss of the FEV1 of around 10 ml per year compared to the controls. But silica related airway obstruction is rarely disabling in absence of a underlying silicosis. So person if develop the silicosis, then that air obstruction becomes symptomatic. Otherwise, that airway obstruction because of the silica dust per se is not going to cause much problem. An interesting observation that we know that silicosis and sarcoidosis, it has many similarities. Both are asymptomatic most of the times. Both have parenchymal infiltrations like nodular opacities. Both may have sometimes pleural effusion. Both have hilar lymphadenopathy. And certain occupational and environmental exposure to the silica in certain studies has found to be a relationship. Whenever there is an exposure to the silica, that population is found to have more silicosis. Like a case control study where the cristobalite form of the crystalline silica was the exposure individuals, they had a silicosis odds ratio of around 13.2. Incidence of the sarcoidosis in persons residing near a plant processing the dichometaceous earth, the found sarcoidosis was more in that populations. Higher incidence of the sarcoidosis was observed in World Trade Center exposed individuals. Swedish foundry workers, those who are exposed to the clay and other things, the frequency of silicosis that population was more than their national average. So there is some relationship between the silica exposure and the frequency of and the chances of the sarcoidosis in that populations. Silica exposure is found to have an carcinogenicity. Pooled data and meta-analysis done by the International Association for Research on Cancer, they observed a odds ratio of the 1.7% in the silica exposed individuals. This risk is not strong in absence of the silicosis, and risks do not increase linearly with the magnitude of the exposures. So there is no guideline for the screening for the lung cancer in the silicotic persons. If a person is a smoker, then probably what are the guidelines are available for the screening of the smokers for the lung cancer can be applied for that. Otherwise, a silicotic person can be assessed for the lung cancer on individual basis. Connective tissue, the frequency of the connective tissue disorders, both antibodies and for both the disease is more in those patients with the silicosis, particularly the scleroderma and ANA vasculitis. Presence of the autoantibodies do not correlate with the progression or the severity of the silicosis, and mechanisms of the silica-related autoimmunity are not well understood, but possibly chronic activation of the T lymphocytes are responsible for the connective tissue disorders in patients with silicosis. Nephropathy is also common in patients with the silicosis, possibly either because of the direct nephrotoxicity or through an autoimmune process. So it is important to identify the occupational related renal disease in order to provide a ideal preventive protection for the exposed individuals. There is no proven treatment for silicosis. Removal from the further exposure is the only thing which is available with the physicians. Smoking cessation, influenza or pneumococcal vaccination can be suggested, and treatment of the comorbidity, if any, can be considered. Preventive measures, it can be primary preventions like substitution of the material, isolation of the source, or training and education about the workplace practice to the individuals. It can be secondary prevention, or can be tertiary prevention, what is at the hand of the physicians. We can leave this one. The hierarchy of the control can be like this: elimination. We can remove the hazards, substitution of the hazards, engineering control of the occupations, administrative control, and PPE, personal protective equipments. The best is the elimination of the hazard is the best thing. PPE is the least effective. National Institute of Occupational Safety and Health has given some criteria. The recommended exposure limit is the 50 microgram per cubic millimeter of the inhalation of the dust-containing respirable silica, and up to 10 hours work hour day for 40 hours a week. But does the exposure into the permissible limit prevent the silica? Answer is no. This so-called permissible limit, if 1,000 persons are exposed for 45 years, still 19 are at risk of the lung cancer mortality, 54 will have lung diseases other than the silicosis, and around 75% will have radiological silicosis. Health monitoring program for the silicotic persons should be included in this one. And after this one, PIL was filed in the Supreme Court, and National Human Rights Commission was asked to take care of these ones, and there is a provision of a compensation for the silicotic person. I don't know about the other state, but in my state, those persons diagnosed with the silicosis, they are given a 1 lakh compensation by the government, and those persons who have died because of that, they receive a 3 lakhs compensation from the government of India or government of state of Rajasthan, I don't know that, but they receive the compensation. To summarize, silicosis is a worldwide problem. Despite the extensive use of the silica, incidence of silicosis has declined in the developed country due to effective preventive measures. Developed nations are facing epidemics of this disease due to accelerated construction activity and poor preventive measures. Good history, typical radiology is often sufficient for the diagnosis. In situation of atypical presentation, histopathological correlation may be required. Exposure to the silica is associated with a wide spectrum of both pulmonary and extrapulmonary diseases. As there is no proven therapy, avoidance is the best prevention, and no preventive therapy is foolproof. Thank you for giving me the patience list.
Thank you, Dr. Gupta. May I just have a small question to be addressed? In Rajasthan, the government has taken a fantastic silicosis control program plan, out of which they have come up with an AI-based sort of algorithm for diagnosis of silicosis by clinician on the front line. Can you elaborate on that a little? Government of Rajasthan, as part of their silicosis control program, has come up recently with an AI-based protocol for identifying silicosis by the primary care physician. Can you illustrate a little bit on that, as because that will be much helpful? No, they have publicized it in a very big way. Nothing is happening on ground. Another thing I will just ask you to, before I ask Dr. Sarkar, the Director of National Institute of Occupational Disease with us, will be addressing us shortly. One thing is the permissible exposure limit time weighted by OSHA for silica dust is 0.05 milligram per meter cube. Whereas in India, it is 0.15 milligram per meter cube. Is this laxity causing a lot of more silicosis in India? Sir, I will beg to differ. As because I have studied some industry, big organized industry, mostly ceramics and engineering. So I have, say, around 1,000 cases of silicosis diagnosed by me till date, and it is going on. So all of them are working in a big industry, in an enclosed space, having huge amount of exposure, and nothing is happening. Even some industries, due to my studies and work, some industries were scrapped. Their green license was scrapped. Even then, nothing changed. So they are producing, say, average, a particular industry, I cannot take name, a particular industry is producing 30 dead bodies a year dying of silicosis till date. I started this work in 1996 and it is going on. So I beg to differ that no, not all the workers suffering from silicosis are working in open space. Yes, 17% of industrial workers in our country, 17%, that is 21 million, they work in organized industry. Rest work in unorganized sector. That is all right. Maybe the industrial sector, organized industrial sector have less number of silicosis, but the prevalence is much higher. Prevalence among them is much higher, as because the concentration and the dust load is much higher in a organized industry. So this permissible limit, this TLV, BTLV, it matters very much. Any other question for Dr. Gupta? Okay. Thank you, Dr. Gupta, for your nice presentation of silicosis. Now I will ask Dr. Sarkar, Director, National Institute of Occupational Health, Kamlesh Sarkar, to make his presentation on alternative and novel methods of diagnosis of silicosis.
Just a little bit correction, I retired already, so I'm former director. So my topic is, good afternoon everybody. My topic is control of silicosis and silicotuberculosis using a novel method, you can say. Actually, we tried to identify a novel biomarker that is known club cell protein 16 or CC16. See, as we understand that most of the occupational diseases are not curable, but it is preventable. And unless you try to prevent it at early stage, even you cannot prevent it. So if you want to prevent it, diagnose it at early stage, so you need to find. As my previous speaker, Dr. Gupta has told, chronic silicosis, most of the silicosis in our country is chronic silicosis, which usually takes 10 to 15 years to get detected, because the X-ray based shadow, appearance of X-ray based shadow, it takes 10 to 15 years. The driving force is the silica content of the dust. If the dust contains 95% silica, or maybe recently we explored one epidemic of acute and accelerated silicosis in Jharkhand in a ramming mass industry. In ramming mass industry, that dust contains more than 99% silica. So even less than 1 year, the workers will develop silicosis. I'm just, you know, this is a very common scenario in our country, dry drilling and this manual cutting of stone, and it generates lot of dust which contains silica particle. These I am skipping because Dr. Gupta, he did very nice presentation, he explained everything which I wanted to tell. So India has a huge burden of silicosis, and mostly, as Dr. Dotto told, in the informal sector workers. It was estimated, actually in a Lancet editorial information which was published in 2019. Estimated 11.5 million workers are at risk of silicosis because of their day-to-day exposure. But we have certain reservation on it. It is grossly underestimation. Why it is underestimation? Because we have a lot of diversified workplaces which generates lot of dust, and many of them are unorganized sectors, and it's very difficult to control all those workplaces, and they are exposed to risk. There is a lifetime risk of developing pulmonary tuberculosis, as because of their, when they get exposed to silica dust, it continuously destroys the lung immunity, as Dr. Gupta explained it. And our country is a TB endemic country, so often they get infected with tuberculosis. Earlier, we conducted a study at National Institute of Occupational Health, Ahmedabad, which showed that the workers which are exposed to certain duration and which the workers which are exposed to longer duration. Actually, we divided the workers into healthy group one side, some exposure but X-ray negative, and some exposure and long exposure X-ray confirmed. In this three group, we found that, now I am coming to the biomarker. Biomarker is club cell protein 16. It is a protein. It is a protein which is secreted from the terminal bronchioles, non-ciliated epithelial cells of the terminal bronchiole, and it is an anti-inflammatory in nature, antioxidative, anti-inflammatory. Its aim is to repair the tissue injury, lung injury. Now, what happens in silicosis? There is a continuous or intermittent exposure to silica dust, and there is a continuous or intermittent destruction of the lung tissue. When there is a continuous destruction of lung tissue, the amount of CC16 present in the bowel fluid, it gets reduced over a period of time. And this CC16, it diffuses very easily to the peripheral circulation. So by pricking, finger prick, 1 drop of blood if you collect, and if you see how much is this CC16 level, you can identify what is the lung status among the silica dust exposed workers. This is not a very specific, because lung damage due to any reason it will decrease. But the problem is that in public health, particularly when there is no other alternative method, you can use it as a proxy marker, and you can select a selective group of who are silica dust exposed group. If you periodically detect their CC16 level among the silica dust exposed group, you can identify their lung health status. So we found there is an inverse relationship between increasing duration of silica dust exposure among workers and their corresponding decline of the serum CC16, which was published in one Indian Journal of Indian Journal of Medical Research, which is our ICMR publication. It was published there. But then we worked again next. We conducted another study. In that study, we showed that this CC16 value, the first study showed that it is with duration, it is related. But as I told, in various workplaces, the dust content, silica content of the dust varies. So whether it is really related with the progression of lung damage or not, that needs to be identified. So in our second study, we tried to identify the amount of lung damage from the X-ray chest. This method, I am coming to that. This is a typical X-ray shadow, bilateral patchy white opacities for the silicosis. Now, in that shadow, there are four types of, four criteria we considered. One is the small opacities, one is the large opacities. When small opacities coalesce, they make large opacities. Then the profusion opacities and zones of lung involvement. Now, based on these four criteria, we gave certain scoring values. And ultimately, by calculating the scoring values, this lung damage scoring value is equal to X into Y into Z plus L. L is the large opacities, X is the small opacities, Y is the large opacities. Y is the proportion of opacities, X is the small opacities, L is the large opacities, and Z is the zones of lung involvement. So anyway, this is the lung damage score. It was made by us for the study purpose. Mild lung damage was considered as when lung damage scoring value between 1 to 6. Moderate is when between 7 to 15, and the high or severe lung damage when it is more than 15. Now, we collected blood samples. In this left side, this represents the normal healthy people. The average value is 16.3 nanogram per milliliter, and this red portion represents the lung damage, and the green portion represents the healthy lung, means not healthy, the normal lung, performing lung. So in mild lung damage, the value was 8.4 nanogram per milliliter. The moderate lung damage, the value was 4 nanogram per milliliter, and the severe lung damage, the value was 0.7. So, and there is a continuous decline from healthy to as time progresses, the lung damage increases, and there is a progressive decline of the CC16 values. So we concluded that CC16 may be used as a possible cost-effective and proxy biomarker for screening and assessing progression of silica dust lung damage in silica-exposed workers. So they need periodic screening. If we do periodic screening among silica dust-exposed workers, we can identify their silicosis at very early stage. Now, one confounder is the smoking. Smoking also reduces to some extent 1 to 2 nanogram from its non-smokers value. So, to neutralize the smoking effect, we have suggested one is the stop smoking for at least 1 month before the test date. Once you stop smoking for 1 month, the value elevates again, the CC16 value elevates. Or you add 2 for heavy smoker means more than 10 cigarettes per day, or moderate 5 to 10 cigarettes, you just add 1 nanogram with the test value. So in this way, you can neutralize the smoking effect. Now, following identification of this biomarker, our team, they tried to develop a point-of-care, semi-quantitative and user-friendly CC16 detection kit. Because ultimately, the biomarker which we try to establish, unless you can make a point-of-care device, because in our country, there are a lot of workers, they are located in all over the country, some are in the remote rural villages. So unless you develop a system, the national silicosis control program in which all the public health, primary healthcare center, physician or healthcare workers, they are able to test it periodically, that means once in a year, and it should be linked with the Aadhaar. Why I am telling the value should be linked with Aadhaar? We suggested to the government of India, you make a program, National Silicosis Control Program, in such a way that periodically, once in a year, the CC16 value to be detected among those history of silica dust exposed workers and linked with Aadhaar, because many of them are migrant workers. This year they may be in Jharkhand, next year they may be in Punjab. So if you want to track it longitudinally, the progress of silicosis, you have to make a system like kind of this, which needs to be digitalized. Anyway, maybe it is over ambitious, but this was our suggestions. Our partner institute, the National Institute of Virology, they have their Mumbai unit. We got hold one of our biotechnologist friend, and we explained them that we need this thing, that 1 drop of finger prick, 1 drop of blood, if we put on these oils, it is just like pregnancy detection kit. And then the method is the lateral flow immunochromatographic method. If you put 1 drop of blood and nitrocellulose paper, then the serum will come out below and it will flow along the channel. Now, there is no pointer, na? See, the number 1, there is only one line which is considered as a negative control. Just like pregnancy kit, unless that line appears, so test is invalid. So it will appear always. Then when there is one line, negative control plus one line, it indicates the CC16 value between 6 or below. That means advanced silicosis, X-ray detectable silicosis. And this one is the when there are negative control plus 2 lines, CC16 value between 6.1 and 9. And when there are 3 lines, it is above 9, something like this. So it is a semi-quantitative method. In that way, we planned it. As I told, serum CC16 may be used as a proxy marker for early detection of silicosis, at least for screening purpose. All primary health centers, doctors or nurses may be, need to be trained towards this to support above activities. Vulnerable informal sector workers must undergo annual screening. A suitable legislation is required by the relevant authorities. Now, problem is that the silicosis is a labor-related problem they consider. So it is related with the Ministry of Mines, Ministry of Labor, Ministry of Industries, etc. Whereas, as it is a lung disease and TB is intimately related with that because of there is a continuous destruction of lung immunity, so they often get infected with tuberculosis. So based on our working experience, we have suggested, SAR has also suggested, unless silicosis is controlled, TB will never be eliminated. This is our understanding, but people are not, maybe some are very hesitant to accept it, but this is fact based on our experience, working experience. We published these two things. One is the secondary prevention of silicosis and silicotuberculosis by periodic screening. Thank you. This was published in Health Science Report, and that was Nature Scientific Report, the kit related publication, it was published there. Now, ICMR has already accepted it and they posted it in their Twitter handle, rapid point of care test. Now, 2 companies have been assigned for developing this kit. They are finding some problem in the final, so they are fine tuning it. We hope that in near future it will be available in the market. Now coming to a very interesting part and very important part. As I told, or SAR has also told Dr. Gupta, that it takes long time, 10 to 15 years time to develop silicosis by radiologically. Before that, there is a long gap, long lead time or whatever you call window period, during which lung is damaged and person is having silicosis, but it is not radiologically detectable. It is known as subradiological silicosis, which should not be overlooked, should not be neglected, because once somebody is exposed to silica dust for a considerable period, lifetime he will remain vulnerable to tuberculosis. This has been established by studies in South Africa among gold miners. So we have termed it invisible silicosis. Now this CC16 kit, as from the healthy person, the journey, the entire journey, it will indicate, so the subradiological silicosis portion also it can hint. So India is committed to eliminating TB by 2025, but there are a lot of challenges. SAR has also told these are lack of early detection. There is an increasing drug-resistant TB cases. Actually, when there is underlying silicosis, 3-4 things happen. There is a more chance of tuberculosis, which is very difficult to detect. The organism is very difficult to detect when there is underlying silicosis. There is uncertainty of treatment outcome. There is increasing chance of multi-drug resistance, increasing chance of morbidity and mortality among them. Relapse rate is higher when there is underlying silicosis. So the silicosis needs to be detected at very early stage. We should not wait for when it becomes X-ray detectable by after 10 to 15 years. So before that, we need to try to detect it. Recently, not recently, some 1 to 1.5 years back, we conducted another study among the glass industries in Firozabad. The glass industry, it's a huge glass industry. Glass dust contains the silica basically. So among glass industry workers, among glass industry workers, we found that 46% they had tuberculosis tested by CBNAT, whereas the non-glass factory workers, they had only 4%. And among these glass factory workers, those who had radiologically detectable chest X-ray, So means radiologically silicosis, among them they had 66% tuberculosis, and those who were not X-ray detectable silicosis, but they are exposed to dust, that means subradiological, some of them are at least subradiological, they had 20.8%. So non-glass factor it is 4%, here it is 20.88%. This means the TB rate is very high even among subradiological silicosis also. So this should not be neglected or overlooked. So it appears unless silicosis is controlled, TB will not be controlled and eliminated in India, as the burden of silicosis appears to be very high and grossly underestimated. In South Africa, they have shown that out of every 100 exposed workers, 57 were subradiological silicosis and 43 were radiological silicosis. In South Africa, they have a rule when any miner means gold miners I am talking, when any miner dies, before the death, there is a X-ray was done, but after death, routinely autopsy was done, and in the autopsy they they detect silicosis and silicotuberculosis if there is, and if it is detected, then he will get compensation as per their country rule. But in our country, if it is subradiological, if it is not detectable by chest radiography, then it is not given. So that's why we are telling a suitable legislation is required. It should be brought under the network of compensation along with system of detection. So TB Elimination Authority appears to have almost no idea about silicotuberculosis burden of the country. Recently, another scientist of National Institute of Occupational Health, they have tried to work on the burden, and they have projected, the projected burden will be silicosis burden by the end of 2025, 5.2 crore, means 52 million. So it should not be neglected, that I am telling. So we published this paper. This was published in Indian Journal of Tuberculosis, which is an international journal, although name is Indian Journal managed by Elsevier. Elimination of tuberculosis requires prior control of silicosis, including subradiological silicosis. We are trying to sensitize Government of India and the TB control program authorities to accept importance of subradiological silicosis. Now, following early detection of silicosis, what is next? Recently, few studies have already published that shows metformin, which is a very commonly used anti-diabetic drug. Metformin has very good antifibrotic activity, and they have prevented silica gel-induced silicosis in rats. So why not initiate a trial among the early silicotic, particularly the subradiological silicotic patients with this metformin, and see how is the result. That is our suggestion, basically. Thank you very much. That was my last.
Thank you, Dr. Sarkar, for your very informative, novel idea of detection of silicosis very early. So I will ask if there is any question from the audience. I think we should have some questions.
Sure.
Anybody?
For the 20%, around 20 point some percentage persons among the non-silica industry, they have tuberculosis. Can you tell what type the industry they are having? That figure looks very huge now. 20%, every 1 out of the 5 was having tuberculosis.
All were worker of the glass industry, and there is a huge cloud of dust in the entire area. They are exposed to that. Even during office hours, work hours, beyond the work hours, entire area is full of cloud of glass dust.
Sir, actually, he has specifically told that the study was conducted in glass industry among the workers. And
that was a very far place. That was in another place within the same district, Firozabad district, but that was not glass industry. Some 5-6 kilometers away from that area.
I don't know about the present day statistics, but in our younger days, John Hunter textbook of occupational health, they used to say that silicotics are 15 times more prone to contact tuberculosis. Now I have come across some studies done by NIH recently published. They are telling that they have studied silicosis to be at least 3 times more prevalent than open population.
The reason I am telling why there is a varying percentage.
There's a very recently published paper
It
by them.
depends on basically the silica content of the dust. The main driving force is silica content of the dust. If the silica content is high in a particular workplace, the lung damage will be more, the chance of tuberculosis will be more. If the silica content is less, lung damage will be less. Of course, other factors, the duration of exposure, the amount of dust each day, the dust concentration at the workplace, and the silica content of the dust. These 3 things, of them, the silica content of dust is the most important and driving force. So that's why workplace to workplace it will vary. The TB prevalence will vary.
Can we go to that slide, sir? Can we?
Sure.
Next slide where the around glass factory 50% are having
Can you
silicosis.
please put it? No, I cannot open it from here.
Yes, yes. Sir, this one, non-silicotic arm. Next slide, sir. Next slide, sir. Yes, yes. Non-silica worker based test.
No, non-silicotic workers means based on radiography.
Sir,
Based on radiography. Some are in the early stages, some are in the radiographically detectable stage. That means they have a longer exposure.
This 20% is in those individuals who are not exposed to the silica.
No, they are exposed to silica. They are exposed to silica, but not radiologically detectable. Same industry. Radiology, yes, sir, you also told the same thing. Initially, radiologically negative.
This is some other industry.
Anyway, this is just an eye-opener for the national program authorities.
Okay.
Okay, sir.
So, any question for occupational asthma, doctor?
Sir, it was a very nice talk. I just want to ask you that I am working with silicosis. So I found that CC16, when I am planning to work, it is actually a non-specific biomarker for lung. So
Actually, you are right, very right. It is non-specific marker. Since there is no other specific marker, so out of frustration we have taken it. But when you select the group do the test in a selective group, it will become specific. So it is like this.
Okay, sir.
Actually, this CC16, we initiated trying to make a suitable point of care device. Then recently one paper published from Cincinnati University from USA, they have also developed a device in the published paper that says they have developed a device by which they have also found that it accurately correlates. See, how do we assess it? You collect 1 drop of blood and test CC16. Same time the conventional method is ELISA kit, which is not available in India at present. We need to import it from Czechoslovakia. We did it. And if you test both the side, and in USA paper that Cincinnati paper they tested, they have said it is very well correlated and the gap is very low, 0.3. Gap is very low, 0.3 nanogram. So once we come to know that USA has also told the similar thing, so it can be used for screening of silica dust exposed workers. So we got excited, we are in right direction, right path.
Sir, can you tell me the sensitivity and specificity of the
sensitivity is high, specificity is high. See, I am telling in world, no test is 100% perfect.
Right.
If sensitivity is more than 90%, 95% for screening purpose, you consider it's a very good test. Because, see, the silicosis, if you diagnose a little late, it does not matter much. But your point of the concern or the aim should be the early detection as early as possible. If you detect at early stage, you can prevent both bigger silicosis, means advanced silicosis, you can prevent tuberculosis, nephropathy, whatever else. So our target is to detect at early stage, and it has that ability to detect.
Okay, thank you, sir. Thank you.
Yes, yes.
Most of the persons who are engaged in the silicosis or silica industry, from day one, I'm not telling 100%, but most of the persons, they know that this job is not good. They know. But it is the social and economic compulsion with them that's forced them to work that. Unless we take care of that, even the test is good, good innovation is there, I don't deny with that. But even if you tell him that you are going to develop silicosis, you stop this work. Second question he will ask, then tell me what should I do tomorrow. So unless we answer that thing from the administrative side, from the government side, probably the things will not be solved in a...
Sir, I agree 100% with you. But one thing I am telling, repeated screening, it changes the behavior from unhealthy behavior to healthy behavior. Repeated screening, it has another very important side effect or whatever. It changes human behavior. In HIV, we have observed one thing. In HIV, I worked extensively with HIV infection also. In sex workers, sex workers injecting drug users, they are the very vulnerable group for HIV. If you screen them repeatedly, every 6 months you collect their blood and see how many of them are HIV positive, they changes their behavior in that particular community. Similarly, if government make a program kind of thing, so every year it should be tested, and once it is tested, then some information will go to his or her head, that these do and don'ts, this should be done, this should not be done. And at least 50% of them, they change their behavior, at least it will minimize the dust exposure. So that effect. So you want to tell something? Please. So this is, I want to say, one is the government side, one is the community side, one is the individual side. Everybody has to work together, then only it is possible.
Thank you, Dr. Sarkar. Gupta sir, you have touched the right point, as because we are a forum of doctors primarily. So this conjecture and this point made, it has to be taken up by the socio-political people, socio-political milieu, and it exactly is not our cup of tea. So we can just say that unless this is a very big social issue, so diagnosing a case and finding prevalence and all, it is not going to help much as regards the silicosis scenario and upcoming silicosis wave in India is concerned. Still, Dr. Sarkar, thank you for your very illustrative and innovative presentation. Thanks. If there are no more questions, then we will go and conclude the session and break for lunch.
Yes, sir. That was a very productive session. Thank you all for engaging in the productive discussions. So now we will break for the lunch. The lunch is served upstairs in the first floor. And after lunch, we have in this hall a platform presentation for selected abstracts. I think the people who will present, they have already been informed. And after that, we have a very interesting sleep medicine workshop coming up in this hall only. So where you will be able to have a hands-on training on your sleep evaluation and treatment part. So after that, and after lunch in the hall A, we will have the quiz session going on. Thank you, everyone.
পাঁচজন একটু মাথায় রাখ পয়েন্টসগুলো কাগজটা আসছে
Good afternoon, everyone. We'll now begin our presentation session. I would like to call Ms. Orchita to please come and present her talk.
Can I begin? Hello everyone. Good afternoon. I am Orchita Rai. I am a research scholar under Dr. U. Mavali Rajan. I will be talking on the potential role of a DNA repair protein RAD50 in attenuating features of acute lung injury. Acute lung injury is an umbrella term for a lot of inflammatory lung diseases which can range from dyspnea to ARDS, and it involves transepithelial and transendothelial migration of neutrophils, and it is one of the leading cause of death and hospitalization worldwide. So what happens, there is a reduction of the surfactant proteins which is observed, like BP1, F1A and S-Plank1, and these surfactant proteins are regulating the ENaC activity, which is the epithelial sodium channels, and when there is an improper ENaC activity leads to reduced alveolar fluid clearance and edema. Our lab was seeing the role of this protein RAD50, which is a DNA repair protein, and we saw that despite being a DNA repair protein, this protein was constitutively expressed in the mice lung, and it was also seen in the human control lung tissue. So when this protein was knocked down with siRNA, which was administered intranasally, we saw huge neutrophils in the lung. And we also saw that in this RAD50 knockdown mice lung, there was a reduction in this S-Plank. And S-Plank is a surfactant protein, and neutrophils are crucial in lung diseases like acute lung injury. So we hypothesized that RAD50 may have a role in attenuating the features of acute lung injury. So first we developed an acute lung injury model. Like for that we administered LPS to mice intratracheally, and we checked the expression of RAD50. We saw it was reduced. So since RAD50 was reduced in this ALI mice, we wanted to upregulate the RAD50 expression by giving RAD50 plasmid intravenously. And so there were three groups now: control mice, LPS mice, and LPS mice with RAD50 overexpression. So we saw that RAD50 overexpressed ALI mice showed reduced lung parenchymal neutrophils, and there was also a decrease in the thickening of the alveolar walls which were happening due to neutrophil infiltration. So we collected the bile fluid from these mice, and we checked the cells, and we saw that RAD50 overexpressed mice with LPS, they show reduced neutrophils in the bile fluid. We also did the protein estimation, and it was seen to be reduced. Now we checked key inflammatory parameters like IL-6 and this transcription factor NF-kappa B. We saw that RAD50 overexpression in ALI mice inhibits pro-inflammatory signaling. Now we also checked chemotactic factors, and we saw that this RAD50 overexpressed ALI mice had reduced chemotactic factors like IL-17 and CXCL1. Now these chemokines brings about neutrophils, and neutrophils secretes neutrophil elastase. So we checked neutrophil elastase activity, and we saw that in the LPS given mice there was an increase in the neutrophil elastase activity, but when we gave RAD50 plasmid to overexpress RAD50, the neutrophil elastase activity were getting reduced. Now neutrophil elastase, this key parameter can act on various substrates like elastin and also on SPLANK1. This S-Plank1 is getting degraded by neutrophil elastase. So we checked the S-Plank1 activity expression level, and we saw that RAD50 overexpression in ALI mice is increasing the S-Plank1 expression. So what does S-Plank1 do? S-Plank1 is an innate defense protein that can prevent this biofilm formation and also inhibits the improper activity of the epithelial sodium channels, which in turn recovers the airway surface volume, liquid volume, and recovers infection. So all this, from this we conclude here that whenever RAD50 is low, there is a huge neutrophil accumulation. Neutrophil secretes neutrophil elastase, which act on SPLANK1 and degrades SPLANK1. And when SPLANK1 is degraded, then there is improper microbial clearance, improper enough activity, and this leads to edema. So we hypothesize like this, conclude that RAD50 may have a protective role in this acute lung injury, and when we give RAD50 plasmid, we saw these features were getting reduced. So we conclude by saying that RAD50 could be a therapeutic target in neutrophil dominant lung diseases like ARDS. So till now there has been no small molecule for like upregulating RAD50. So in future we want to upregulate RAD50 by using FDA approved drug array and other small molecules. Thank you. Yes, RAD50, we have it's not only in ALI but also in multiple lung diseases. We have shown that we are seeing that RAD50 has a role in maintaining epithelial homeostasis. So like whenever there is any lung injury, especially in like models like ALI, the RAD50 level is reduced. So when we are replenishing this RAD50 level, then these kind of features are getting attenuated. So since we have a lung function machine, from there we check the lung function parameters, and for ALI model we use LPS. And also for other lung injury model, we have other agents like naphthalene is one of the lung injury model that we use. So we mainly work on mice. So we are just trying to mimic the infection with LPS and other agents like naphthalene till now. We have a lung function machine from where we take the elastance, compliance, and we try to see. So this data is not shown here, but we have a machine, it works, which is specially designed for mice. We do tracheotomy and then we take the lung function. Till now, the confounding factors are the downstream parameters that we have along with the lung function machine. We mainly base our studies on the histological and pathological slides that we get. HNE staining and after giving the LPS, there are two models we have right now. One is this LPS model. So after LPS, generally this is a very known model. So after giving LPS, we sacrifice after 24 hours. And if this other lung infection agent like naphthalene, then we sacrifice after 10 days.
And by giving those RAD50, how many days you are observing?
So first we give RAD50 plasmid, and even if we are going for siRNA, we give 2 doses. So first we give the plasmid, and then we try to, after giving 2 doses, then we administer LPS. So after LPS administration, within 24 hours, we sacrifice the mice. This LPS, I think the activity is for 24 hours is the optimum dose. It is worldwide done.
But whatever treatment you are giving by RAD50 or those, so you are observing the mice for 24 hours.
Yes, first we give the plasmid, 2 doses, and then we give the LPS, and then we sacrifice.
And observe for 24 hours.
Yes.
And what are the agents, what are the parameters are you looking for comparison?
The parameters that I have shown in the PPT, we check the lung function, that is one of the parameter, and apart from this, we check for neutrophilia in the HNE slide section, and also the bile fluid protein estimation and the bile fluid cells, and then the downstream parameters like the cytokines and through Western and ELISA.
Can you show your results once again?
Yes.
What is the rationale for only 24 hours?
It is a well accepted, maybe the LPS treatment is the effect is seen after 24 hours very nicely. So most of the papers that we have studied have done it for 24 hours only.
Just show your results.
Yes.
Not the conclusion. So you looked into these parameters, IL.
Yes. We have done. and like we did IL-6 and also the P65 Western blot for NF-kappa B. Yes, we are looking into the inflammatory parameters. Okay, sir.
It is only for neutrophilic inflammation, or it also helpful in eosinophilic?
No, initially we started our studies of the RAD50 study, we started with asthma only, but we have seen that RAD50 have a very predominant role in neutrophilic inflammation. So when we knock down RAD50, a lot of neutrophil related genes are getting upregulated. So majorly we are focusing on the neutrophilic lung inflammatory diseases.
Okay, thank you.
Thank you, sir. Thank you, sir.
Next, I would like to call Ms. Joyitri Dotto to present her talk.
Good afternoon, everyone. My name is Joyitri Datta. I'm working under the guidance of Dr. U. Mabilitajan at CSIR IICB. The topic of my presentation is PD05, a novel neutrophil elastase inhibitor, mitigates features of acute lung injury. So, lower respiratory tract infection is the 4th leading cause of death worldwide. So, acute lung injury or its clinical manifestation ARDS is primarily caused by bacterial or viral infection, and it is manifested as lung inflammation and lung edema. So, coming to the pathophysiology of ARDS, so coming to the pathophysiology, so when there is bacterial or viral infection, so the macrophages get activated and secrete certain cytokines which bring neutrophils to the lungs. So these neutrophils secrete certain cytokines and proteases that break the alveolar and capillary barrier so that protein-rich fluid enters the alveoli, and this causes features of ARDS like breathing difficulty and the need for mechanical ventilation. Neutrophil elastase is an enzyme that is secreted by the neutrophils, and it has some host damaging effects like mucus production, pulmonary edema, and pro-inflammatory cytokine release. So, we have designed a novel neutrophil elastase inhibitor PD05, and compared to the known neutrophil elastase inhibitor civilistat, it is more potent in inhibiting its substrates, and it has got a greater dissociation rate compared to civilistat. So we tested this compound in a acute lung injury mimicking ARDS model, where we administered the mouse with LPS and gave this compound orally and checked its effects. So first we measured the lung function with this machine called Flexiven, which is designed for measuring lung function for small animals, and we found a significant improvement in lung function on giving PD05. We also measured the neutrophil percentage in the bronchoalveolar lavage fluid, and we found a decrease in neutrophil percentage on giving PD05, and we also found an improvement in the immune cell infiltration on giving PD05. So we also checked the status of various pro-inflammatory cytokines, and we found a reduction in the level of various pro-inflammatory cytokines on administration of PD05. Next, we checked the protein content in the bronchoalveolar lavage fluid, and we found a significant reduction in the protein levels. So we can conclude that PD05 decreases the alveolar capillary barrier damage in acute lung injury or ARDS. So we can conclude that on inhibition of neutrophil elastase with PD05, there is a decrease in lung inflammation and pulmonary edema, which eventually improves the lung function.
Please summarize.
Thank you.
Just summarize.
Yes. So, like we found that in... Yes, sir. So this is the concluding slide. So I can explain here. Yes, lipopolysaccharide induced. Yes. So I am using a compound that is a neutrophil elastase inhibitor. So this is a novel compound. No, that is actually she showed a gene that is, yes. So and this is a drug. Yes. So
Otherwise, all parameters are same.
yes. So she showed the role of that gene in acute lung injury, and I'm showing the effect of this compound in acute lung injury. Yes, sir. So this compound has been designed by our lab in collaboration with chemists. Yes, and we also have a published paper on this compound in the context of emphysema. And now we are checking its effect in acute lung injury.
So this is basically a neutrophil elastase inhibitor.
Yes, sir.
And name is phosphodiesterase 5.
No, PD05. The chemists have named it based on its chemical.
Not that phosphodiesterase.
No. So basically it is binding to neutrophil, competitively binding to neutrophil elastase and inhibiting the activity of neutrophil elastase. And when we are testing it in the mouse model of LPS, we are finding a reduction in lung inflammation and pulmonary edema. And there is improvement in the lung function. Yeah, so for lung inflammation, we have checked for these cytokines. TNF alpha, IL-6, IL-8, IL-17. Yes, sir, I'll show. So, this is the machine that we use, Flexivent. This is designed to measure lung function for small animals. So, we found that there is a improvement in lung function when we are administering this. This study is still unpublished, but the emphysema study is published. Emphysema, on pulmonary emphysema, is published. Okay, thank you.
If anyone of the audience have any questions, can ask.
Next, I would like to call Dr. Debranjan Dash to present his work.
Hello. Good morning, sir. So today my topic is a study on pulmonary tuberculosis and iron deficiency anemia in a tertiary care hospital, Odisha. Hello. In 2021, an estimation of 10.8 million people fell ill with TB. So first of all, one is prevalence of iron deficiency anemia in pulmonary TB. Second is about CRP, the inflammatory marker in pulmonary TB. Then coming to metabolism methodology. So I have taken sputum positive pulmonary TB patients and done the required biochemical and pathological tests, and they were statistically analyzed. My sample size is 52. So first inclusion criteria. So I have taken sputum positive pulmonary TB. Those are below 18 years of age. Second is extrapulmonary TB, and the third is those PTB with carcinoma, CKD, diabetes, heart disease, or liver disease. So coming to results, this is just an age and sex-wise distribution. So here the maximum incidence is seen in 20 to 30 years of females, and 50 to 60 years in case of males out of the 52 study participants. Then coming to distribution of sputum microscopy. So in my study, I found out maximum cases of 1+ sputum positivity, which came to around 23 out of 52 participants. Then coming to different sputum microscopy, different parameters, the output of the ANOVA analysis of different parameters and whether there is statistical significance found out in our groups, which we can see that significance p-value is 0.001, and there is statistical significance in the mean, except the parameter transfer in, which p-value came out to 0.552, so which is not significant here on. So next, coming to the descriptive statistics of different parameters, the mean and standard deviation of hemoglobin was 9.23 plus minus 1.89, which ranges around 6.5 to 12.40. And on TLC is around 3,340 to 13,780. CRP range from 18 to 153. Serum iron range from 11.8 to 770. Serum ferritin range from 18.7 to 3,638. And transferrin 3.757 to 5.636. Now coming to neutrophils, maximum neutrophils were around 70 plus minus 2. And for lymphocytes, it also same, lymphocytes were around 28 plus minus 2. The Pearson correlation gives the correlation coefficient between hemoglobin and serum iron with p-value of 0.001, and serum iron transferrin saturation R is equal to 61%, p-value 0.001, gives the strength and directions of relationship between pair of variables. So there is statistical evidence for linear relationship among the some pair of variables. Now come to CRP and sputum microscopy. So the Pearson correlation gave the correlation coefficient between CRP and sputum microscopy 56.7%, p-value 0.001. So it shows that there is linear relationship between pair of variables. So discussion is the same thing. So now coming to conclusion part. In the discussion, main thing is that in the present study, CRP correlated strongly to sputum microscopy. Progressive increase in CRP with decreased severity also suggests its potential as an indicator of clinical outcome of disease and can be used in monitoring treatment efficacy. The correlation coefficient between hemoglobin and was R is equal to 0.064. Anemia has been linked to poor clinical outcome. However, there are no clear guidelines on whether TB patients require iron supplementation. So my conclusion is CRP is associated with more severe disease, and iron deficiency is associated more commonly with sputum positive pulmonary TB and needs to be taken care of. Thank you, sir. Pardon?
You written CRP?
Sir, as per the sputum reports, +1, +2, +3 in the results.
Microbiological reading, what is asking about, how do you correlate with severity with CRP? What are the indicators you have searched for severity?
Okay.
Radiologically, clinically, what are the parameters you have searched for severity?
Actually, that is based on +1, +2, +3, sputum microscopy, on severity. Okay.
Second question, very importantly, we all know in tuberculosis it is usually anemia of chronic disease.
Yes.
So how many patients you have found the anemia due to chronic disease, and in how many patients you have found due to iron deficiency, and how did you differentiate both of them?
So I didn't do that actually.
Okay.
Why ferritin is raised? Any discussion on that?
Maybe because this is an inflammatory condition that might be causing it to rise.
So that's what the question lies. No? In iron deficiency anemia, it should be low.
Yeah.
How will you diagnose iron deficiency?
Microcytic hypochromic is the main thing, I think.
It is one of the criteria, but it's not the specific one. Maybe normocytic.
So ferritin high.
Also other TIPC, those kind of
Total antibody capacity also.
Which stain you used in this study?
ZN
And any culture is done or no, or any drug sensitivity test in TB? This
No,
case?
actually we do that but for this study we didn't do.
Chest X-ray or nothing is?
Because I have taken only sputum positive cases only. So
sputum possibility is microbiological load
Yeah.
you can assess, but the severity should be checked by the
symptoms. Usually we can do CT scan, X-rays. Yeah. According to the opacity, we will see the severity.
Okay, thank you.
Thanks.
I'd like to invite Ms. Anindita Bhattacharya to present her talk.
Hello, good afternoon. I am Anindita Bhattacharya, a PhD scholar under the I'm Anindita Bhattacharya, a PhD scholar under the supervision of Professor Koel Chaudhary at IIT Kharagpur, and today I'll be presenting my work entitled Lung Cancer Risk in Relation to Blood Cholesterol Profile, a meta-analysis of prospective cohort studies. So as we all know, lung cancer is a global health threat and is the leading cause of cancer-associated deaths. And there are several established risk factors for lung cancer, which primarily includes tobacco smoking. But since given the yearly incidence increase of lung cancer and given the fact that prevention is better than cure, the need to identify potential risk factors for lung cancer is well realized. So in this regard, blood cholesterol levels have been long associated with the risk of cancer, but when it comes to lung cancer, epidemiologic research have resulted in inconsistent and inconclusive findings. So this brings us to a research question that what is the actual causal association between blood cholesterol levels and the risk of lung cancer? And to answer it, it needs to be mentioned that generally individuals is a statistical tool that can effectively assess and give us a more reasonable conclusion about the studied association by pooling data from the individual studies. So here our aim is to conduct a meta-analysis that assesses the association between the following blood cholesterol components and lung cancer risk. The blood cholesterol components being total cholesterol, high density lipoprotein cholesterol and low density lipoprotein cholesterol. And for the methodology, we have conducted a thorough database search which includes 4 databases, which includes PubMed, Scopus, Web of Science and Cochrane Library, using relevant and all keywords that are related to the research. So our inclusion criteria had 4 basic cutoffs. That is, the study design has to be a prospective cohort study. The exposure of interest has to be at least one of the selected blood cholesterol components, that is TC, HDLC or LDLC. The outcome of interest must be lung cancer, and number 4, the hazard ratio has been reported with 95% confidence intervals. So from these papers, from the individual data presented by the papers, the HRs of the high versus low categories of blood lipids were extracted and they were adjusted with the highest degree of potential confounders. Next, the homogeneity of the HRs were assessed using the Cochrane's Q statistic and quantified using the I-square method. And when significant heterogeneity was assessed, a random effects model was used to calculate the relative risk with corresponding 95% confidence interval. Otherwise, a fixed effect model was adopted. And further, since the pool data had data of individuals from different geographical location, we further conducted a subgroup analysis for each cholesterol component, but LDLC could not be performed due to limited number of studies based on geographic area, because the samples that we have pooled were from individuals from North America, Europe and Asia. So this is the flow diagram of our study selection. Potentially relevant studies were identified from the databases, and we obtained around 8,000 publications. From that, we excluded those that were not in English, that were not original articles, and those that were irrelevant of our research topic. From that, a full text of 34 was assessed for inclusion, and out of that, 26 did not report either the HRs or were not prospective cohort studies, and finally 8 articles that gave us information about the HRs were included in our studies. Additionally, we searched for references of these articles and got additional 3 articles that reported the HRs with 95% confidence intervals, and ultimately a total of 11 prospective cohort studies were included in our meta-analysis. So coming to the results, we pooled the data of around 20 lakh participants, out of which 21,000 developed lung cancer. So this is the forest plot of the highest versus lowest categories of TC and lung cancer risk. So these individual diamonds represent the HRs of the individual studies, and this line represents the confidence intervals of the individual studies. And this diamond over here is the pooled risk estimates that we have calculated by our meta-analysis. And from here we can see that the relative risk of TC and lung cancer is 0.94 with a confidence interval of 0.85 and 1.04. And since there is 1 coming in the confidence interval, this is not interpreted as a significant result, and so we conclude that there is no significant association of TC and lung cancer risk. Coming to the results of HDLC and lung cancer, here we can see that the pool analysis gives a HR, that is a relative risk of 0.86 with a confidence interval of 0.78 and 0.95, which is a significant inverse association indicating a protective role of HDLC in lung cancer. And for LDLC, we found a HR of 0.97 with a confidence interval of 0.77 and 0.21, again which gives a non-significant association. So further, as I said, I performed subgroup analysis based on geographic area. So here we can see that this is the result for TC. The total result that we obtained, pooling data from 8 different prospective cohort studies, was non-significant. But when we look at the data of Asian population, we found a significant association which is inverse in nature between TC and lung cancer risk. Similarly, for HDLC, the total result was a significant inverse association, but for Asian population, we found that there was no association between HDLC and lung cancer risk. So coming to the conclusion, we could say that there is no significant association between TC and HDLC, but LDLC, but for HDLC, there is a significant inverse association, and which suggests a protective role of HDLC in lung cancer. Thank you.
What made you choose this topic? What is the scientific rationale for choosing only triglycerides? You did a study on total cholesterol and lung cancer, but what was the hypothesis behind choosing this?
Between cholesterol and
Why you chose only cholesterol? You could have chosen any other parameter also, right?
Yes, sir. Actually, we are collecting samples of lung cancer patients, and from there we see that total cholesterol, HDLC as well as LDLC is downregulated in lung cancer as compared to controls. So depending on an epidemiologic study, case control studies have noted that these cholesterol components are inversely related to lung cancer risk. But the problem with case control studies is that they already have cancer.
But was there any other confounding factors like smoking causing dyslipidemia rather than triglycerides being the cause?
Smoking and the possible confounding risk factors like age, BMI, smoking, fat years, etc.
I'll invite Mr. Shubham Ghosh to present his talk.
Good afternoon. I'm Shubham Ghosh. I'm from Institute of Pulmocare and Research. So I have two slides. The first one, I would like to talk about the Th2 distribution in obstructive airway disease. So first, I'd like to introduce the Th2 inflammation in a very short way. Different factors are responsible for the progression of Th cells to Th1 and Th2 respectively. So there are two types of inflammation, Th2 and non-Th2, what we can see. So what we tried to do is we first did a spirometry of the patients having symptomatic OAD. So then we did a spot spirometry to classify them as asthma, COPD and unclassified. So we classified asthma and COPD as GINA and GOLD, but the patients we couldn't categorize into asthma and COPD. We termed them as unclassified. So later on, we did FeNO, AC and IG of those patients to determine the inflammatory status, either Th2 or non-Th2. So we found that patients having high values of FeNO, AC and IG was termed as absolute Th2. On contrary, the patients having low values of AC, IG and FeNO were termed as non-Th2. In order to do so, we found a lot of patients having mixed values, that is either two of them are high or two of them are low. So they were termed as possible Th2 and possible non-Th2. So from the population of 246 patients of obstructive airway disease, we found that absolute Th2 comprises of 54 and non-Th2 comprises of 46. Whereas the majority of population belongs to actually the mixed population, that is, they might be possible Th2 or possible non-Th2. So if we look at the whole population of OAD, we can find that say 22% of Th2 is present and 19% of non-Th2 is present in the population. And if we look this population in a disease-wise manner, that is, if we go via the filter of asthma, COPD unclassified, we can see that asthma is predominating in absolute Th2, while the COPD group is predominant non-Th2. But in case of unclassified, the mixed group is the majority. So in conclusion, I would like to say that in outpatient department, if we can pragmatically determine the Th2 status of the patients, we can give a better treatment to the patients. Thank you. Should I go for the next one, sir? Well, the next one is about glycopyridine responsiveness. So here what we did is, along with salbutamol, we can also do spirometry with glycopyridine. That is, although salbutamol is the predominant bronchodilator to be used in spirometry, but antimuscarinic agent is also present there, so why can't we use that as a bronchodilator? So in order to do so, what we did a normal spirometry. Post salbutamol assessment, we did a glycopyridine assessment. But in order to do so, a question was arised that whether this glycopyridine reversibility is an add-on of salbutamol or not. To rule out this question, to rule out this issue, we did a placebo along with. So placebo was used as a negative control here. So what we did a 48 population in each group. So there are the population. The first one given salbutamol and then placebo. For the second group of population, we give glycopyridine post-placebo. And here are the lung function parameters of both of these groups. But we also did a FEV1 reversibility comparison between these two groups to see whether there is any add-on effect of salbutamol on the glycopyridine. So what we found that there is a significant difference between each of the group. If we go for the whole OAD or the asthma or the COPD or the unclassified, each of the group has a significant difference between the salbutamol post-placebo and salbutamol post-glycopyridine. So from these data, we can say that also we are adding a glycopyrronium post-salbutamol, but the result didn't show a spillover effect of salbutamol. So we can use glycopyrronium as an add-on treatment to salbutamol for checking the reversibility via spirometry. Thank you.
What is the role of glycopyrronium in asthma?
It acts as a LABA, it's an anti-muscarinic agent. So basically, in addition to salbutamol, it can aid the volume of lung, or it can relax the muscles of airway.
Asthma is an inflammatory disorder. And what is the role of glycopyrronium? Is only bronchodilator?
It also can act as an anti-muscarinic agent, in addition to the bronchodilator.
Why you didn't choose ipratropium? Why specifically glycopyrronium? When you
No, we have planned to do for ipratropium also, but this is the initial data. So we have did with glycopyrronium only. So the ipratropium we will also do.
The question is that glycopyrronium, the onset of action, ipratropium, when you are doing the spirometry,
Right.
you are looking for a short-term reversibility. No,
Right.
the agent which will have the fastest onset of action.
Right.
So why did you choose glycopyrronium compared to when we are doing the spirometry? Why we are using salbutamol?
Actually, what I found that glycopyrronium acts after 30 minutes, but its optimum result we can get post 12 to 24 hours. But it starts acting post 30 minutes.
So when you are doing the post-bronchodilator study?
After 30 minutes of salbutamol.
So that may not be optimal.
Yes, that may not be optimal, but for the optimal result, we should do the spirometry 24 hours later. But in our OPD, due to logistic issue, we couldn't do that.
We conclude our platform presentation here. Now I would like to call Dr. Abhishek Kaur to coordinate the next session.
अच्छा आपके पास माउस और पॉइंटर है? पॉइंटर दिख रहा है, माउस है?
পয়েন্টার তো এই তো
হ্যাঁ পয়েন্টার ঠিক আছে, মাউস আছে? মাউস
ডেটা দেবে নাকি?
ঠিক আছে আপনি লাগান এটা।
ওখানে দিয়ে দিতে হবে।
ওখানে দেখি 1 মিনিট এখানে লাগানো জায়গা আছে।
ওয়েট কর।
মাউস পাওয়া যাবে না একটা?
একদম।
মাউস পাওয়া যাবে? হ্যাঁ হবে তো, মাউস পাওয়া যাবে। মাউস
আমি দেখছি স্যার ওটা। We will start the workshop in just 5 minutes. Give us just 5. Okay, so very good afternoon to all of you. Today, as the last session of the Pulmocon 2023, we have made available to you a state-of-the-art sleep workshop where we aim to make you aware of how a patient of sleep apnea or rather any sleep disorder can be approached. So this is a very realistic approach to a patient. We have not included all the theoretical parts that we all know, we have all read in textbooks and all. So our main aim in these 2 hours will be how to approach a patient of sleep disorder or especially sleep breathing disorder, and then how to take the history, how to assess the patient, how to predict, how to use some predictive questionnaires in first, and then based upon those predictive questionnaires, we will go to the sleep study main. So how to choose your sleep study, what level of sleep study should be done, and again after sleep study is done, you get a report from a third party, I hope. So very few sleep labs are available in our state. So I suppose most of you like us get a third party report of a sleep test. So how to interpret that sleep report? So basically these are the few things, and then prescription of the PAP therapy, which we always do. We just write auto PAP or auto CPAP or BiPAP, but how do you know that when to give what? So these are our main aims and agenda of this session. I hope it will be fruitful for all of you, and after going out of this session, you will be able to confidently assess a patient of prospective sleep apnea, able to do the test yourself and interpret the report and confidently prescribe the PAP devices. So without any further delay, let's start it, and we have with us 3 eminent speakers for the session. First is Dr. Shamul Sarkar, sir. He is a consultant pulmonologist at Ranchi, based on Ranchi. His area of interest also includes sleep medicine. So he will start the session with a brief overview of polysomnography and what is it. Then we have Dr. Saurav Das amongst us. He is a renowned somnologist in Kolkata, and he has his own lab, a level 1 sleep study lab. So he will be able to answer most of your questions on how to do a level 1 sleep study, how to hook up a patient, and what. So he has a vast interest and a very high research experience in sleep related subjects. Next we have with us Dr. Khushbu Saxena. She is a dear friend, and she is a consultant pulmonologist at Apollo Hospitals, Bhopal, and she has her keen interest in sleep medicine and has published a number of research papers in sleep medicine. She has also worked in Yashoda Hospitals, Hyderabad, during her post-graduations, and so she is very well versed with the idea of this sleep lab, and she also has recently done her she also got her sleep lab done recently, so she also now has a operating level 1 sleep lab. So with this, and me of course, I am working at Institute of Pulmocare. I have also done my fellowship in sleep medicine from AIMS Bhopal. So I will also be contributing some part of it, but most of it will be covered by these 3. And after that we will go, and after each session, after each talk, we will just have a hands-on session so that you don't forget the things. So we will have 2 hours and we will make most of it. So now I invite Dr. Shamul Sarkar sir to please come on the stage and start the session with overview of polysomnography. Thank you.
Thank you, Dr. Abhishek, for the introduction, kind introduction. And in this workshop session, I will just give an overview of polysomnography. And I think you will be able to decide what are the types of sleep study going on in our field and how you can choose it. So main purpose of this overview is that what are the types of sleep study of different levels we know, level 1, 2, 3, 4, what are the, why these are so much leveling of 1, 2, 3, 4, and how you will decide in your patient which test you will advise. That is an important first part of treating any patients with sleep disorder. Progress. এটা কাজ করবে এটা দিয়ে আগে বাড়ছে না কেন এটা দিয়ে কোনটা প্রগ্রেস হবে বলে দাও ওটা না হলেও তো আচ্ছা ঠিক আছে কর next slide দেখো এখানে করবে না এখানে করে দাও না এখানে করে দাও
কখন আছে না না চেঞ্জ
দাও লেজার
হচ্ছে
এখান থেকে দিয়ে দাও না এখান থেকে প্রগ্রেসটা দিয়ে দাও না এখান থেকে কি করে প্রগ্রেস করবে
এই যে এখান থেকে
কই হচ্ছে এখান থেকে প্রগ্রেস এই তো দাও কোনটা আগে So polysomnography, the test, so the name is self-explanatory. As you can see, as you know, the poly means multiple, somno means sleep, and graphy means recording. So it is actually is a multi-parametric recording, which is done for the study of the sleep, and it is an imperceptible, essential tool in the sleep medicine. And it is also popularly known as the sleep study. Now what actually we do in the sleep study, it provides an objective evaluation of the patient's sleep. Sleep study records multiple parameters. Most important are sleep and neurological parameters are recorded, cardiac parameters, respiratory parameters, and in-lab sleep study also have the facility to have video of the patient throughout the night with an infrared video. And what is the objective of the sleep study? So diagnose a primary sleep disorder, and as we know, primary sleep disorder is not only the sleep-related breathing disorder, which encompasses obstructive sleep apnea, central sleep apnea, and hypoventilation, but it also includes other disorders like central disorder of hypersomnia or hypersomnolence, like narcolepsy with or without cataplexy or primary hypersomnia. There are certain parasomnias like sleepwalking, sleep talking, bruxism, or a number of REM sleep behavior disorders that can be recorded or that can be studied with this. There are a number of sleep stage disorders or circadian rhythm disorders, a number of movement disorders like periodically movement disorders or insomnia. So there are a number of primary sleep disorders, and for diagnosis of these we need polysomnography. It can be done with this only. And in addition to the diagnosis of the primary sleep disorder, many times we need to rule out the underlying sleep disorder in some other medical disorders which are suboptimally controlled, like congestive heart failure when it is suboptimally controlled with the conservative management, or diabetic patients or hypertension patients having a resistant type of hypertension. So these are the certain other medical disorders which may have an underlying sleep disorder, which may result in uncontrol of the primary disease. And in this situation, we need sleep study. So what are the types of sleep study? So this is the main crux of this topic today for me. So as you know, the sleep study, we can divide it in according to the diagnostic utility, like level 1, 2, 3, 4. And level 1 and level 2 are actually with sleep channels. Level 3 is limited diagnostics, no sleep channels. And level 4 is used only for the screening purposes, and that only records the respiratory channels. So these are, according to the diagnostic utility, we classify them as level 1, 2, 3, 4. And within the next few minutes, we'll come across what is level 1, 2, 3, 4, what are the advantages and disadvantages. Now, sleep studies can also be classified as according to the location of the study, that is in-lab sleep study or home sleep study. In-lab sleep study is considered to be the gold standard, and it is used for diagnostic, titration, split night study, and also it includes the multiple sleep latency test in specific situations. And all are, you see, all are in level 1, and which are considered the gold standard test. And there is another home sleep study that can be done at home situations or in some nursing homes or in a hospital, personal rooms or like that. So again, home sleep study is popularly known. It is also can be done with the help of level 1. Level 1 I included here because level 1 and level 2 are almost the same parameters are recorded here, but you can arrange in a particular patient's room with an attendant there full night and all the facilities which are in lab, then it can be considered as level 1, but it can be done in the home sleep study. But usually the same parameters are recorded with the same machines with no attendant or no technician at the field, and then it is considered as the level 2. So diagnostic purpose, level 1 and level 2 can be done with attended and unattended. And on a limited diagnostic level, that is level 3, and screening, these are unattended, which can also be done in the home sleep study. So all the levels can also arranged in the home, and then it will called as home sleep study. So what are the basic differences between all these levels? Level 1, 2, 3, 4. So starts from the level 4. It records on the respiratory parameters, that is the respiratory airflow, as you can see here, respiratory airflow, oxygen saturation, which also records the pulse, respiratory efforts. Only these respiratory parameters are recorded in the portable device screening in the level 4. And actually, this is the level 4. So used only for the screening purposes. And actually, none of the pulmonologists advise this modality of that sleep study testing. The next one, if we add recording of the snoring, recording of the position of the patient during sleep, and ECG recording, then respiratory parameters in addition to recording of the position and ECG, then it comes to the limited diagnostic testing level 3, which is actually known as called as the polygraphy. So you can see here the difference in the name. One is polysomnography, it is only said polygraphy. So it is level 3. And this is the level 3. So these are the attachment, basically respiratory flow. There is also a recommendation for the use of the oral thermistor. And these are the thoracic and abdominal belts, which records the respiratory efforts. And there is pulse oximetry, which records SpO2 as well as the pulse rate. And it is arranged in the home situations or patient's own home. So this is level 3. And this is the sleep parameters. If we add EEG, electroencephalography for the recording of the sleep, and neurological parameters, and EOG, electrooculography, right and left, electroocography, and electromyography. Chin electromyography is most commonly used, and if you suspect periodic limb movements, you also add limb EMG. So when you add EEG, EOG, and EMG channels, so these are basically the sleep channels, and then everything is included in the polysomnography or the diagnosis, which is considered to be the gold standard. And also the in-lab polysomnography has the facility of infrared videography. So this is the situations of level 1 polysomnography. As you can see here, that there is a very comfortable room arranged here, and that mimics the home situation with all facilities. But the most important is that there is a control room, there is a very well-trained, dedicated attendants or sleep technicians, which play the main role here, how he does the attachments here. So there are the EEG channels, there is EOG channels, there is the EMG channels you can see here, in addition to respiratory and the cardiac channels. But the most important is this attendant, who plays the most important role. He not only hook up, but also he continuously monitored throughout the night. So a very well-trained and dedicated sleep technician has an immense role in doing this in-lab polysomnography. So these are the spatial attachment which differentiate level 1 and level 2 from level 3, 4, that is EEG, EOG, and CNEMG. So these are basically needed for sleep staging, as well as also diagnosing the microarousals. And these are the attachment airflow, SpO2, chest and abdominal movements for identifying respiratory events and classifying severity of the sleep-respiratory disorders. And these are the EMG channels, limb EMG, as well as the chin EMG, to identify the periodic limb movement disorders, and ECG channels are for the identification of the heart rate and different types of heart rhythms. So here in this chart you can see the difference of polysomnography and polygraphy. So in polygraphy, actually, oronasal thermal flow and pressure sensors, pulse and occipit, SpO2 monitoring sensors, position sensors, respiratory efforts. So these are common in both level 1 and level 3. But others are not present in level 3. So what are the basic difference between level 1 and level 2? So level 1 has attended and actively supervised, level 2 is not. And in level 2, there is no video options and end-tidal carbon dioxide monitoring. So these three important parameters are difference of between level 1 and level 3. Otherwise, the level 2 is same as the level 1. It gives all the recording of all the parameters, excepting that it is in the out of lab situation and unattended. This is the difference of strength of polysomnography and polygraphy. As you can see here, obstructive apnea, central apnea, these are scored both by the level 1 and level 3. But hypopnea is partially recorded in level 3. Why? Because no EEG recording is there. So hypopnea which are diagnosed with arousal, so that cannot be recorded with level 3. Similarly, respiratory event-related arousal or RERA, these cannot be recorded with level 3 because there is no EEG, so no arousal scoring can be done. So these are the most important differences which can give rise to underestimation of the obstructive events. Periodic limb movements, hypoventilation, and parasomnias. So these are the important accessories or facilities which are available in the sleep lab polysomnography. So this is the basically difference between the level 1 and level 3. So what are the advantages if you combine together, and we know that level 3 is most popular in the medical field. Level 3 study is most popular amongst the doctors as well as amongst the patient because of it has several advantages. Number one is it is simple, less technical skill and labor intensive. Setup and validation time is considerably less. It has increased access to testing and also most importantly decreased cost of the study. And another most important thing is that it can be used at patient home in a familiar environment, avoiding first night effect. So it is a very inhibitory factor for the patient to come to the sleep lab to spend whole night. And if think it is a female or elderly female, then someone has to accompany them. Some person has to accompany them. And patient usually try to avoid to come to the sleep labs or for the medical test because they don't feel themselves ill in that sense, why to be hospitalized. And definitely if it is a distance, sleep lab is from a distance of their home, so it needs communication and convenience. So there are a lot of disadvantages regarding when a patient is asked to come to the sleep lab for the test, other than these technical differences. So these are the advantages. Definitely it is simple. Patient himself can hook up this small machine, and for hookupping it takes little times, 10 minutes. Within 10 minutes you can finish the attachment, and this is the most important. Last one is the most important factor for the patient, favorable for the patients. And what are the advantages of polysomnography? On the other hand, polysomnography allows for the accurate physiological measurement of the sleep and its distribution. So specific clinical endpoints such as sleep onset, sleep latency, REM latency, which all can be calculated only with the polysomnography, which are essential for diagnosis of specific types of the sleep disorders. And another important is less chance of data loss here. So you can see this is an example of the sleep reports. So these are the sleep summary. So these are the sleep part. So what is the total recording time? What is the wake period, wake after sleep onset, total sleep time, sleep latency or sleep onset, and number of awakening, different stages. So all are very important to know about the sleep study. So EEG data gives us what is the sleep efficiency of the patient. What is the sleep latency? Sleep latency is very important parameter. Less than 30 minutes or REM latency 60 to 120, it is the normal. If sleep latency is very small, it indicates certain diseases. If the sleep latency long, it indicates particularly some other diseases. So overall, whether the patient is sleeping or not, so what is the overall sleep efficiency? We have to know this. Secondly, we have to know the sleep stages and the sleep architecture. As you know, the sleep is divided in non-REM and REM part. Non-REM again have 3 stages, N1, 2, 3, 4. This is non-normal. N1 5%, N2 50%, N3 comprises 20% of the total sleep time. And slow wave sleep is the most important stage of the sleep. And we can have an idea whether the patient has slow wave sleep or not. That it has important relation with the cognitive behavioral abnormalities the patient might have. And REM sleep, 20 to 25%. So each and every sleep stages has its important advantage, so which can be known only with the help of the polysomnography. Then arousal index. EEG abnormalities may also detect epileptiform activity or alpha intrusion into this. So these are the abnormalities which can only be detected with the help of the EEG data. REM-H, this is another important thing. So we can have an idea whether the obstructive events are coming predominantly in the non-REM phase or the REM phase. This has an important clinical implications. If the patient has REM predominant obstructive sleep apnea, so it has a worse or very bad clinical implications. So we can have idea with REM or non-REM. We cannot have this idea with the level 3. Arousal index, so we need to know what is the arousal index. And also not only that, arousal what for? Whether it is spontaneous arousal, whether it is because of the desaturation arousal, whether it is due to the periodic limb movement arousal. So we have to know the cause, number of the total arousals, and that has an important implication for the fragmentation of the sleep. That has an important implication for the patient having excessive daytime sleepiness, which in turn have an important clinical importance for the development of complications, particularly cardiovascular complications. So each and every parameter is important clinical implication. Similarly, periodic limb movement disorder. Limb movements can only be detected with the level 1. So all these things, EEG data, arousal index, the structures of the sleep, the periodic limb movements, etc., each and every part can only be detected with the help of the EEG, EOG, and EMG channels, which can only be used in the in-labs. That is level 1. That's why the level 1 is considered as the gold standard. Still, is there any utility for the level 3? Yes, there are certain indications of the unattended portable monitoring, that is home sleep apnea test, which we must know. If the patient your patient has a high pretest probability of moderate to severe OSA, so only in this group of the patient you can advise for level 3. So if during clinical examination you identify that the patient has high probability of moderate to severe OSA, but that not only that suffices, but the patient must not be associated with abnormal comorbid conditions. Like that, patients should not have significant cardiac problems or significant pulmonary disease or significant neuromuscular conditions which results in potential respiratory muscle weakness, or there is history of stroke or chronic opiate medication use. So these are the medical conditions which can give rise to certain other abnormalities like central sleep apnea or severe nocturnal or hypoventilation and desaturation or hypoxia, which can only be detected in the level 1 study. That's why patients should not be associated with these medical conditions. Thirdly, the patient should not have any other non-respiratory sleep disorder. Non-respiratory sleep disorder means central sleep apnea, narcolepsy, periodic limb movement disorder, parasomnia, circadian rhythm sleep disorders, or even severe insomnia. So patients should not have these non-respiratory sleep disorders. So only in patients with moderate to severe OSA is not enough. So comorbidities and presence of other sleep disorder has to be sorted out during history taking. So that is the importance of history taking in these patients. Patient who cannot have polysomnography, that is patient cannot go to the sleep lab because of immobility or safety reason or because of critical illness, but you suspect that the patient is having associated some sleep disorders. In those cases, you can opt for the level 3 or home sleep apnea test. Unattended portable monitoring may be used to monitor response to non-PAP treatment. Suppose the patient are using some other forms of treatment, not the CPAPs, oral appliances, surgery, or weight loss. In that situation, this unattended polysomnography can be done at home. So these are the special indications for the level 3 study. So what it means that an increased risk of moderate to severe OSA. So usually we identify them. The presence of excessive daytime sleepiness is a must, and at least 2 of these following 3 criteria, that is habitual loud snoring, witnessed apnea or gasping or choking, or diagnosed hypertension, particularly even if any hypertension or taking treatment for the hypertension. So these are the criteria. So you can easily sort out from this stop bank questionnaires used. You can use it at your clinic here. So first four, that is A stands for snoring, T for tiredness or excessive daytime sleepiness, O for observed apnea or choking during sleep, usually observed by the sleep partner, and presence of high blood pressure. So if you remember only the stop, that is STOP, which stands for all these four criteria. So if the patient has excessive daytime sleepiness and any two of these falling, that gives the patient has the patient has a high chance of moderate to severe ASA. So you can identify. So you will come across these questionnaires in detail in the next sessions. So what are the indications of polysomnography? So polysomnography is strongly indicated, as you come to know already, you have assessed that if the patient has existing cardiac problem, pulmonary, cerebrovascular, neuromuscular, or metabolic disorder, or if the patient has sleep or awake hypoventilation, that is low SpO2 or high PCO2, or chronic use of neuropsychiatric medicine. Patient have some neuropsychiatric problems or taking medicines for insomnia or depressions and some other sleep disorders. So these are the indications of polysomnography, in-lab polysomnography. And avoid level 3 sleep study in all these situations. And another important is pediatric population, level 3 study is not validated at all. But I would like to just give you American Academy of Sleep Medicine guideline. I have given some input here, but it will be more strengthening your identification or take home message in that form. So first thing is diagnostic testing for OSA should be performed in conjunction with comprehensive sleep evaluation. So don't go straightly to advise the sleep study. So comprehensive sleep evaluation is very essential, which includes a detailed, thorough sleep history taking, use of questionnaires to have an idea about the risk probability, and physical examination includes, which includes assessment of the body habitus, anthropometric measurement, and examination of the ear, nose, throat, and detailed examination of the respiratory, cardiovascular, neurological system. So this is the 2018 American Academy of Sleep Medicine guideline regarding obstructive sleep apnea. The same thing we have discussed here, that OSA can only be diagnosed by polysomnography. Questionnaires are not sufficient for the diagnosis. Polysomnography should be done in place of home sleep test for patients with cardiovascular disease, respiratory disease, neuromuscular conditions, stroke, because these may give rise to nighttime desaturation. If home sleep apnea test do not detect OSA in individual patient with formidable risk of OSA, polysomnography must be done. Split night polysomnography, that is both diagnostic and titration part in the same night, may be used in high probability of OSA patient and the subsequent criteria. These are the criteria given. If AHI is more than 40 for minimum of 2 hours, initial 2 hours, then CPAP titration is done for the minimum of 3 hours, and polysomnography demonstrates that CPAP has abolished OSA. And if the first polysomnography, even if do the level 1 study, if the first polysomnography fails to detect OSA, subsequent polysomnography can be repeated if OSA is suspected. See, these are the indications of ASM regarding obstructive OSA. Another indication like patient with cardiac failure. So this part is mostly neglected by both of us, pulmonologist as well as the cardiologist, but it is very important. Patients with cardiac failure, both systolic and diastolic, with nocturnal symptoms or insignificant improvement despite optimal medical therapy should undergo polysomnography test. Patients with coronary artery disease or cerebrovascular disease or arrhythmia should be evaluated with polysomnography if symptom signs for OSA is present. Titration of CPAP always done in lab, best done in the in-lab test, and also pre-procedure testing done in the level 1 study. There are certain situations where you can have, you need a repeat polysomnography test, particularly if the patient is taking some oromandibular devices or patient have some other operations for the surgery. In that situation, to know the result of the modalities of the treatment, you can have to do the polysomnography here. Or even in individual who have substantial alteration in the body weight, 10% gain or loss, then to regulate CPAP pressure setting, you can have to repeat the test. So what are the limitations of less dialysis? So these are the things which we must remember. The limitation of the level 3 or polygraphy. There may be accidental removal of the channels while sleeping. That can give wrong interpretation because there is no attendant there. Nobody is watching. Your attendant or your technician has gone to the patient's room. They've hooked up the level 3 parameters and again come up and go into the morning to just disassemble these machines. So during the night, what was the condition of the patient? Nobody knows. So what are the attachments there? Nobody knows. So EEG, particularly nasal pressure channels, or the patient is using thermistor, or the patient is using the oximeter, or the bells, everything can be disturbed. So removal of the nasal cannula can be interpreted as obstructive sleep apnea, as there is no airflow is detected by the machine. Similarly, misalignment of the chest belt can be interpreted as the central sleep apnea because no respiratory effort is there. Removal of the oxygen probe, there will be loss of important data. So these are the disalignment or of the channels can give rise to wrong report. Similarly, level 3 equipment does not measure the sleep. It calculates the time between the machine on and the machine off. That is the total recording time. The level 3 does not record the total sleep time, which is the very essential to assess all the parameters. So you want to know the sleep time and what is the character of the sleeps and the other parameters, respiratory, cardiovascular events occurring during the sleep time, not during the recording time. So AHI, and what is AHI? Whether RDI, that is apnea hypopnea index and respiratory disturbance index. These are actually total respiratory event per total sleep time per hour of sleep times. But it records the total recording time, not the sleep time. So it is their calculation of the AHI and respiratory disturbance is inaccurate. There is underestimation, and that's why it is not the new recommendation tell that this is respiratory event index. This should be called respiratory event index, not AHI or RDI. Thirdly, another important is level 3 cannot diagnose upper airway resistance syndrome, cannot diagnose mild OSA. It can diagnose moderate or severe, but cannot diagnose upper resistance syndrome or mild OSA. It cannot diagnose obesity, hypoventilation, as well as repeatedly I have said, these are the other sleep disorder which cannot be diagnosed by the level 3. So these are the main limitations. So here is an example of the sleep report. Suppose here is a sleep report, obstructive, central, mixed, and hypopnea. Here the patient has AHI 22. AHI 22. Patient's total recording time is 329. Total sleep time is 128 minutes. So these are the important parameters. So level 3 study we diagnose like this. Apnea hypopnea index, actually the respiratory events occurring per hour of sleep. So here the level 3 will study instead of total sleep time, it will use total recording time. So here this obstructive event is 22 divided by total recording time 329 into 60, that is AHI will be calculated as 4. So we know that AHI up to 5 is normal. So 4 is normal in that sense. But you use the same parameter when you use in lab sleep study level 1. So here the AHI will be 22 divided by the sleep time, that is 128, and the AHI will be 10.3. It will come in the category of moderate degree of the OSA. So this is the basic difference. And level 1 also give you a diagnosis of RERA, that is respiratory event related arousals. Here the RERA index is 4.6. So AHI 10.3 plus RERA 4.6, so actually respiratory disturbance index will come to 14.9. So level 1 study also identify whether REM or non-REM events are there. So here the majority of the events are occurring in the REM. So REM AHI is 20.7. non-REM HI is only 7.3. So it gives a gross difference in the same study, gross difference in the interpretation. So a normal sleep study as diagnosed by the level 3 comes to be a moderate OSA, again with a REM stage predominant, which has a serious consequences. So these are the differences of interpreting the same sleep study from the level 3 and level 1. So obstructive sleep apnea is rarely an isolated upper airway disorder. It has a number of complications with which the patient may come, a number of medical complications, a number of other sleep associated disorders. Chances of missing diagnosis and underdiagnosis are high with polygraphy, that is home sleep apnea test, particularly level 3 test. AHI, which is used most commonly for the diagnosis as well as the severity grading of the obstructive sleep apnea. So that AHI and the lowest saturation of the oxygen represent on the tip of the iceberg. Because we know that, come to know that arousals and sleep fragmentations are equally important in the development of serious metabolic disturbances. So unattended level 2, that is the level 1 machines at home without attendant can lead to serious loss of diagnostic data. So level 2 also have no importance here. And lastly, auto scoring and auto interpretation of the study, as we do in case of ECG, in case of Holter monitoring, in the CT MRI, CT scan or MRI, as well as same as the sleep study is strictly no. So auto scoring given by the computer or is computerized reporting many times is having a fallacy. So you, whenever you are deciding to practice sleep medicines or diagnosing the sleep disorder breathing, you must know the proper diagnosis and proper interpretation of the sleep study by yourself. So these are the things we wanted to discuss here and wanted to highlight here. So thank you very much.
Okay, so that was a rather comprehensive view of polysomnography, I would rather say. So next we move on to the predictive questionnaires. So we have to rush a little bit because we are less on time. Okay, so most of the things have been said by sir, so it has made my work a little bit easier. So next we will just discuss the pre-test assessment of these patients. So as sir told, we need to have a detailed history of sleep related problems. We should hear about the complaints to the patient patiently, because many a times we just hear that snoring is there, so we conclude that he may be having OSA, so we go for a sleep study directly. But a detailed history gives a lot of hints towards the what type of sleep problems he is having, whether it is an insomnia or whether it is hypersomnia. Then the things that should be taken into care are demographics of the patient. The snoring history should be taken also from the bed partner. The witnessed apneas history should be taken from the bed partner. Daytime somnolence history, insomnia, fatigue, underfreshing sleep, morning headache, nocturia. Actually this history is to be elicited from the patient. Many times they complain vague complaints like fatigue and headache and all, so you don't make up that it is a OSA. So in that case, nocturia is a very prominent symptom in some cases of OSA, and it should not be missed by a clinician. Then there are some cognitive and behavioral symptoms as well. Any sign of potential respiratory muscle weakness due to neuromuscular condition, and any history of stroke. If nothing is found, then OSA should be evaluated in these patients who have suffered stroke. Comorbid conditions that should be taken care of are hypertension, diabetes, hypothyroidism, Ischemic heart disease, arrhythmia and heart failure are the three important parts where every cardiac patient should be evaluated, because arrhythmia is very common in cases of unattended sleep apnea. Heart failure patients tend to have central sleep apnea most of the times. So for the better management of their heart failure and to address the central sleep apnea also, these patients must be evaluated, and if needed, CPAP can be given. Psychiatric disorders and patients of obstructive airway disorders, many a times asthma has a good correlation of the patients with OSA. So obese patients who are asthmatic, they must be evaluated for OSA as well. So we must also inquire about the medications, the sleeping pills, the antipsychotics they are taking, inhalers and anti-allergic medications. Many a times these medications induce sleep, so the patient have complaints of daytime sleepiness. Other than that, chronic opioid medication use should also be taken care of. Excuse me. Systemic examination which are relevant to OSA are Malam patti grading, macroglossia and mandibular position and size. So the Malam patti score, we all know, it is performed with the patient sitting in a Fowler's position with mouth open, and the score is based on the amount of visible space in the oropharynx, which is classified into 4 grades. So class 3 and class 4 Malam patti grading have a high probability of having sleep apnea. Then macroglossia, how do you find out? You just ask the patient to protrude their tongue, and if you see that dental marks on the tongue, then they are having macroglossia. And retrognathia and hypognathia, these are the two conditions where the patient may not have these are the two conditions where the patient may not have excessive daytime sleepiness, but they should be evaluated for having sleep apnea. Now measure. These are the three things, a few things which should be measured in a patient. Those are height, weight, we have to calculate the BMI, the waist circumference, which is measured at the level of the midpoint between the top of the iliac crest and the lower margin of the last palpable rib in the mid-axillary line. So neck circumference should be measured at the level of the cricothyroid membrane using a measuring tape, and vitals should always be measured in a patient of sleep apnea. Blood investigations are basic investigations. Lipid profile and thyroid profile should be kept in mind because hypothyroidism also predisposed to OSA. Chest X-ray PA view should be taken into account. Echocardiography, basic echocardiography to look for any signs of heart failure, and spirometry should be done to rule out any COPD or asthma patient, COPD patients specifically, because COPD patients have a different type of OSA. I mean, they have a high probability of having OSA, and their titration is also very difficult because some of them may need supplemental oxygen along with the PAP devices. Now coming to the predictive questionnaires part, there are few well-known predictive questionnaires. First of all, I will like to highlight it as a Berlin questionnaire. It is one of the most, one of the oldest. So here we have 10 questions along with a BMI. So the scoring is slight different. There is the category 1 is positive with 2 or more positive responses to questions 2 and 6. So the positive responses are those only which are marked in, in box. Like if you are snoring, the positive response is yes. Your snoring is, if it is louder than talking or very loud, then only it is a positive finding. So it is a bit of confusional questionnaire. It was first introduced. So his sensitivity and specificity is both are low. Then came the stop and bang questionnaire. So initially the stop questionnaire was there where 4 questions were to be asked. Then the bang part is the examination part, which was this was introduced by the anesthesiologists, and this questionnaire, the sensitivity of this questionnaire is high in picking up mild to moderate to severe OSA. It was initially used as a pre-operative assessment for patients having sleep apnea, because in cases of sleep apnea, the patient's high risk consent should be taken for general anesthesia and all. So high risk of OSA, if the score is 5 to 8, intermediate risk is 3 to 4, and less than 2, the score, there is a low risk of OSA. Then another questionnaire is Epworth Sleepiness Scale. It is basically a scale which measures excessive daytime sleepiness. So in this questionnaire, there are a series of questions, rather instances, where the patient is likely to fall asleep. If the score for each question is 0 to 3, so the patient has to give a score to himself of how probable he or she is to fall asleep in these situations. This questionnaire only measures daytime sleepiness. It does not mean that the patient has OSA only. It can be any hypersomnolence disorders. Patient can also have sleep deficit. So this questionnaire is only for excessive daytime sleepiness. Next, new questionnaire which was introduced by AASM was GOAL. The GOAL questionnaire contains 4 yes or no questions, 1 point for each affirmative answer, mainly male sex, BMI more than equal to 30, age more than 50 years, and loud snoring, and each parameter is categorically scored as negative if 0 or 1 positive. Score of more than equal to 2 indicate the individual at high risk of OSA. This has got little significance. Then there is ASM given criteria for assessment of patients for OSA. So they told that if the patient has excessive daytime sleepiness, along with it, if the patient has snoring, apnea or choking or hypertension. So excessive daytime sleepiness plus 2 of any of the last 3, like snoring, apnea or hypertension, then the patient is highly probable for having moderate to severe OSA. So if we look into this, there have been a few landmark studies where they have shown that the 4 questionnaires, ESS, Berlin, STOP and STOP Bang. If you can see, please note that the sensitivity of these tests are around 72% for ESS, 95% for Berlin, 91% for STOP and 97% for STOP Bang, whereas the specificity is low. So this means that these all questionnaires are good for screening tool and not for confirmation of sleep apnea. And this is for any type of sleep apnea. If we look into prediction of moderate to severe OSA, then also the sensitivity is very high, but the specificity is very, very low. So this also indicates that this is a very good screening tool, but not confirmatory. Then came a new questionnaire, which was the NOSAS questionnaire. It made somewhat sense because it has a few points. It is more like the Wells score for thromboembolism. So neck circumference at the highest points of 4, BMI has a point of 3, and BMI if more than 30, it has a point of 5, snoring has a point of 2, age more than 55 years has points of 4, and sex is male has a point of 2. So if you you assess the patient's points, and then you to have the total score. A threshold of 8 at NOSA score has been suggested to discriminate patients at high risk of OSA. A recent study published in 2023 also concluded that NOSA score of more than 8 has a high specificity of 88% in predicting hypoxemia during sedation. This study was published in an anesthesiology journal, so they were more concerned with hypoxemia during sedation of the patient, but still when the patient is sedated or asleep, both will have a hypoxemia part. So this is a good questionnaire. Using a NOSA score of more than 7 to predict OSA, the sensitivity and specificity in other studies were 85 and 50. So this was somewhat more than the other ones which were there. So if we look at all the 4 criterias, if you see that the ASM criteria of excessive daytime sleepiness, snoring, choking and hypertension, then goal criteria, stop bank criteria, and NOSAS criteria. You see that if in AHI more than equal to 5, the sensitivity and specificity of NOSAS was greater than all of them. The goal criteria was also somewhat near to them. Then so gradually as the AHI is increasing, the sensitivity and specificity, the sensitivity is improving and specificity is also improving. So this is the same part here, that this is from the excessive daytime sleepiness. S means snoring, A means apnea, and H means hypertension. So combining all the parameters, they did a study and tried to assess the sensitivity and specificity. It also shows that when AHI, the grade is in severe OSA, then the sensitivity and specificity is good. So this is all, and next I would like to invite Dr. Saurabh Das to proceed further.
A very good afternoon, everyone, and thank you, dear Abhishek, for inviting me here. And I must thank Dr. Sarkar, first of all, for being very much inclusive. Just hold on a second. Okay, so for being very much inclusive in his lecture and discussing about a lot of things over polysomnography, and it made my job a lot simpler because most of what I was going to talk about has already been covered. So I understand that it has been a lot of sensory overload for the audience here. So I would try to make things very simple, just like a workshop model we have to think at this point. Let's just, okay, so basically by this time we have understood why my screen is not showing. Excuse me, hello, it's not showing in the computer. Yes, thank you. Yes, okay. So basically now we realize that there is something called polysomnography, a test which finds out how the person is sleeping, right? And it also tries to find out if there are any sleep disorders. So that is polysomnography. By this time we know about the various levels of that. Now to understand sleep medicine, we have to first be aware that there are almost 100 different types of sleep disorders, right? Among those, as pulmonologists, we mostly deal with and focus on the group called sleep-related breathing disorder, okay? Now this sleep-related breathing disorder itself has multiple different types of diseases. Among those, the superstar is obstructive sleep apnea or OSA, right? For adults as well as pediatric population. So now, suppose as a practicing clinician, you sit in your clinic and you see that a person has come who is kind of obese, has a history of snoring, maybe his bed partner complains that there are pauses in his or her breath, and they have excessive daytime sleepiness in the daytime, they feel fatigued, they have problems with cognition and memory. So you think that, okay, this person may have obstructive sleep apnea or OSA. So how do we proceed with that, right? So of course, by this time we are aware of various terms and various things. Just keep this in mind that when such kind of a patient comes, we have to think in two levels. First level is screening, the second level is diagnosis. Now in the first level, when we are talking about screening, Abhishek has very nicely elaborated about various different screening tools that we have. Of those, two most important are, number one, stop bank questionnaire, and number two, Epworth sleepiness scale. Now Epworth sleepiness scale is not specific for OSA at all, it is specific for daytime sleepiness. So whatever may be the underlying cause, if a person is sleeping 4 hours in the night and working for the rest 20 hours in the day, he will have a positive Epworth score, right? But stop bank questionnaire is relatively or rather decently sensitive as well as specific to detect obstructive sleep apnea. So these two are the screening tools which can be very easily done. It can be given to the patient for self-filling up in the waiting room while he's waiting for the consultation, or maybe just after the consultation. And another screening tool that we have is level 4 device, level 4 polysomnography, which measures either the nasal airflow or the pulse oximeter. There are few devices which can actually measure both of them. So all these, the screening tools. They are for the screening tools like level 4 polysomnography and or the various questionnaire methods. Now coming to the proper testing. Okay, now when we try to confirm whether the person is having an obstructive sleep apnea or not, or any other sleep disorder or not, we have at our disposal level 1, 2 and 3 types of polysomnography. If you think about level 3 polysomnography, on top of, like in level 3 we measure only the cardiopulmonary system. We measure the airflow, we measure the respiratory effort, we measure the oxygen saturation and the pulse rate. There are newer devices coming up which also measures the body position, right? There is nothing with the brain or mind at all. So these 4 things, they are very simple. Is that device available? Okay, now let's just see how simple it is and how easily we can hook it up, right? Just to have a fair idea. Right now we are using one level 3 device. We have our very good patient who will sit. Thank you. Yeah, so now he's putting the belt. Okay, usually in level 3 devices there is only one belt which is put on the chest, not on the abdomen, right? So okay, he'll be putting the belt, and he will also be putting a cannula in the nose, which is a single cannula which can measure the airflow, okay, by means of any changes in the airflow pressure. It can also measure snoring, right? And also he will be putting one part of the device on the fingertip which will measure the pulse rate as well as the oxygen saturation. This is a very simple device. In real world clinical practice, almost 85% of the suspected patients of OSA can be dealt with by using this device alone. It's a very simple, portable, cost-effective device, easier to do, more importantly, easier to read the report, right? I'll come to that in a while. So this is a very simple device which can be used in most of the cases, but you have to use a screening tool first. Like the person needs to have a high probability of OSA technically, like the person has a high score on stop bank questionnaire, high score on Epworth scale, or the person has been screened to be positive in terms of a level 4 device. So there is a high risk of obstructive sleep apnea, number 1. Number 2, the person does not have other conditions, like for example, as Dr. Sarkar has mentioned, like cerebrovascular accident or CVA patient, or any other, say, COPD patient, or say the person is having uncontrolled hypertension. If these conditions are not present and the high probability of OSA is present, we use this device. Very simple and cost effective. So how does the report look like? I would request Dr. Deepan to show the report. I think it's a small gathering, everyone can see what is going on. We can just focus on, okay, this is a different computer. Okay. Okay, so we can see two different brands, level 3 devices. Both are, I would say, equipotent to detect all the things. No, the companies are different. Sir, the companies are different. Like you can think of, one is Complan, the other is Horlicks. Okay, same thing, but in different brands. Yes, correct. There is no difference in these two devices. They are equally same in every aspect. The only thing is that the companies is different. But anyways, both are equally effective, right? So now suppose now how do we look into the report? Okay, so I'll be clubbing my two lectures together so that it's easier to comprehend. Now with this particular say this device that has been done, now we send the device to the patient's home. No, you sit here. And the device is sent to the patient's home. The next morning the device is collected. It is usually not supervised. Now there is a chip inside the device which is used to gather the data and generate the report. How does the report look like? I would request this computer to be shown on the screen, please. Hello, excuse me, can you show this computer? Yeah, so this is, let's just skip the first page. So this is what the data that these kind of devices generate, okay. So basically, what do we look for? We look for the patient identification. We look for the date of recording. Okay, this is very important. The date of recording, and more importantly, the duration of recording. Okay, you can see here it is 8 hours 23 minutes, and the duration of evaluation. This is very, very important. 8 hours and 5 minutes. Okay, so like as Dr. Sarkar was mentioning earlier, like we need at least 4 hours of recording to conclusively say that the study is valid. If it is less than 4 hours, the study is invalid straight away. So here you can see there is more than 4 hours, so the study is apparently valid. We also look at the height, weight and BMI of the patient just to have an idea, because we are not seeing the patient in our lab, so we need to have this idea about how does this patient's BMI is. The first thing that we need to look at, and the report ensures that we look at, is the AHI, the apnea-hypopnea index, which is 45 in this particular patient. So now there is a classification, like if there is less than 5, it is considered normal. If there is less than, is between 5 to 15, it's mild obstructive sleep apnea. Between 15 to 30, it's moderate obstructive sleep apnea. If it is more than 30, then it is severe obstructive sleep apnea. So just at a glance, we know that this person is having a severe obstructive sleep apnea in a valid level 3 study. Now we look into the more specific things. For example, this AHI of 45, what does it comprise of, or how it is, how does it become 45? What are its ingredients, so as to say? Now we look into, we come here in the report, we see that there is the obstructive apnea index is 37.7. So out of these 45 total number of obstructive events, 37.7 events per hour were due to obstruction, like obstructive sleep apnea. Now there is very less amount of mixed apneic index, like 0.4, and a little bit of central apneic index. So the person is predominantly having obstructive sleep apnea. Now again, we need to know a little bit of theory, that if in this result of 45 AHI, like AHI events per hour, if it would have been more than 22.5, have been comprising only of central apnea or hypopnea, then we would have classified this patient as that of a central apnea, not as an obstructive sleep apnea, right? So here we can see that this patient is having obstructive sleep apnea. By this, we are more or less happy that, okay, now we have diagnosed the person. Now, what more do we need to look at? So we need to look at the oxygen desaturation index. This is a very important marker. Why? Because it's a like non-monitored study, we have to rely a lot on the machine and its data. So if we can see that the person's AHI, say 45.4, and ODI 46.5 are more or less in tandem with each other, we can be sure that the report is valid and the patient has been properly hooked onto the machine throughout the night, right? So we know that this is a more or less valid report at this point. We then start looking at the total number of desaturations. Okay, so we can see that the entire night, or whatever time the person was hooked onto the device, total number of desaturations were 382. So this is actually quite much. Now we have to know that if the number of desaturations is more than 100 for the night, we need to be concerned. Then we go dig in more deeper and we see that, okay, or the number of desaturations are there, but what do we mean by the number of desaturations? We can see here, just give me a moment. Yeah, we can see here that desaturation data is 3%. So when the oxygen level drops by 3% against one respiratory event, we mark it as a desaturation. So there were 382 times the oxygen level has dropped by 3%. So okay, but now a person's oxygen was 97, it has dropped to 94, so what? Now we need to look at what was the lowest oxygen desaturation. Okay, we can see it is 49%, which is huge. It's a huge drop, and it actually puts the patient at a direct risk of some of the complications of obstructive sleep apnea, for example, cerebrovascular accidents, for example, acute myocardial infarction, and a lot of other stuff. So this person needs immediate management. Also, we need to look at a very important data as saturation less than 90%. So we can see that 45% of the times the person's oxygen level was less than 90%, which again gives more validity to whatever we are thinking in our minds by this time looking at the report. Okay. Now, okay, so the person was having obstructive sleep apnea, he was having lots of desaturations, most of the time it was less. At one point maybe it has dropped to 49%. What do we need to look at next? We need to look next at the graph called hypnogram. Okay, so what does this signify? This signifies that the spread of the events. We can see here that this is the pulse oximeter, this is the oxygen saturation, and this is the airflow sensors, like there are hypopneas, mostly desaturations, snoring, the person was snoring for the entire night. There were some flow limitations which are basically synonymous to upper airway resistance syndrome in level 1 device. Okay, so there were no central like chain strokes respiration is absent in this patient. So, and we can see the spread and the depth of the desaturation event. The entire night the person was grossly desaturating, right? A very high or severe risk patient who has come to you, unfortunately. You can see that in this area, this particular area, the desaturations were not there. What does it signify? Most probably the person got awake at that point of time. Maybe he went to the washroom or something like that. So this is how we find out that, okay, this is the person having obstructive sleep apnea, right? So this is one of the reports. Let's go to another one, okay? Now, I think we have covered the basics, so I'll be skipping a bit faster for the next reports of the level 3 devices. This particular patient, just let's look at here that the AHI is 68, the duration is 747 minutes of recording, 729 minutes of evaluation, so valid report. AHI is 68, which is even higher than the earlier one. Lowest desaturation 63%, ODI is more or less similar, 67.8, 66.1. Number of desaturations 469. Okay, so this person is actually even more severe obstructive sleep apnea. In fact, this report is not correct. I mean, not exactly correct. Why is that? Because if you look downwards, we will see desaturations set as 4%. This was the earlier AASM criteria, like in the 2000s maybe. So when it only detected 469 events because it detected the oxygen drop at 4% instead of 3%. So the moment you just change you make one click in the software and you reset it to 3%, most likely this 469 events will go into 569 or 570 or maybe 600, more than 600 events. So that gives you an impression that this is even serious case of obstructive sleep apnea, right? So this is something which is very important. We need to check at every report that we are getting. Okay, so this much for this particular report. Now let's look at another report. Okay. I thought since it's a workshop, you would rather understand things, so I have not made any PPTs. I hope you will excuse me for that. Okay, so in this particular report, we are seeing that the result is 37, like AHI is 37, but the oxygen desaturation index is 47.2, right? So maybe at some point of time in the night, the nasal cannula got a bit loose, and that kind of explains the difference between the oxygen desaturation and the AHI. But again, it does not invalidate the report because the total duration is more than 8 hours. We are getting very little differentiation between the AHI and the ODI, right? And the oxygen desaturation is set as 3%. All the other reports are more or less good, okay? So if we come to the next part, now this particular report, this is interesting. We can see that the AHI is 14 events per hour has been recorded by the help of nasal cannula, but oxygen desaturation index is 23.2. Significant number of desaturations are there, 148. Okay, desaturation has set at 3%. So why is this important? Because by definition, result of 14 AHI per hour classifies as mild obstructive sleep apnea, which does not warrant treatment. But on the other hand, the ODI falls in the moderate level, right? And the number of desaturations also are a bit on the moderate side. So probably the question comes whether to treat or not to treat this patient, and if we rely only on AHI, we will probably not treat the patient and thereby risk the patient for future negative outcomes. But on the other hand, if we have a closer look at the report, then probably we'll try treating the patient or maybe repeat the study again, right? So this is how you have to understand it. Now let's look at a normal study. Like this study was done and the patient came up with no problems, right? The result was 2, okay? These are all real patients, huh? These are all actually very real patients, all of them. So now the point is, this level 3 device can rule in obstructive sleep apnea. It can never rule out obstructive sleep apnea. So if the person's report has come as negative, like we do not say that the person does not have OSA. Why? I'll come to it in a moment. But in this particular thing, but we can have some idea that whether it is truly negative or it is falsely negative. How can we have that idea? We can see that the result, this AHI is 2. We can see the ODI is also very less. We can see the number of desaturations very less. So all these 3 are corroborating with each other. Duration, study duration, and duration of recording is very, like evaluation is very appropriate. Now we go a bit downwards. We can see in this graph, okay, we can see that there are no gaps in between. The person was more or less like the cannula and the recordings were there. It did not get loose. And most importantly, we also look at this snoring events. Okay, the snoring events for this person was 1378 times. So basically, this was a benign snorer. Of course, a person who was put on a level 3 device for testing was because the doctor had suspected OSA. Why did he suspect? The person may have been obese. We can see at the BMI here the person may have been having a history of snoring. So the snoring is there, a significant amount of snoring is there, which validates that the person was actually sleeping the entire night. But still, the person was sleeping, the cannula and the oximeter were in place properly, and they came with less result, less number of AHI, and less number of ODI as well. So you don't need to harass the patient for level 1 study, and you can say that okay, so we can proceed for other treatments. But at the same time, let's look at this other report, which again will show you a normal AHI, almost like result is 6, very, very mild, up to 5 is normal, it has come 6. What are we missing here? This very important point of the duration. Duration of 7 hours and 4 minutes of recording time, evaluation time only 2 hours or 6 minutes. That means the cannula or whatever got dislodged for majority of the period, so the report immediately becomes invalid. This particular report, we will not look into anything else after that. We will just have to do a repeat study, right? So this is what is important to evaluate. Now let's look at this particular report. Again, this is a normal study. I'm making sense, right? Or am I going a bit fast? So this is again a normal study. In this patient, we have duration of 10 hours or 40 minutes, evaluation time more than 9 hours appropriate. We are looking at the HI of 1, 1.1, 1.9, right? Number of desaturations, 20. Desaturation index 3%, everything in tandem, okay? Everything is fine, the person is negative. Now, the question comes, do we repeat this study or not? The point is, look at the snoring events, only 118, okay? The person was, again, we have to know that the person has been referred because there was a high probability of OSA, but it came out like this with very less number of snoring events. Probably the person had not slept at all the entire night, and that is what has happened. In this particular patient, the study was repeated after 3 days, and I'll show you the differences. This is the name of the person, and the date is on the date is on 2nd of September, a very recent study actually. Let's look at this particular study. Okay, that the same patient, 3 days later on 5th of September, the study was done. Now see the HI, okay, it has come to 30. Look at the snoring events, it has gone to 1094, desaturations 296, ODI 29.5, AHI 30.4. The same patient in a gap of 2 days showed severe OSA when the study was reported, just because whoever was doing that found out or bothered to look at the number of snoring events, right? So this is how you have to more or less look or interpret a study. It is way more than just looking at the AHI and giving a CPAP, right? So with this we conclude the level 3 device and scoring. Now let's get to the more interesting part of the level 1 device. So now we know that OSA can more or less be covered by level 3. Now there are various other devices, various conditions. For example, OSA can be comorbid with a person having a history of CVA, having a history of COPD, having a history of some other psychological issues. So how do we deal with that? Or the person we may suspect the person to be having some other primary sleep disorders. For example, we can be suspecting of having periodic limb movement disorder, we can suspect chronic insomnia, things like that, okay? So what do? We then send the person for a level 1 sleep study, which has to be mandatorily done in the lab. I would like to mention here that only level 1 is the gold standard, level 2 is not the gold standard, because patient monitoring is of paramount importance. You put multiple leads on the patient, leave him for the night, he will just roll here and there, all the leads will become loose, you will get a very not right report, right? So it has to be supervised continuously. The technician has to be awake all night, he has to monitor on the computer what is going on. If any lead has fallen out, you have to put the lead properly, and you have to see that how the data is, we are getting the data appropriately. So now we'll show the hooking up procedure. So in level 1 device, there are a few things you have to understand. On top of the cardiopulmonary issue, we also have to look at the neurological parameters in the level 1 study. What are the neurological parameters that we need to look at? We need to look at number 1, the EEG. Now when we talk of EEG, traditionally in a neurology setting, it is a 32 lead or 64 lead EEG, right? Based upon the 1020 classification system. Now we don't put 32 leads on the patient set for the entire night simply because it is very cumbersome, it will interfere with the person sleeping. We need at least 6 lead positions, like the lead positions, yes. Just put in. He is trying to measure the what we call as the 1020 EEG placement system. So basically let him do it, we will talk in the meantime. So there are the 6 positions that you need to mandatorily put a lead on are number 1, the F3 and F4, which is in the frontal lobe, which looks at the frontal lobe, C3 and C4, which looks at the central lobe, and O1 and O2, which looks at the occipital lobe. So these 6 leads have to be mandatorily placed. On top of that, you need reference point, usually M1 and M2, or the mastoid process leads are the reference points that are used. So M1 and M2 are the reference points for these leads, and there's a grounding lead which is put on the Nasian. Okay, so these 6 plus 2 8 and 1 9 leads if present, only then it becomes a level 1 PSG. There are various devices available which have 1 or 2 leads for the EEG, and they say that we are doing level 1 at home. This is nonsense. The only thing that has to be said a level 1 is if you have all these minimum leads. Now we can upgrade it. For example, we are looking at a patient whom we are suspecting to be having a nocturnal seizure disorder, or whom we are suspecting of having a parasomnia. In those cases, we need to have more leads put on the temporal lobe, on the parietal lobe as well, maybe more leads on the frontal and central lobes, so that we have almost 32 channel EEG or at least 16 channel EEG to find out how the brain is reacting through the entire night. So we look at these EEG parameters. We also look at the EOG parameters, like EOG is something which is put on just outside the outer canthus of both eyes, 1 millimeter to outwards and 1 millimeter downwards on the right side, 1 millimeter outwards and upwards on the left side. So this EOG, what does it do? It basically looks at the eye movement. Why is it important? Because when the person is sleeping, we have our various sleep stages. That is out of scope of today's discussion because I think it will be way long. So just to make matters in a nutshell, with the help of EOG, we can find out if the person is having a REM sleep or the person is dreaming. Okay, and why do we need a chin EMG? There is something called chin EMG which is put on the patient's chin. There are 2 electrodes, one in the 1 centimeter upwards in the midpoint of the jawline of the lower part of this chin, and another one 2 centimeters below and to the right or left of the jawline. Okay, so these 2 electrodes help find out the chin EMG. So why do we need the chin EMG? We need the chin EMG to look at the resting muscle tone. We need the EEG for finding out whether the person is awake or the person is falling asleep. We need the EOG to find out if the person is having a REM sleep, and we need the chin EMG to find out if the person is having a REM sleep or if the person is actually in a wakeful state. Okay, if the person is awake, everything will, the EEG will and the EOG will look same, both in REM stage and in wake stage. Only difference is chin EMG tone will be much lower in the REM sleep. Okay, so this is how we find out the sleep stages using the EEG, the EOG, and the chin EMG. Of course, we have the nasal system. We have 2 different kind of nasal devices here. One is the nasal cannula, which measures the pressure flow difference in while the person is breathing or not. There is something called nasal thermistor or oronasal thermistor, which measures the temperature change of the air that is flowing in from the nose as well as from the mouth. So the nasal thermistor is more the nasal thermistor. Can someone help? Dhimanji, you can start using the putting the nasal and chest. Let him do the EEG. Both of you can hook it up together so that it's faster. We have lost a lot of time today. Okay, so like the nasal thermistor detects mostly apneas. Nasal cannula detects both hypopneas and apneas. But again, you can see in the graph that sometimes this is the nasal cannula. You can see. Okay. So there are finer technicalities, like for example, you see that the person's nasal thermistor graph is very normal, whereas the nasal cannula, this blue word graph is flat. That basically does not mean that the blue wire is not working. That simply means that the patient is breathing from the mouth, and since the thermistor can pick up signals from the mouth as well or airflow, it is detecting a full normal respiration. Okay. So this is the respiratory system. It also has 2 belts, plethysmographic belts, which reads the stretching of the belt during the inspiration and expiration. One belt is present at the thorax or chest, one at the abdomen. Okay. So there are very technicalities exactly where you put the belt. I will not bore you with that. So there are 2 belts, one for chest and one for abdomen. There are 2 cannula to measure the hypopnea and apnea. And we also have the full EEG, EOG and EMG systems. We also have ECG leads, which is, in addition to the level 3 device that I was talking about, we put 4 leads, one for grounding and, and like 3 leads to detect the like EG1 and 2. Okay, and we also have to put PLM leads, or that is EMG leads on the tibialis anterior muscle. Where do we put it? We put it basically, we have to palpate the tibialis anterior from its source till it becomes a tendon. You have to find out the midpoint, and you have to put like the 2 leads, each 2 centimeter above and the other 2 centimeter below that particular midpoint. Okay, that will give you the tibialis anterior movement or limb movement to find out if the person is having associated periodic limb movement disorder. It has to be put on both the limbs, not any one limb, because oftentimes you see that a person can have periodic limb movement only on one limb, not on the other limb. So there is data loss if one limb is missed. Okay, and to top it up, in certain systems or certain centers, we also have an infrared camera capable of doing a synchronized infrared videography, which actually looks at what the person is doing while the person's EEG or EOG or EMG or whatever things are happening. So we do all the hookup, we monitor the patient throughout the entire night, we let the person sleep properly. When the person wakes up, they are discharged. So how does the report look like? So let's look very quickly at the different types of reports. Yes, yes, sir, please. Sorry? No. See, number one, polysomnography is a nocturnal test. It's not a daytime test. So in daytime, there is absolutely no question of polysomnography. Number one. Number two, when we are doing the polysomnography, that means we are trying to look at the patient's sleep. We are hooking up the patient and we are seeing how the patient is falling asleep. Okay. Sometimes it happens that the person is not sleeping, or the person finding it very difficult to sleep with all those wires and everything. So that is often called the first night effect. So if again the total amount of data that we get is less than 4 hours of sleep of the patient, then we discard the study, we repeat the study. Okay. If we get more than 4 hours of valid data, then only we go ahead with scoring the study, number one. Number two point is that a lot of the times the patients as well as many doctors question with the doctor, how can a patient or a person sleep with all those wires attached to his body? Okay, it's a very valid question. The simple answer is there is something called habituation fixed in our brains, which makes us, there's something called the sensory gating at the thalamus. In our brain, we know we have thalamus. There are various neuronal circuits which are cut or sensory gated at the thalamic level, which does not let various sensations reach our brains unnecessarily. For example, we are all sitting here. Ideally, our brain should keep sensing where our body is touching the chair, or where our shirts or pants or saris are touching our bodies, and the fan or whatever, all the sensory inputs. We have lots of sensory overload at every point of time. Fortunately, our brain has the capacity of something called thalamic filter, which cuts off all those sensations. Okay, so when all those things are put on a person, of course the sensation is there, but only for a few minutes, hardly 10 minutes. After that, sensory getting kicks in, all those things we do not sense anymore. To put it simply, when you enter a room, you will sometimes, smell a fragrance, or hear the fan is like moving. After a few minutes time, you will forget about the fan or the smell, you will get used to it. When you put a perfume on your body, you can smell it for the very first few minutes. After that, you don't smell it anymore. Whereas you go somewhere, your friend will tell, okay, boss, your perfume is very nice. So this is the mechanism which tells us that the person can sleep properly with all those things attached. Okay. No, that is what I was explaining till this time, sir. No. See, believe me, if you do 10 patients, 9 patients will sleep normally in spite of all those things, even a normal patient, because তাদের সেন্সারি গেটিং হয়, তাদের ব্রেন অবধি সেই সিগন্যালগুলো পৌঁছয় না। শুরুতে কিছুক্ষণ থাকে, তারপরে ব্রেন সেটাকে অ্যাডাপ্ট করে নিয়ে ফেলে, তারা সেটা আলাদা করে এই সে এত সময় লেগে আছে ভুলে যায়, তারা লাগে না সেটা। বাট কিছু পেশেন্ট থাকে অফকোর্স যারা ঘুমোতে পারে না, তাদের জন্য আমরা কখনো কখনো কিছু স্লিপিং পিল ইউজ করতে পারি। ফর এক্সাম্পল, ক্লোনাজেপাম ইজ দি মোস্ট ওয়াইডলি ইউজ স্লিপিং পিল at a dose of 0.5 to 1 milligram. Clonazepam usually does not interfere with the sleep architecture for one single day in a very large extent. এবার যদি একজন লোক ক্লোনাজেপাম 1 বছর ধরে খাচ্ছে, তার স্লিপ আর্কিটেকচার আলাদা হবে। এক রাতের জন্য দিলে it will not make much harm. Okay, and also we have to remember that if the person is having obstructive sleep apnea, you can see the person here that he is almost sleepy, right? When all these wires are being attached, his eyes are getting like drooping and dozing. It's bright daylight. It's like, but so you imagine at the night time, when the person is trying to fall asleep, believe me, sir, I'll show you real reports. Within 30 seconds to 1 minute, people are falling asleep. I'll show you the EEG graphs as well to prove my point. Okay? Yes. Yes. Sir, this is a very hot topic of debate at this point, primarily in the US, because it is driven by insurance companies. USA te amra je test ta amader lab we charge around 12 to 15,000 rupees for one night of the test. In USA they charge 1 to 1.5 lakhs of rupees. Everybody cannot afford that, so those who have insurance, they do it. Ebar insurance company ra ei guideline gulote dhoka shuru koreche. They start saying that no, level 1 you don't need, you can do level 3 because it is cheaper for the insurance companies. Similarly, ekhon tader boktobyo hocche test korare dorkar nei, you give a CPAP trial and see how things are going on. Okay, so it's a matter of debate. I personally believe it is not a very right approach in majority of the cases, because even in OSA patient আমি আপনাকে দেখালাম যে level 3 device টেস্টের রিপোর্টে কত ভ্যারিয়েশন থাকতে পারে, কত কিছু হতে পারে. So there are multiple things that we need to look at. It is not that okay, the person is snoring, you give a CPAP. No, that is not the right approach. But of course in resource poor settings যেখানে আমাদের কাছে অপশনস নেই, তাহলে কি আমরা ট্রিটমেন্টই করব না পেশেন্টটার? অফ কোর্স করব. Then we can give a trial যে ঠিক আছে আপনি CPAP লাগিয়ে দেখুন. Never sell the CPAP to the patient, always give it on rent, so that he come back to you and understand that okay, এটা লাভ হচ্ছে কি হচ্ছে না. You can try with different masks, different machines. We'll have a look at that after some time. Okay, so this is how you can formulate it in your mind. Okay, so now if we come into how a level 1 report looks at.
Okay, sir, I will just like to intervene. Actually, both the things that were discussed was if the patient has a high probability of OSA, you can, and no comorbidities, then you can do a level 3 study that we have showed earlier. That is much simpler to do, and the patient is also very compliant. You can have your report, if you can assess the points that were described by sir, and then by assessing the points, if you think that the report is worthy and the report is authentic, then you can proceed with the treatment. But if you have the comorbidities like the COPD, or you have cardiac morbidities, or you have a history of stroke and all, in these conditions, ideally level 1 study is indicated, because we need to see much more parameters than what it is in level 3. So in these cases, yes, Kushbu, do you want to add something?
Also, there is an entity known as paradoxical insomnia, wherein patient perceives that he is not sleeping. Patients and most of the female patients have this perception that they are not sleeping, but the bed partner would say, yes, she is sleeping, but yeah, with slightest of the disturbance, patients do get up. So in those scenarios also, especially in such females who are less symptomatic for OSA, who are not having excessive daytime sleepiness, this test is ideal. Moreover, you get more and more of information. Likewise, the way you have asked same queries I also had, unless and until we had done 1 whole year of sleep. But then you get to explore many more things in your EEGs also, like REM behavior disorders and so many things which are quite common in OSA, COPD and other conditions. So nothing can replace level 1.
Yeah, I absolutely agree, 200%. Now, regarding this paradoxical insomnia, it's a very favorite topic of mine. I'm digressing a little bit from this. Just remember that, when the patient is saying that I'm not sleeping at all, and the bed partner is saying the patient is sleeping, what is exactly happening? There is loss of mesograde amnesia. When we sleep, when we wake up in the morning, we do not remember when the door was opened, or who the alarm was, or somebody has come into the room, because our body realizes all those things in the brain it comes, but sensory getting happens, you don't get to remember all those things. Like there is something called mesograde amnesia which wipes out the entire memory. Like you can think of it like a computer. When the person is sleeping the entire night, all these things, these events, both inside the body, like the urge for micturition, the whatever is happening in the tummy, as well as external, like light, sound and all these things, they come and enter the brain, they are stored in the night. In the morning before waking up, it's just wiped clean. So you don't remember anything. That is called mesograde amnesia. In this particular subset of patients having paradoxical insomnia, they do not have this wiping clean of the memory of the night. So they can remember. They will say that, okay, the bed partner will say that the patient was sleeping. The patient will say, but I remember that you went to the washroom at 3 a.m., somebody came at 1:30 a.m. So they will remember correctly, and that is correct. Because sleep is not a passive process, it's a very active process where all of the sensory things are coming into our brain and mind, right? It's a fascinating subject if we choose to look beyond obstructive sleep apnea. Okay, so let's come back to the original thing. Hello, please show this computer on the screen. Okay, so we'll very quickly look into how level 1 reports are there, because Dr. Sarkar has already showed very important things in his talk. So I'll just quickly recap a few things. We have to look at the lights off clock time, lights on clock time. That is, this is the period in which the data was recorded. Okay. Total recording time 483.2 minutes. Total time in bed 483.2 minutes. So, you know, the person was on the bed the entire night and the recording was done. Now sleep period time, that is, once the data you get from this particular level of study, you classify it as it's a wake stage, it's a N1 stage or light sleep, N2 stage or light sleep, N3 stage or deep sleep, or REM stage, and you also score or point out that this is apnea, this is hypopnea, and this is central apnea. You also score this is leg movement, this is not leg movement, this is oxygen desaturation. You make all these scorings sitting for 2 hours with the computer, and after that when you generate the report, it looks something like this that I'm showing here. Okay, it will give you the entire evaluation. It will tell you how much time the person has actually slept. You can see 469.5 minutes compared to the time he spent in bed. So we come to the very important point of sleep efficiency, which is more than 95% for this particular patient. Ideal sleep efficiency is above 85%. Anything above 85% is good and acceptable. Okay. Now this is sleep onset. How much time does the person take to fall asleep? This is 12.5 minutes. So the normal is between 8 to 15 minutes. If a person is going to bed and falling off asleep in less than 1 minute, this is highly abnormal, needs evaluation. If the person is going on bed and not sleeping for 35 minutes, 40 minutes, 1 hour, again that is abnormal, that needs evaluation. Okay. So this is ideal. So then we look into the wake after sleep onset. So one thing is that the person is taking a lot of time to fall asleep. The other data is that once the sleep has come, then how much time period the person has spent in an awake stage. That is called wake after sleep onset, which is in this particular patient 9.7 minutes, which is obvious because he has a sleep efficiency of more than 95%, right? So this is REM latency, like after falling asleep, how much faster REM sleep came. This is 11 minutes. This is not very good for this particular patient, because ideally for the first REM sleep comes after like 60 to 90 minutes of the sleep onset. So this is something which we need to keep in mind while evaluating the rest of the report. Now then we look at the sleep staging. Now we had already staged the sleep, like light sleep or deep sleep or REM sleep. We can see that N1 is 0.8%, which is normal, which is less, around 1 to 2% is normal. N2 62.6%, again this is normal, more than 50 to 70% is normal. N3 31.9% is slightly on the higher side, usually 25% approx we get for N3 stages. 4.8% or REM sleep, this is very less. Like the REM sleep has to be at least around 20 to 25%. So we can see that this particular sleep architecture, patient sleep architecture is not very appropriate because the person has very less amount of REM sleep. And why is that happening? One of the explanations is that since the person, I'll come to that, has just a second. This person's REM sleep is not happening because this person was on certain psychiatric drugs. So that explains why this thing was happening. Otherwise, this person's report is more or less normal. You can see that AHI is only 3.6%, on which only 0.1% central apnea, 0.4 obstructive apnea, 0.5 apnea. I think if we do the sleep test of all the persons sitting in this room, we will get higher figures than this figure particularly. Okay, so we also look at the arousal and awakening index, how many times per hour the person's brain had awakened for at least 4 seconds. When we consider something called microarousal, then in the graph, the awakening has to last for at least 4 seconds. And if it is more than 15 seconds, then we call it as arousal. So this is the difference between microarousal and arousal. So combining both micro and arousal, the person's the index was 50.6 times. We also look at the limb movement index, total number of leg movements, periodic limb movement sequence. This is something out of scope of today's discussion, but there are certain disorders called PLMD, in which patients, there are certain specific kind of movement on the lower limbs, on the toes of the patients, which includes an extension of the big toe and fanning out of the other smaller toe. This is a very specific movement. A person just, like moving his legs like this and this does not consider as PLMD. PLMD is a very specific type of movement. Okay. So that index we see here, if that is less than 15, this is normal. And oxygen desaturation we look at the minimum desaturation here. We look at the graph, how this has been distributed. We also look at the cardiac data, the highest heart rate during sleep, highest heart rate during recording. We look at the average heart rate, we look at the lowest heart rate and the highest heart rate, because we have the ECG as well and the plethysmography and a few other cardiac things for this level 1 device. This is how we look at a normal hypnogram. Okay. So this is just something which I add. This is just to give an evidence that okay, this is the person who was sleeping, this is the name of the person, this is how the graph look like. You can see this wire got loose, F4 wire was not working properly, but sometimes since we have backup wires, we do not choose to wake up the patient, correct the wire if only one wire is loose. But if it would have been 3 or 4 wires loose, we would have woken up the patient and again reset the wires, right? This is, you can see the flow and the cannula. These are the thoracic and abdominal belts. These are the EMG for chin, these are the EMG for leg, these are the ECG graph. This is the SpO2 oxygen saturation. This is the plethysmography, and this is the pulse rate. You can see the pulse rate is quite higher. This person has actually some psychiatric disorder, so that caused this particular event. Okay, so this is how it looks like. I'll just show you a few things. This is stage 2 or N2, because you can see here as the K complex. This is a K complex, which denotes a stage 2. Okay. There's also something called sleep spindles. I'll try to show if it is there. These are all K complexes. You can see K complex here and there. Okay, this is REM sleep. You can see this is the eye movement that I was talking about. You can see this is a slow eye movement, this is a fast eye movement, a rapid eye movement. The opposite movement of the eyes, this denotes REM sleep along with low chin tone. Okay.
Okay, sir. Now I think we should focus on the hooking.
Yes.
And
so
then we will see a pathological report.
Yes, of course. Sure. So we can see here that this person has been hooked up properly. Okay. So we can see that this is Somnath, to dekhaben please.
So okay, focus the camera there,
yeah,
so that we can point out the channels which we have put on that.
Yes, we can see whatever is visible on the screen is this is the grounding channel. These two are F3, like the left side of the brain is odd number, right side of the brain is the even number. So F3 is the left one, F4 is the right one. Okay, you can see here some little bit white thing. You can see this is the C3 and that is the C4. Okay, and on the back side there are occipital leads which are put. You can turn the patient's head a little bit. You can see the M1 here. This is the M1 or the mastoid reference point electrode. They are the same thing opposite side M2. Okay, they are the right mastoid process. Okay, we can also see these two nasal things that I was talking about. This is the blue wire is the nasal cannula which measures the change in air pressure of the whatever air is flowing out. Okay, this white wire we can see one part in the nose, one part in the mouth. It is called a nasal thermistor, oronasal thermistor. It detects the change in temperature of the air that is flowing out. So technically when the air is flowing outside, when we are breathing out the air, that has to be warm than the air that we are breathing in, because it has passed through the human respiratory tract. Okay, so these two things are detected. This is the EOG or electrooculogram. You can see that these are put the way I mentioned, just outside the outer cancer of the eyes. You can see one is put up, one is put down, so that we get that opponent movement of the eye movement in the graph I showed you just now. This is the chin EMG, this is the one EMG, this is the other one. The difference of the potential difference between these 2 points produces the graph that we are showing. And this is okay, we can see here this is the snore sensor. This is put on somewhere where the vocal cord is most prominent. Ideally, you have to ask the patient to say ah or something, and you palpate which one is vibrating most. You put the cannula there. Okay, so this is the snore sensor. Compare that to level 3 device which had the inbuilt snore sensor in the nasal cannula itself. So it's a bit different. Okay, now please focus the camera a bit downwards. Yes, an excellent job has been done by Somnath here. Arektu niche, please. Yes. You can see the belt ঠিক করে দিন সোমনাথদা একটু বেল্ট অ্যাবডোমেন বেল্টটা ঠিক করে দিন yes না ওরকম না স্ট্রেট আসতে হবে প্যারালাল just yes ideally the belt has to be put at the position of maximum movement of the patient's abdomen. Usually it is somewhere around the navel, and the chest belt you can see just below the nipple line we put the chest belt. Okay, So there are two belts, and this is something called the body position sensor. This detects the person whether he is lying supine or on one side, left or right or prone. This is the body position sensor. Okay. Now let's camera try to niche korun. Let's look at the legs. Oh, sorry. Let's wait. Let's look at the oxygen. This you can say pulse oximeter. This measures the patient's oxygen levels, saturations or desaturations. It measures the pulse rate. It measures the plethysmography as well. Okay, and we get 3-4 other channels as derived data from this particular device. Okay, arektu niche korun please. Okay, shall I repeat it? আচ্ছা আবার বলবো?
Okay, sir, I will make it simple. Actually, we have here, what we have here is, sorry to, I will just take 2 minutes.
Please.
Actually, what we have here is, we have some EEG channels here. So, here is the frontal leads, here is the central leads, and here is the occipital leads. Then we have something called the electrooculogram, where both leads are on either side of the eye. Then what we have for muscles, for chin movement, we have 3 leads here for chin movements. Then we have 2 types of cannula which are put on the nose. One is the nasal cannula and one is the thermistor to look after those apnea, hypopnea part. Here we have something near the voice box. This is for capturing the snoring. Okay, so that will capture the snoring. It is put near the voice box. Then after that, we have a thoracic belt and we have an abdominal belt. Both belts are used for movements of the thorax and abdomen. So, to look after the movement.
Just a moment, Abhishek, just give me one moment here. Like the thorax and abdomen both measures the respiration, like the chest and abdomen movement. But why 2 belts are needed in a level 1 study? Because often we get something called paradoxical respiration in obstructive sleep apnea. That is, when we breathe normally, our chest and abdomen both expand. When we breathe out, both contracted. But in paradoxical respiration, we will see that the chest is going out and abdomen is going in at the same time. Okay, and that is represented graphically also. So to find out if there is paradoxical respiration, which in turn has an important role in the treatment of the patient, okay, and also in PAP compliance. So we use 2 different belts to find out the respiratory effort. Abhishek, please continue.
So after that, we have something in the fingertip. It is the pulse oximeter to measure the oxygen saturation. And then we have few leads in the legs to look after the leg movements. So we put leads in both the legs so that we can monitor both the legs. Okay, so these are the things which are being put in a level 1 polysomnography, and this is it.
Okay, and just one more line to add. You can see in the leg movements, like we add leads on both the legs because sometimes periodic movements can be present on one leg and not the other. So in order to prevent data loss, we put it on both the limbs. That is one. But on the EEG, say we are seeing on like C3 and C4, F3 and F4. So we are putting leads on both the hemisphere. The second set of one set is enough, okay, but the other one is kept as a backup so that we, in case one lead moves out, we can still get data from the other lead. Same is for the chin EMG, okay, there are one lead is extra, okay. So is there any question? Anything somebody wants me to repeat? Yes, sir, please. Yes, right. Yes, sir. The body. No, sir. No device has 2 pulse oximeters. Correct, sir. Very true. Actually, this is where experience comes in. When you start scoring and recording data, you will often see that in certain patients, even without any signs suggestive of obstructive events in the airflow or in the chest abdomen, the patient will show desaturations. So this, what you said, explains the fact that there is maybe some compromise in that particular blood flow or that pulse of that particular patient, but unfortunately, in all the devices present globally, there is no provision of having 2 pulse oximeters anywhere. So that is where you have to think along with while scoring the report that okay, if there is an airflow restriction or there is a chest or abdomen movement restriction, there is a desaturation, you classify it as a respiratory event. If none of these things are present, only desaturation is present, you can see in the video the patient is turning like this or lying like this with one hand downside. So that you ignore that, you discard that. You don't need to record that or score that particular thing. Has to put the phone in a switch off or airplane mode, including if there is an attendant, his phone also. So that environment has to be created, otherwise there will be loss in data or disrupted signals like that. But again, in the software also there are certain filters that we use to focus on the particular frequency waves that we want to look at. So there are various. So for example, in the EEG that we use, the filter range is between 0.3 Hertz to 30 Hertz for the EEG signals. Okay. For the EMG signals, we use the filter between 10 Hertz to 100 Hertz. Okay. And there is also something called the QRS filters, which reduces the ECG interference of that particular thing. Another thing is. No, ECG leads. Yes, ECG leads they have put, I think. This part, I think it's inside the shirt, so it's not visible, but usually we put 3 ECG leads and 1 grounding lead. 2 channel EEG, sir. 2 channel, yes. The level 1 device has a 2 channel EEG. We look at the leads 1 and 2. Any more questions? Sir, capnography incorporation is of course possible, but we routinely do not use it in Indian setup because of the increased cost. Okay, but that ideally for PD. Yes. You can also have some esophageal, manometry for certain, to find out, confirm about certain, sleep events, particularly in the pediatric population. But mostly that is used for research purposes, for routine purposes. Putting capnograph is a bit expensive and not, worthwhile for most cases. Capnograph is important for pediatric OSA, and it is very important for obesity-related hypoventilation. Like for those patients who are having, we are suspecting obesity-related hypoventilation, capnography is required, but we have a proxy sensor for that. What do we do is that we use a polysomnography, we ask for a arterial blood gas analysis to find out the daytime, CO2 levels. And based upon that, we diagnose like obesity-related hypoventilation in the patient.
So
yeah,
the
Dr. Khusbe will say
oronasal
something.
cannula that is being applied over here, it can be replaced with the cannula which has ETCO2 monitoring. That cost. So it would require one more software which is low flow. Yes, one hardware and a software is required. Yes. Yeah. Yes. Mostly as a pulmonologist, we screen OHS and OSA and COPD so routinely that we are most of the time using these things. So it is like a surrogate marker. It is a surrogate marker, but then you can also go for a transcutaneous CO2, which increases the level 1 polysomnography price by 5,000 rupees. It's non-reusable. With these, we can also monitor the nocturnal hypoventilation.
Okay, so I think the level 3 devices can be given individually to see and feel with their hands if possible. Somnatha, আপনি একটুখানি ওই ডিভাইস দুটো মানে অডিয়েন্সকে দিন, people should see how they are. Transcutaneous, sir.
that is actually a technical part.
Okay.
So,
Okay, sir.
better
So,
to not go into that.
and you can see how the recording, live recording is being done. You can see that this is the EEG waves, this is the EOG waves, and this is the chin EMG. You can see how much high the chin EMG is, and there is this opposing eye movement which is like the REM sleep, but this is the wake sleep because the chin EMG is high, okay? And these are the leg movements. There are no movements at this point, so it's like kind of flat. This is an artifact, okay? This swell thing is an artifact. This is plethysmograph. These are the EEG, ECG channels. This is the snore sensor. He is not snoring at this point, so we cannot see anything. These are the airflow. These are the thorax and abdomen flow. This is the effort sum. Now, when there is paradoxical respiration that I was talking about, this effort sum will be like flat line. SpO2 is showing, you can see the oxygen levels here, the body position. This is, I think, not showing correctly because the person is supposed to be lying supine. Since he's sitting upwards, the gravitational field is not working properly, I guess. It will not show anything unless the person lies down on the bed. And pulse rate is, you can see here. Okay, so this is how we look at the recording, and once we get the entire night's data, we look at here the 30 seconds epoch. This is called an epoch. This is a 30-second epoch. This is 30 seconds. So we have the entire night's data. The EEG scoring we do on 30-second epochs, and when we are scoring the leg movements or the respiratory movements, we do it on 2 minutes epochs. Okay, so that is how traditionally it is done. So I think let's just look at one. I'll just take 2 minutes. Just to take 2 minutes.
One report.
Yes, one
see.
report which has a severe obstructive sleep apnea with REM preponderance. I'll show. Please show this monitor. No, not that one. Move it. Please focus this computer. Yes, sir. Thank you. Yes, it's come. Okay, so we can look at this data. Let's just skip the first page. Okay, let's look at this particular recording time again. This person, you can see, has slept for almost 95% of the time. Sleep efficiency is very good. The REM again is low. N3 or deep sleep is more or less adequate. N2 stage is adequate. N1 is adequate. Okay. The person has a sleep onset of 1.5 minutes, like less than 2 minutes the person was asleep with all those wires in a completely foreign setup. Okay, so this is what actually happens in real OSA patients. We can see, yes, we can see the respiratory data here, that this is the index, okay, the number of events per hour of total sleep time. So whatever time the patient was actually sleeping, we are analyzing that part of the data only, we are not analyzing the entire time the person is in bed. So we can see that the obstructive apneic events, pure obstructive events were 24.1 times per hour, hypopneic events were 20.5 times per hour, mixed apneic events 0.9 times per hour, central apneic events were 3.4 times per hour, and cumulative, all those things was 48.9 times per hour, and there is something called respiratory event related arousal, that was 1.3 times per hour, total was 50.2 times per hour. So this gives the person's RDI or respiratory disturbance index, and this gives the person's AHI or apnea hypopnea index. This is 48.9. So this is way above the 30 cutoff for severe obstructive sleep apnea. So the person was having a severe obstructive sleep apnea. Another interesting point to note here, if you look a bit downwards here, you can see the REM index and the non-REM index. This basically means that the number of respiratory events that has happened during that night's sleep, how many of them were during the REM sleep, how many of them were during the non-REM sleep. So you can see that in the REM sleep, the obstructive apneic events were all more than double that of the during the non-REM sleep. Okay, but on the other hand, the hypopneic events were, in fact, non-REM sleep had a higher predisposition. Okay, so apparently, if you look at the AHI only, there is no difference. But in certain cases, we see that in REM there is more obstructive apnea. Sometimes we see that in REM. I'll just show it a bit later. Let's go a bit downward. Okay. So let's just look at the respiratory data. Oxygen saturation data. So the total oxygen saturation has been 310, which is huge. Look at the oxygen saturation mean SpO2 levels while the person was awake, while the person was having in non-REM sleep, and in REM sleep. You can see that when the person was in non-REM sleep, the mean oxygen saturation was 92%. Compare that to 78% of the while the person was in REM sleep. So why is that happening? Because the REM was having more obstructive events. The muscle tone is already low in the REM sleep. There were more deeper events and greater desaturations, and that caused greater drops in the oxygen saturation while the person was in REM sleep. Okay, this is something which Dr. Sarkar was talking about earlier. Then we look at the graph. Okay, about the distribution. You can see very classically. This is the graph which shows this is the light sleep, this is the deep sleep, this is the REM sleep. There is red bars, and this is the oxygen saturation level. You can see that here and here there are lots of desaturations while the person was in REM sleep. There was some desaturation in the non-REM sleep as well, but greatest desaturations were in the REM sleep. Okay, so that is graphically also very much visible. So this is the hypnogram, which gives an overview or overall idea about what the person's night sleep or nocturnal sleep was about. We can see here the sleep stages that the person has spent. Yes, please, sir. Sir, awakening and arousal, there is, that way not different, because then I'll have to just give me one moment. I'll show you. Let's look at this graph. Okay. This is how an average 30 seconds epoch, you can see this is 30-second epoch. This is the EEG wave, this is the EOG wave, right? So now and there are the timer markers like 5 seconds, 10 seconds, 15 seconds, 20 seconds, 25 seconds, and 30 seconds. Now if there is arousal, how do we know arousal? Look at this area here. You can see there is something called beta waves that is going on, which has a frequency of 13 hertz or more. So these beta waves, if present, or there is another variation called alpha waves, okay, which has from 8 to 13 hertz of frequency. If we have either alpha or beta waves in the EEG for at least 4 seconds to 15 seconds, we call it as microarousal. If we have this particular graph for more than 15 seconds, like for more than half of the page, then we call it as arousal. And now, of course, if it continues for pages and pages, then becomes an awakening, and that is also visible here in the video, that the person is awakened. But usually microarousals, you will not see any video change. In arousals, you may see a change, you may not see a change, okay? You may sometimes see that the person is, changing his body posture. So that is, underlying there is arousal usually. Okay, so this is how you get. So, yeah, Abhishek, you want to add something?
I am just telling that
we are very much short on time. Just give me 2 more pages, okay, and then I'll leave. Okay, so let's just show you a better in the, yeah. Okay, let's just look here. You can see that this is the respiratory movement. You can see that the T flow and the cannula flow. You can see it is almost flat, right? Now, to classify as obstructive sleep apnea or obstructive apnea, you have to have at least more than 95% cessation of airflow. So that means either there is no airflow or up to 10% is permissible. And you can see the flattening of the lines here. Actually, it should be up to this much. It got like this. There is followed by arousal there. Arousal is though not mandatory to score as apnea. You can see the oxygen is going down. From 93 onwards, going down. The earlier apneic events, it has gone down till 88. Okay, this was at 23:04 p.m. It is a 30 seconds epoch. The person was lying supine on his bed. Okay, so this is how we look at. So this is how we look at obstructive apnea. Abhishek, just give me one moment if I can find anything which has a central apnea here. Yeah, just let's look at this graph. Like we can see that this is this obstructive apnea event. Look at the oxygen desaturation. It has gone to 56, and from here, from 91, it has gone to 63 after an obstructive event. And this is the REM sleep that is going on. We can see that this is where the study is currently. He is on his side at this point. And these are all arousals followed by so much desaturation. Because what happens basically, airflow stops, oxygen levels keep dropping down. At one point, the receptors, they trigger and you just awake, and this is the awakening, and then you again drift back to sleep. The same cycle keeps on repeating. So a lot more can be talked about, but unfortunately we have very little time. So with this, I would like to end my session and invite Dr. Khushbu to take the next session. Thank you so much. Thank you for your patience. Okay, just yeah.
Okay, so now we will quickly brush through the prescription of PAP devices, which is one of the most important part for us clinicians to provide the therapy to the patient, to get the relief to the patient, much needed relief. So that part will be covered by Dr. Khushbu Saxena.
Little unfair from Dr. Abhishek that he has made you all well versed with the diagnosis, but the actual story starts now. So the treatment part would be little shortened, but I'll try to cover up it as much as possible.
Sound.
Maybe in the next Pulmocon, maybe we will focus only on the treatment part.
थोड़ा सा sound. It's coming.
Yeah, I'm Dr. Khushbu Saxena. Thank you so much, Dr. Abhishek, for having me here. So I'll be talking about the basic modes of PAP therapy and how to prescribe a PAP therapy. So let us make it a little bit more interactive. We had a 50-year-old male patient with a BMI of 34 kilogram per meter square. He has given us history of smoking index of 350, and he would take alcohol on weekends, which is around 60 to 90 ml. He presented with the excessive daytime sleepiness with the ESS score of 24. The attendants which were there along with the patient, they would tell that he will be having food and in midway he would fall off asleep. Or maybe he is just sitting and he would fall off asleep. Basically all the 10 questions were positive with the highest possible probability of sleeping. Spirometry was done, which was suggestive of obstructive pattern. So for this patient, we received this patient to rule out narcolepsy, and as a part of a study which we were doing for our research purposes, wherein we were diagnosing, we were trying to equivalent split day and split night titration as better as nighttime titration for patients like this. So in the diagnostic part, AHI was 95 events per hour. So may I have a few inputs? What would you like to do next? Anybody? So this is the diagnostic thing. Would you want to prescribe PAP, APAP, CPAP, BiPAP, AVAPs? Anyone? Whatsoever you are doing in your routine practices. Maybe there's somebody who's sitting in the last. No? Maybe somebody senior who could answer. Okay. So before going to the answer, let us discuss why do we need to treat OSA? Going into pathophysiology, there are basic 3 mechanisms which will interact and cause huge issues, which are intermittent hypoxia, sleep fragmentation, large intrathoracic pressure swings. All these things create a lot of metabolic changes and physiological changes, which eventually leads to metabolic syndrome. So what are the treatment options that we have for OSA? We all know PAP is one thing. Oral appliances are there. Surgical options are there. There are certain adjuncts like weight loss, positional therapy, nasal expiratory PAP, non-invasive oral therapy. Recently, this drug also has been shown that it can reduce OSA. So now what would you want to prescribe for this patient again? You have these options. Or if you want to have ask certain details, then I can answer. So should I prescribe autopap and go ahead? Maybe Abhishek want to say something, but then, yes, please.
It will be unfair if I say the answer, but I think most of the people, most of us in this setting should go for a CPAP. Auto CPAP, I rather say, because the AHI is high, patient is suffering from obstructive sleep apnea as advised. So the most common choice would be auto CPAP.
Yeah, that's right. So as per the ASM recent guidelines, treatment for adult obstructive sleep apnea with positive airway pressure, this is the flow chart, if you could read it. First of all, the basic requirement is to diagnose OSA objectively. You need to have a short proof that patient is having obstructive sleep apnea, because most of the patient would come with snoring, which could be habitual snoring, or which could be excessive daytime sleepiness. So there are n number of reasons for having excessive daytime sleepiness. So first of all, to objectify the disease, we have to go for the diagnostic test, not straight away starting treatment just on the basis of those questionnaires or a probability test. So if the patient is having excessive daytime sleepiness or reduced sleep related quality of life or hypertension, then you have to discuss treatment options available for OSA. But again, do the patient and clinician agree that PAP is the preferred choice of treatment? If yes, then does patient is having significant comorbidities? Of course, you have to evaluate for comorbidities that has been taken already in quite detail in the previous lectures. Again, if the patient is ready for the PAP therapy, then consider initiating PAP in lab strategy if the patient is having comorbidities. If the patient is not having comorbidities, you can straight away go for initiating PAP using auto PAP at home or titration or in lab titration, depending on the availability of resources. Then you have to treat the patient with CPAP, APAP over the time, and you have to follow up the patient again. You have to provide the behavioral therapies. You have to educate the patient on interventions with routine initiation of PAP therapy. Consider using behavioral and troubleshooting interventions with PAP therapy. Consider follow-up using telemonitoring system. So all these PAP devices now they are provided with SD card or a SIM. So as a clinician, you can sit down at home and you can monitor the patient with the therapy that they are using. Also the compliance. So he is showing the SD card which is available. You also have to use nasal interfaces over, nasal interfaces are usually preferred over oronasal or the full face mask. And use of heated humidification is shown to improve the compliance as compared to the dried air, which you. So whenever the patient is going under the titration guidelines, so whenever the patient is planned for titration, usually the titration is always started with CPAP. I'm just discussing about the adult guidelines. Patient is started with 4 centimeter of water and the rule of 2, 3, 5 is followed. Over the 5 minutes, you have to monitor for more than 2 obstructive apneas, more than 3 hypoapneas, more than 5 RERAs, or more than equal to 3 minutes of loud snoring or unambiguous sounds. If the events are resolved, then again you have to wait for 15 to 30 minutes to see whether the events have actually abolished. If there are further events, you have to go up. So how long can you go up? You can actually go up to the limit of 20, but practically speaking, beyond 15 to 16 centimeter of pressure, patient keeps complaining of aerophagia, so you have to shift down to the next level, that is BiPAP therapy. Again, if BiPAP titration is to be started, same rule is followed, 2, 3, 5, and here you have 2 pressures, IPAP and EPAP. So IPAP and EPAP both to be increased if you are having an obstructive event, And if there is only any event like RERA or hypoapnea, you only have to increase IPAP by more than 1 centimeter. So minimum difference between IPAP and EPAP is to be maintained at 4 centimeter of water, and anything, if you have to keep on increasing, the maximum difference should be 10 centimeter of water. The highest limit for IPAP is 30 centimeter of water, and the highest again for EPAP would be 20 centimeter of water. While you are titrating, you have to see whether you have titrated patient well. So the optimal titration, which is considered the best out of all, is defined as RDI of less than 5 per hour for a period of at least 15 minutes at the selected pressure within the manufacturer's acceptable limit, leak limit, which is usually provided by the mask providers. Just to mention, 26 liter per minute is by Reisman mask, and around, again, it depends on nasal, oronasal, or oral mask that you are using. The limit goes up to 60, not beyond 60. The saturation should be more than 90% at the selected pressure, and supine REM at the selected pressure is not continually interrupted by spontaneous arousals or awakenings. So, if not optimal, then what is good titration? The RDI should be less than 10 or less than 50%. If the baseline RDI is less than 15, or a period, again with the same rule, for a period of at least 15 minutes, and 15 minutes of supine REM should be achieved. Again, the acceptable leak limit is defined. When we talk about, when we come down to a slightly lower level, the adequate titration is defined as RDI less than 10 per hour, or by, but the RDI is reduced by, RDI is not less than 10 per hour, but it is definitely reduced by less than 75% of initial baseline value, and criteria for optimal or good titration is met, but you did not get a sample for REM supine sleep for 15 minutes on the selected pressure. And any of the above three, if they are not available, then it is an inadequate titration. You have to plan for the second titration. Sorry, can I ask you again that same question? What would you want to do now? So describing and prescribing PAP therapy is not just prescribing auto CPAP, BiPAP, and all that. You have to evaluate patient's upper airway. If there is any congestion, you have to fix it. For the going, if at all I would want to go back to the same slide. Patient is definitely having obstruction. He has smoking index of 350. Possibility of COPD is definitely there. Along with that, having asthma, I cannot rule it out, right? So we have to evaluate the patient for all these conditions. Having nasal congestion make patient less compliant towards the nasal therapy, nasal mask and CPAP therapy. So correction of congestion should be there. Any surgical condition, any treatable condition should be always dealt with. And prescribing PAP, while prescribing PAP, you have to make sure that the machine whichever machine you are titrating the patient should receive the similar machine, or a machine which delivers the almost equivalent pressures, not more or less than that. Because there is quite difference when patients go back to the different machines. There are n number of Chinese or other machines available which are usually not able to deliver the same pressures as we has prescribed. Prescribing PAP also involves the mask prescription. So while doing a manual titration, you have to take care of the mask. Usually the preferred is nasal, but if the pressures are little higher, there is a loss of PEEP through nasal mask. So oronasal masks are preferred. Now we did a manual titration for this patient, and patient achieved optimal titration at 21/17 centimeter of water. After stabilizing this patient, we again had a lot of time to evaluate and explore various levels of PAP therapies. So I will just share my experience. So there are various levels, various modes of PAP like manual CPAP, auto CPAP, manual BiPAP, auto BiPAP, AVAPs, AVAPs AE, and ASV. So we started doing that. First of all, we did the manual CPAP. Patient was not getting settled with even with the 17 centimeter of water. Then we shifted the patient to auto CPAP. Herein we saw multiple events arising, patient not having settled down. While having this report, there is one more parameter that you can see is PTT variance. So PTT variance is a kind of surrogate marker for negative intrathoracic pressure. So while doing this, we observed that while putting a patient on CPAP, auto CPAP therapy, there is a huge variation in this PTT variance. Why is it? Because whenever you are putting a patient on auto CPAP or auto BiPAP therapy, first of all, it will try to abolish the events. Once the events are abolished, again the pressures tend to come down because of the algorithm which is designed, and again patient will start having events. So there will be continuous swaying of intrathoracic pressure, and it would reflect into sympathetic overactivity in turn. That is why auto CPAP is absolutely no for a cardiac failure patient. We are not supposed to prescribe auto CPAP for any cardiac failure patients. Then going back to the manual BiPAP, as you can see at 21 and 7, patient is sleeping well. There are absolutely no events. The flow is beautiful. There is no desaturation, and the variation is also not huge. We again changed to auto BiPAP, and then we saw again events started arising. So we went on to AVAPs AE. Looking at the patient, we thought the patient might be having hypoventilation and other things as well. So we tried AVAPs AE again, but the pressures were fluctuating, and patient again had repeated events in this mode only. So again patient was put on the same level, and patient again had the beautiful rebound REM sleep, and patient could sleep well. That is it. I think this much time only we have to, but then there is definitely way beyond this for the diagnosis and treatment for OSA and other sleep related disorders, and a lot more in sleep. Thank you so much for me having here. This is the sleep lab that we have recently settled up in my hospital. Thank you. Any questions would be more. So central, we always, whenever we are titrating any patient, be it central, be it normal OSA, usual OSA, obstructive sleep apnea, we always start titrating with CPAP. But if you talk about central sleep apnea, Kind-Stokes breathing, it is preferred to prescribe BiPAP with the ST mode, with a fixed backup rate, and while you titrate the patient, you get the I/E ratio that patient is utilizing best for maintaining saturation. Similar prescription should be given to the patient for treating central sleep apnea or missed. Pardon, sir? Anybody else would want to answer? Yeah.
Okay, sir, actually when we are talking about central sleep apnea, we have to find out that whether we are treating it in the context of heart failure or not in the context of heart failure. For example, when we are talking about treating central sleep apnea using these PAP devices, usually we try to do that with adaptive servo ventilation, which basically has only two things. One is finding out the EPAP. Like for example, we have to find out at what EPAP all the obstructive events are, or whatever events are kind of done, and we have to find out the backup rate. Okay, the backup rate is something basically when we count the respiratory rate of the person while the person is awake, we subtract -2 usually conventionally, and you get the backup rate. So we fix the backup rate and we fix the minimum EPAP of that particular device. Then what happens is that the machine varies the pressure support. That is the difference between the inspiratory pressure and the expiratory pressure. Yes. The machine does it automatically. It will just automatically vary the pressure support, thereby causing a continuous flow of respiration. And when during chain strokes there is a pause of respiration, it will have the backup rate ready. Okay, that is it done. But there was something called the SARV-HF trial, a very large trial done in the West, and it came with a very astonishingly negative result. It said that those patients who had heart failure with reduced ejection fraction, when they were put on these kind of devices, their mortality was much higher, okay, compared to other, like say manual CPAP or something. So if we get a heart failure patient who is having a reduced ejection fraction, we should think twice before putting in this kind of automatic devices or adaptive sample ventilation devices. As Dr. Khushbu nicely said, that manual CPAP, if needed, is the best thing. Now regarding the acetazolamide question, it is basically, it depends upon what kind of patient you are getting in the real life. Of course, a patient may need both a device and an acetazolamide. In certain cases of central apnea, for example, if there is altitude-related central apnea, then only acetazolamide will be good enough. So it depends upon what kind of central apnea we are treating with. Unlike obstructive sleep apnea, which is only two types, adult and pediatric, in central apnea there are multiple types and multiple pathophysiologies and multiple, it's a different world altogether. So based upon that, we have to find out or fit the correct treatment, or rather the most optimal treatment to that particular patient. Thank you so much.
Hello. Yeah, I had one question. Excuse me, ma'am.
Yes, please.
With the advent of the nasal masks, predominantly because oronasal mask is always going to have a lot of claustrophobia and associated issues. But most of the patients who are OSA, they have a tendency to mouth breathe. So in case, what is your experience with using of chin straps along with a nasal mask or a nasal pillow? Like, what is your experience with that?
So practically, when you ask patient, when a patient is already having a severe OSA and excessive daytime sleepiness, so most of the patient best compliance is seen with the patients who are having these kind of symptoms. So because they experience entire world, different world after using CPAP. So usually they are very good, they are very fine with the mask that you are prescribing, that you had decided during the titration. And that's what I am saying. So in my practice, I'll tell you what I am doing. We never had a sleep lab there in the hospital. So this is what, third level sleep study, you get it done. You just document OSA and then you put a patient on CPAP. I'm not left with any other option, but I had to make best out of it. So I would ask them to rent a machine, firstly CPAP. I'll give the full range of pressure, 5 to 16, and then I'll ask them to come back after 10 days. Yeah, 10 days usually. So in 10 days, I would be able to observe how the patient is compliant and what are the T95, the 95th percentile of value, and also I'll see for the mask fittings, the leak pattern and everything I'll see, and then if I'll find the pressures are, beyond 15, I would give them a trial of 10 days again with an auto BiPAP. So from that value, I will narrow down my pressure setting so that variation of intrathoracic pressures comes down, and this is how I was managing. Simultaneously, when you talk about mask, severe OSA patient, they very well tolerate this mask. But then other than buying mask, there is no other option.
I would like to add again.
Yeah, please, sir.
Sir, let's just give me one moment, please. Just finish this question. So basically, when we are thinking of, there's a doubt between the nasal mask or the oronasal mask, a very simple thing in real world will help. Just ask the patient's bed partner that does the person sleep with his mouth open. in most cases, bed partners give a very accurate information that if the person is mouth breather or not. If there is a history of mouth breathing, then definitely go for oronasal mask. That is one. Number two is that if you see that the mask, the pressure that is requirement is above 15 centimeter of water, always go for an oronasal mask. That is number two. And number three is that if you see that you have given us CPAP or autopap for trial, and the patient has come back, and you see the patient saying, okay, doctor, some response we get, but I am not able to use it for a long time. You see the pressure that is going up is up around, like the 95 percentile pressure is somewhere around 12 or 13 maybe. There is a leakage is very high in the range of 30, 40 centimeters. So, and the person not able to use it beyond 3-4 hours or 2-3 hours max, right? So that again indicates that there is a high mask leakage. So basically, the current CPAP or auto CPAP devices, they use something called force oscillation technology. Yeah. So it basically it picks up the amount of oscillation that is happening, of vibration that is happening in the tissues while the air is being pushed in. Now, when there is a leakage or there is a high leakage, they do not push in air. Okay, so what is happening is that if you change the mask from a nasal mask to a oronasal mask in this particular subgroup of patient, you will see that the maximum pressure, 95 percentile pressure, has moved in the range of 16, 17, 18. Usage time has increased to 4 hours, 6 hours, 7 hours like that, and the leakage has come down to say around 20, 25 like that. Okay, so these are certain issues where you can think of changing the type of mask. But I agree again with Dr. Khushbu very much that never ever give the patient to directly purchase the autopap. Okay, you are a clinician, you are a doctor, your job is to find out the right treatment for that patient rather than, the other things. So of course, once you give them patient on rental, you can take rental for 2 months, 3 months, 6 months also and keep managing, the best thing for the patient, because it's a very real challenge, because no single person will sleep similarly in the 2 consecutive nights. The person may have taken a couple of pegs of alcohol one night. The person may have some other stress regarding job. They have to wake up early on some night. There may be more REM percentage on some night. There will be less REM percentage on some night. So it's variable. Okay, it's very difficult to decide how the pressure has to be based on one night observation. So this is how I think we can think. Sir, your question, please.
So, while having your diagnostic study, you can have, but having this titration device, you cannot have. This is what I am telling, this is what we had observed, because they keep, the algorithm is set in a way that it increases the pressure, stabilizes, once stabilized, again it, tries to minimize the pressure requirement again. So it keeps on fluctuating. So narrower the range that you are prescribing, lesser is the probability of patient is having this intrathoracic pressure swings. Dr. Abhishek, if you want to add anything.
Okay, so any other questions?
We haven't covered any part of central sleep apnea, so don't treat obstructive sleep apnea like, don't treat central sleep apnea like obstructive sleep apnea. There is a whole world beyond this to treat OSA.
I think another important message that we need to take back home is that sometimes when we detect a person with obstructive sleep apnea, we prescribe a PAP device. They come back and say that, doctor, I'm not feeling comfortable. In the device report, you see that there is increased central apnea. Okay, so that is called treatment emergent central apnea. So this is a type of central apnea which, in most cases they are treated by correctly optimizing the pressure, usually by reducing the pressure, because if you put in too much pressure and remove the CO2 too much, then central apnea kicks in. And though these are lesser these days with the automatic devices who have this FOT technology, but earlier with manual devices and with the earlier models of the automatic devices, the central apnea emergence was higher. But usually you have to just optimize and probably reduce the pressure that is being given for that particular patient. And you also have to look for any other, other clinical indicators for a central sleep apnea. So that is, I think, one part which is very...
One more point I would want to add is that don't consider that the level 1 study is too expensive, shouldn't be done. You can just manage with the level 3 study, because when you are prescribing a manual device, it is cheaper as compared to the automatic device. So it definitely covers up the price for auto versus manual. Am I correct?
Yes. I think, yeah, you are correct. And actually it depends, like we have to think of something as beyond the AHI and the CPAP. You know, there's a whole world of sleep medicine, beautiful world. We can just dig in, we can read. There are lots of research available. It's a very scientific subject where everything is evidence-based and recommendations are there. So once we start reading up, we will, you know, try to see a lot of newer things that is happening in the same report that we are seeing. If it, and we'll be able to demarcate what to do and when to do and where to do, you know, that way. So thank you so much. I think Dr. Abhishek would like to close the workshop. And there are some devices for demo. You can see there are. Yes, sir.
Yes.
Yes,
So
sir.
mask has to be cleared only with the soap and water. Ideally, the mask should be changed every 6 months.
Yes, sir. Sir, like. No, sir. Ideally,
One more thing, sorry sir, sorry
No,
to interrupt.
just
One more thing with the mask, I would want to tell you, please do check the mask whether it is vented or non-vented, because the non-vented masks are usually connected with the ICU setups and IV, and sometimes, not sometimes, very often I have seen that patient carries the same mask and tells us that this machine isn't working. So, and then mask is also very expensive, you cannot do anything, so sometimes I have to make holes in the mask to make that adaptable to the patient.
So, but regarding mask care, I would say that once the patient purchases the device, there are few things we have to tell them, because often those who are selling, they forget to do so. Every machine comes with a once in a year, you know, free servicing, which is very important, just like the servicing of our cars. Second thing is there is something called an air filter, which needs to be replaced every 3 to 4 months, depending upon how much pollution level is there in the place where the person is living in. Suppose there is a highly polluted areas, they will need more frequent changing. Lesser polluted regions, they will need less frequent changing on the air filter. Very cheap, 300-400 rupees is the price, and it can be done by himself or herself. And regarding the mask, they have to be, you know, cleaned with like Savlon or sanitizers. You have to take a cotton, wet it with Savlon or Dettol or whatever is there. You have to clean both inside and outside, wipe them thoroughly, then, you know, dry it in the sunlight, ideally. And then you can use it, and ideally it should be cleaned once a week at least to make the mask, you know, keep fresh and functional. And regarding what Dr. Khushbu said, not every 6 months, I had seen that a mask of good companies like these that are on display here, they last around up to 2 years in our country. Those who have taken good care of the mask, it can last a bit longer also. And however, if there is the reason for changing a mask is if it breaks, or if there is a leakage, or if there is, if you know, sometimes some people with continued treatment or CPAP use, patients lose weight, oftentimes it is seen, then the mask becomes loose, or the belts become, they keep stretching and they become loose. So those are the things which have to be taken care of when the patient comes for a follow-up visit. For example, just saying that the machine is not working, or AHI has gone up, or I am not able to use it, we have to start thinking from the very basics till the medical level. So that is how the optimum treatment can be given. Sir, humidifiers are, yes sir, humidifiers are mostly inbuilt. In current machines, whatever they come, they have mostly inbuilt humidifiers, or you can extend that also. So it's not a problem anymore. And plus in Calcutta and West Bengal, humidity is not that much of an issue like in the northern part of the country or in the western part of the country. But again, some patients, they do feel more comfortable with using a humidifier.
So the take-home message is definitely nothing can replace level 1 study. We should all promote level 1 studies.
Thank you so much. Thank you for your time and patience. And there are the devices on display. You can just have a look if you want. Thank you.
Okay. Thank you, sir. I would like to thank Dr. Saurabh Das and Dr. Khushbu Saxena for your diligent deliberation of the lectures and lucid presentation to our audience, the various facets of sleep medicine and the various facets of polysomnography. I think we had dwelled into a much detail than we had expected. So I hope we need more time and more dedication for sleep medicine. So next time we have to do it in a much longer format. That will be, that way we can cover all the aspects. So thank you all of you for attending the Pulmocon. And as far as the last session this is, so we would like to close on a good note. Thank you everyone. We hope to see you next year again. Thank you.